How can you help of the youth of the other day? There's a question for Abdul. I have one question. Yes, the question is and
Listing of IBC to the RA quality index, then it means the patient is fluid, hypovolemia. Even these are all the indirect indicators of hypovolemia and shock, which are very important clinically. But
Hazard is whenever any leaf fall, slide. Second test is the Pethick's test or oxygen flush test. Here, you pressurize the system and activate the oxygen flush and observe the bag. If the inner tube is intact, you will observe deflation of the bag, because when you activate the oxygen flush, there is high flow of oxygen coming through the narrow inner tube, which will cause a Venturi effect, creating a negative pressure in the outer tubing. Fresh gas flow requires modifications of ISTPs, in which a reserve bag is added.
And 1 mole of a gas contains 6.023 into 10 raised to 23 mole.
हेलो, देख लो ना। हेलो हेलो हेलो।
Check. Hello. Hello. Check. Hello.
Hello.
Hello, Dr. Sadiq. Hello, Dr. Sadiq. Dr. Sadiq. May I know who is Vivo 1933?
Dr. Ankit.
Dr. Ankit.
Yeah.
Thank you.
Good morning, everyone. Welcome in whole day. In whole day, session 1 is start. Okay.
Yes. आनंद शुरू हो गई है.
Hello. I invite as a chairperson Dr. Kharad Mohammed Bhatt and Dr. Sadiq Mohammed. First participant is Dr. Ankit Rao.
Greetings to all. Myself Dr. Ankit Rao. Guiding Medical College, Europe. Today's my topic is to evaluate the efficacy of lidocaine patch 5% as pre-treatment technique before spinal needle insertion for pain reduction and patient satisfaction in intra-umbilical surgery. Introduction. Spinal needle used for regional anesthesia produce various levels of pain and anxiety to patients. Such type of pain and anxiety can lead to abnormal motor and psychological responses and may cause patients' refusal for regional anesthesia. There are many modalities to alleviate superficial pain during lumbar puncture. Infiltration of local anesthetics at the lumbar puncture site may make normally palpable anatomical landmark disappear. Lidocaine patch contain 5% lignocaine, size 10 into 14 centimeter. Each patch contains in aqueous phase. The amount of lignocaine systematically observed from patch is directly related to both the duration and surface area of application. Previous studies have shown that pain reduction start within 30 minutes of application of patch and last for about 12 hours. The main purpose of my study is to evaluate the efficacy of 5% pain patch for pre-procedural application to achieve decrease in pain during lumbar puncture. Aims and objectives. The aim is to observe the efficacy of 5% pain patch, medicated patch for pain reduction and patient satisfaction. Primary objective, the pain assessment during lumbar puncture in the form of NRF2, patient satisfaction, and future preference of spinal anesthesia. Secondary objective, adverse effect associated with medicated patch, if any. Material method. The approval from ethical committee of institution was taken after obtaining written and informed consent from patient. A prospective observation study was conducted on 100% of either sex aged 18 to 16 years undergoing elective infrabrachial surgery in Nehru Hospital, BRD Medical College, Gorakhpur. Consent. Total 120 patients we can take it. Out of 120, 20 patients excluded. Exclusion criteria including patient refusal, spinal deformity, spine surgery, local anesthetic allergy, local site infection. Out of 100%, we divided into two groups, Group C and Group L. Group C contained 50% and Group L contained 50%. Group C received a gauze piece covered with adhesive tape, and Group L 50% received 5% pain medicated patch 5 centimeter into 7 centimeter containing 175 milligram of pain. After giving, we observed the result after 30 minutes. Spinal anesthesia was given after 30 minutes. Spinal anesthesia was given, observation, NRS, and patient satisfaction score. I have shown in this scale, numerical rating scale, 0, 1, 2, 3 is mild, 4 to 5, 6 moderate, and 7, 8, 9 to 10 to severe. The patient satisfaction score, 1 is very satisfied, 2 is satisfied, 3 no comments, 4 not satisfied, 5 very unsatisfied. Lower the patient satisfaction score, higher will be the patient satisfaction. Statistical evaluation. Independent study was used for testing of mean difference between independent groups. Cross table was generated and Chow square test was used for testing of association. P-value less than 0.05 was considered statistically significant. All analysis was done using SPSS software version 24.0. Observation and results. As shown in this figure, comparison of mean value of NRS between study groups, Group L and Group C, and comparison of mean value of PPS between study groups. Conclusion. The mean NRS was significantly lower in Group L as compared to C. The PPS patient satisfaction score was better in Group L as compared to Group C. Almost all patients in Group L had preference over spinal anesthesia in future, whereas Group C, 4 patients denied spinal anesthesia in future. No adverse effect observed in both the studies. Thank you.
Now, second speaker is Dr. Vindu Yadav.
Myself, Dr. Vindu Yadav. My thesis topic is effect of waist hip ratio, uterine size, and body mass index on sensory neural level of spinal anesthesia block and the hemodynamic changes during cesarean section. Introduction. Spinal anesthesia is one of the most preferred anesthetic method during cesarean section since it provides easy and rapid induction, effective sensory and motor block, and has little effect on the fetus. The normal anatomic changes of pregnancy affect neuraxial anesthesia techniques. Obese pregnant patients are anesthetic risk directly related to maternal mortality and morbidity. In addition, the vertebral foraminal veins, which are contiguous with the epidural veins and enlarged and obstruct one of the pathway for anesthetic from the epidural space during administration of epidural anesthesia. The enlarged epidural veins also may displace CSF from the thoracolumbar region of the subarachnoid spaces, as does the greater intra-abdominal pressure of pregnancy. This displacement partly explains the lower dose requirement for spinal anesthesia in pregnant women. There is less space between adjacent lumbar spinous process during pregnancy. These changes may influence the spread of subarachnoid anesthetic solution in supine patient, leading to a higher sensory level in the pregnant patient. A high level of sensory block after spinal anesthesia increases the incidence of hypotension. Another explanation of hypotension after spinal anesthesia is supine hypotensive syndrome. The incidence of hypotension may be greater in pregnant women with larger uterine size and more waist hip ratio than in those with smaller uterine and lower waist hip ratio. Aims and objectives are level of spinal anesthesia block, parameter changes. Material and methods are, these are my inclusion criteria, ASA1 and ASA2. Exclusion criteria are these. Methodology. Preoperatively, all patients will be weighed and their height will be measured. BMI of the patient will be calculated. Demographic information in gestational week of each patient will be recorded. Waist measurement by abdominal circumference will measure from midpoint between the upper part of the iliac bone and the 12th costal rib. Hip circumference measured by highest part of gluteal muscle, uterine size, and uterine size pubis to top of the bone. In the operating room, all patients will be routinely monitored with ECG examination, NIBP, and SpO2 measurement with the patient in a sitting position. The subarachnoid space at the L3, L4 space will be entered with 25 gauge Quincke needle. The end spinal anesthesia was administered with 10 milligram hyperbaric bupivacaine. Following application of block, the level of sensory block will be evaluated 3-minute, 5-minute, and 8-minute intervals with the pinprick test. After 8 minutes, the sensory block will be recorded and the operation will be permitted to start. The measurement of mean arterial pressure, systolic BP, diastolic BP will be performed, recorded at 3 minutes until a sufficient block level of surgery will be reached. Then 5-minute interval after an adequate block level will be achieved. These measurements will be repeated at 12 at delivery, after delivery, and 10-15 after baby out. The collected data will be subjected to statistical analysis to find out the result. This was my sample size was 200 around. These are my result in tabular form. Discussion. In this study, we assess the hemodynamic change and level of sensory block in pregnant women with high BMI, waist hip ratio, and uterine size after spinal anesthesia for cesarean delivery. Our result suggests the incidence of hypotension and tachycardia. Bradycardia was increased with higher BMI, waist hip ratio, and uterine size. Previous studies on BMI, waist hip ratio, and uterine size and hemodynamic changes after spinal anesthesia shows conflicting findings. Some shows incidence of hypotension increased with high BMI by Fernando Susanani discussion. Some shows no any positive correlation between hypotension and high BMI waist to hip ratio. Study was Lopez Hernandez et al. And in our study, we found increased incidence of hypotension in patients with high BMI and high waist hip ratio. Some of the previous higher level of sensory block with high BMI, waist hip ratio, and uterine size. That studies was Gunnison et al. And Ansel M. Lemon studies. So my study showed no any correlation and dose adjustment of anesthetic agent. In our study, we found a positive correlation between high spinal level and waist hip ratio, and the association of high spinal induced bradycardia was higher in patients with high waist hip ratio. Occurrence of bradycardia was seen in 2 out of 87 patients and 5 out of 87 patients with waist hip ratio less than 1, 7 out of 113 patients and 6 out of 113 patients at 3 minutes and 8 minutes after spinal anesthesia. High BMI occurrence of bradycardia was seen in 1 out of 85 patients and 1 out of 85 patients with BMI less than 30, 16 out of 115 patients and 12 out of 115 patients of BMI more than 30 at 8 minutes. Greater uterine size occurrence of bradycardia was seen in 3 out of 91 patients and 4 out of 91 patients with uterine size less than 37, 6 out of 109 patients and 5 out of 109 patients of uterine size more than 37 at 3 minutes and 8 minutes after spinal anesthesia. Conclusion. From the above result, we conclude that there are increased risk of hypotension in pregnant women with high BMI, waist hip ratio, and greater uterine size. There are also more number high sensory neural block height patients among the high BMI, waist hip ratio, and uterine size. Pregnant female also there are greater risk of high sensory neural block induced bradycardia among pregnant female with high BMI, waist hip ratio, and greater uterine size. Thank you.
Now we are more forward. Next is Arunima Patana.
Today I'm going to present a topic on effectiveness of epiglottic devices for error management in pediatric laparoscopic surgery, comparison of ideal origin and social element. Epiglottic error devices have secured their place in error management in adult laparoscopic surgeries, but the evidence is lacking for its use in pediatric laparoscopic surgery. Aim of the study was to compare the effectiveness of epiglottic error devices, origin, ideal, and social in pediatric laparoscopic surgery. The objective was to determine which second generation epiglottic device is better in terms of oropharyngeal leak pressure in pediatric laparoscopic surgery. Elevation of intra-abdominal pressure and tendon inverse position during laparoscopic surgery reduced diaphragmatic expulsion and flip the diaphragm in a circular direction. So epiglottic error devices during laparoscopy have an increased chance of gastroesophageal reflux. Procedure and ideal compared with the endotracheal tube have been found to be comparable in efficacy during the pediatric laparoscopic surgery. But different epiglottic airway devices have not been compared with each other in pediatric laparoscopic surgery. This study was conducted at a tertiary care hospital. It was a single center study at the All India Institute of Medical Sciences, Patna in India. The design was a randomized control trial. The study was conducted from December 2018 to March 2020. The study population included pediatric patients scheduled for laparoscopic single-sided inguinal hernia. After approval of Institutional Ethics Committee and registration with the Clinical Trial Registry of India, we included male patients aged between 6 months to 10 years of age grade 1 and excluded any patients with anticipated difficult airway with a previous abdominal surgery, any comorbidity that would affect the surgical time with time under anesthesia and intrathoracic pressure and abdominal pressure. The performers and associates were not blinded to the study group. We did a block randomization and allocation was conceived with field OPEX envelope method. The sample size was calculated based on a study by Goyle et al., which showed a difference of 13% in the oropharyngeal leak pressure between the IGEL and the Procil LMA group in pediatric patients. So, with a projected difference of about 15% between the two groups, taken for the leak pressure to be significant, and 5% confidence interval in the type 1 error of 0.05 and the power of 80% and taking dropouts into account. We included 30 patients in each group for the study. The primary outcome was to measure the oropharyngeal leak pressure, and the secondary outcomes were to measure the peak pressure before and after pneumoperitoneum, the fiber optic tube, and the insertion attempt. The patients were induced with inhalation induction method with sevoflurane. After that, fentanyl 2 microgram per kg and injection atracurium 0.5 milligram per kg were given intravenously. Any patient who had air leakage following 3 attempts at the placement of epiglottic devices were excluded and they were intubated. Oropharyngeal leak pressure and peak airway pressure were recorded before and after pneumoperitoneum. The anatomical position of the airway was assessed as per the fiber optic glottic view. Apart from all the standard monitoring, peak airway pressure before and after pneumoperitoneum was also measured. Parametric continuous variables were measured using the one-way ANOVA with post-op testing analysis. Non-parametric continuous variables were measured using the crystal wall test. Continuous variables in same group were compared with the pair t-test in the categorical and ordinal data using the chi-square test. 106 patients were assessed for eligibility, out of which 16 patients were excluded because they did not meet the incident criteria. So 90 patients were randomized, 30 allocated to each group. All the patients were studied and analyzed except for in the group 3, that is the ProSil LMA group, in which one patient was excluded from the study because supraglottic acid. As we can see in this demographic data table, we did not find any significant difference in the demographic data between all the 3 groups. Coming to the primary outcome, here we can see that the oropharyngeal leak pressure before pneumoperitoneum and after pneumoperitoneum have been found to be significant different in between the 3 groups. Also, the insertion time have been found to be significantly different. There is a box test in the primary outcome in which we can see that the oropharyngeal leak pressure both before and after creation of the pneumoperitoneum have been found to be higher in the IGEL group. Coming to the intergroup comparison, we have seen that that IGEL, when compared with AMBU or again a ProSil LMA, has a higher OLP both before and after creation of pneumoperitoneum, and the insertion time of ProSil LMA has been found to be higher as compared to both AMBU or again and IGEL. So airway protection and successful supraglottic airway placement and the efficacy of positive pressure ventilation. OLP measured before and after pneumoperitoneum have been found to be statistically significant higher with IGEL than AMBU or again and ProSil LMA. Increase in the OLP after the creation of pneumoperitoneum in all the 3 groups have been found to be statistically significant. All the 3 supraglottic airway devices have been effective, been found to be effective to maintain the seal and the adequate ventilation. But IGEL, however, has been found to be better placed and have a higher peak inspiratory pressure during the laparoscopic surgery. The insertion time of the ProSil LMA was statistically significant and longer as compared to AMBU or again and IGEL, but this is not of any clinical significance. The limitations were that we included only healthy patients with normal airways in our study, and surgical time was less than 1 hour, so we included specific surgery. And the effectiveness of supraglottic airway devices for longer duration laparoscopic surgeries need to be evaluated. And comparison of supraglottic airway devices in laparoscopic surgeries in infants and their use in an intubating device can be taken up as further research perspective. So we conclude that all the 3 supraglottic airway devices can be used in pediatric laparoscopic surgeries, but IGEL may be better suited in conditions where higher ventilatory pressures may be necessary, like in extremes of weight or in pendulum of position. These are all my references. Thank you very much for your patient listening.
My institute,
Sri Hari SS.
Hi, greetings from my institute, Subha Institute of Medical Science. My abstract ID is ABS 1287. My study on feasibility of cervical epidural anesthesia as a sole technique for breast cancer surgeries. As we all know, surgery is the mainstay for the management of the breast cancer, even before or after the radio or chemotherapy. Cervical epidural, it provides a stable cardiorespiratory status and can be used as a sole anesthetic technique in these patients. As we all know, cervical epidural anesthesia is less commonly practiced among the onco anesthesia specialties due to it requires a certain degree of skill and also due to fear of complications. This study is observational and it's a descriptive study. Objectives of this study include to evaluate the feasibility and safety of cervical epidural as a sole anesthetic technique for modified radical mastectomies done for carcinoma breast, and also to determine the incidence of adverse events with the cervical epidural anesthesia. 18 breast cancer patients physical status 1 and 2 who were scheduled for modified radical mastectomy and the comments under cervical epidural anesthesia were included in the study. After the informed written consent in the preoperative period, 18 cervical epidural was secured at C7 to T1, and anesthesia is induced with 15 ml of 0.25% bupropion in titrated doses to achieve the blockade of C3 to T8, which corresponds to the innervation of the breast. All patients were given IV sedation with injection midazolam 1 mg. This shows the cervical epidural placement with the patient in sitting position. Postoperative analgesia is managed with epidural infusion of 0.125% bupropion at 5 ml per hour, and also injection paracetamol intravenous 1 gram IV, 1 gram TID. VAS scores, hemodynamic parameters, episodes of nausea and vomiting, satisfaction scores were monitored for the first 24 hours. Pain threshold was kept at 4 centimeter on VAS scale, and if it is more than 4, then 5 ml of epidural infusion drug bolus was given. The hemodynamic variables, the VAS scores, requirement of rescue analgesics, requirement of rescue drugs for PONV were documented and analyzed. Statistical analysis was done using SPSS software version 3.2. The mean operative time for the modified radical mastectomy was around 100 minutes and plus or minus 24 minutes. Average VAS scores was 2.5 out of 10 in the first 24 hours, and average satisfaction score was 80%. To document the adverse effects include one patient had bradycardia and 2 patients had hypotension after the initial epidural bolus, which were managed accordingly. One patient required conversion to general anesthesia as the patient complained of discomfort in the intraoperative period. None of the patient had nausea or vomiting during the study period. All patients were started on liquid diet 4 hours after the surgery and were mobilized after 24 hours. So, of the study it's an observational and descriptive study in small samples, and it was performed in ASA of physical status 1 and 2 patients. To conclude, cervical epidural anesthesia is a safe alternative in breast cancer surgeries, and cervical epidural anesthesia, it maintains the hemodynamic, provides the both intraoperative and postoperative analgesia, leading to early recovery. And these are my references. Thank you.
Now we are moved forward. Next lecture is Dr. Nidhi Singh.
Good morning, everyone. I am Dr. Nidhi Singh. The topic for my paper presentation is exploring the effect of perioperative blood transfusion on neurological outcome following aneurysmal subarachnoid hemorrhage, a prospective observational study. Anemia is common after aneurysmal subarachnoid hemorrhage and is associated with secondary brain injury and also leads to unfavorable outcomes. Transfusions are frequently given to counter anemia and maintain adequate oxygen delivery, and they also augment the cerebral perfusion. However, lately there has been increased concern about the deleterious effect of blood transfusion as well. This is because of the blood storage effects, decreased production and availability of nitric oxide, defective microcirculation, and all this is thought to lead to increased vasospasm and hence unfavorable outcome. Whether physiological benefits of transfusion for anemia surpasses the risk of transfusion is not known. That is, anemia is associated with poor outcome, but then to counter anemia, if we give transfusion, transfusion is also thought to have some negative effects. So in this study, we hypothesized that transfusion of blood is associated with poor neurological outcomes after aneurysmal subarachnoid hemorrhage. The aim of the study was to evaluate the impact of perioperative blood transfusion on long-term postoperative neurological outcome as assessed by Glasgow Outcome Scale Extended at 3 months. We also studied the short-term neurological outcome assessed by modified Rankin scale at discharge or at 7 days, and secondary outcome also included the effect of blood transfusion on post-operative characteristics like vasospasm, infarction, re-exploration, etc. Coming on to methodology, this was a prospective observational study conducted after institutional ethical committee clearance and written informed consent from each patient. We included all patients of age 18 to 60 years who were scheduled for clipping of aneurysm, and these were the exclusion criteria. The sample size was derived based on a previous study of our institute, that is, effect of perioperative hemoglobin concentration on cerebral oxygen extraction and neurological outcome in aneurysmal subarachnoid hemorrhage. Based on the proportion of poor outcomes found in this study and using likelihood ratio test, a sample size of 164 was derived, which was adjusted after assuming 10% of patients who were lost to follow to 185 patients. Results: a total of 197 patients were assessed for eligibility, of which 12 were excluded for not meeting the inclusion criteria. 185 patients were finally enrolled and analyzed for short-term outcome. 14 patients were lost to follow-up at 3 months, and for the neurological outcome at 3 months, we had 171 patients. This is the baseline table, which compares the demographics as well as also tells the intraoperative characteristics. For the purpose of analysis, the patients were divided into two groups, that is those who received transfusions and those who did not, and the baseline characteristics were comparable in both the groups. Also, the intraoperative characteristics like the total temporary clipping time, the rupture, incidence of rupture, blood loss, etc. were comparable in between the two groups. Coming on to the comparison of post-operative characteristics. If we look at the post-operative complications, the patients who were transfused had more complications, of which vasospasm, infarction, re-exploration, tracheostomy, and length of hospital stay. They achieved statistical significance. Outcome variables. If we look at the short-term outcome, those who were transfused in that group, 42.7% patients had unfavorable outcome as compared to around 26% patients who were not transfused, and this came out to be significant. However, if we look at the long-term outcome, which was the primary outcome of our study, only 27% patients had unfavorable outcome in the transfusion group as compared to 17% in the non-transfusion group. And this was not statistically significant. That is, the blood transfusion does not affect the long-term neurological outcome. Discussion. In this study, we studied the long-term outcome because aneurysmal subarachnoid hemorrhage, as we all know, is a dynamic disease affected by multiple elements, and long-term outcome seems reasonable. Blood transfusion in our study was not found to affect this outcome. This was similar to a study by Bosner et al., who also failed to find an association between transfusion and ICU mortality as well as unfavorable outcome. Another study, which was conducted prospectively, concluded that keeping a hemoglobin concentration of less than 10 led to unfavorable outcomes. So, transfusion to keep hemoglobin around 10, as in our study, seems reasonable. To conclude, when blood transfusion is given judiciously, as per the clinical requirements, the long-term neurological outcome at 3 months is comparable. Blood transfusion is associated with more neurological complications like vasospasm, infarction, increased length of hospital stay, etc. And this explains that it leads to also unfavorable short-term neurological outcome at discharge or at 7 days. These were the references of my study. Thank you.
Now, next is Dr. Isha Chopra.
Hello everyone. The topic of my paper is analysis of the efficacy and safety of regional anesthesia technique in arteriovenous fistula surgeries. According to the closed flame analysis report of 2008, peripheral nerve block is the technique of choice for limb surgeries, but local anesthetic systemic toxicity, it accounts for almost 35% of the medical legal claims against anesthetists. However, ultrasound-guided regional anesthesia has brought a definite decline in the recent claims. The objectives of my study included evaluation of the efficacy and safety of ultrasound-guided brachial plexus block during AV fistula creation in terms of operative conditions, vascular patency, and complication rate, and also to develop and standardize protocols to avoid LAST, that is local anesthetic systemic toxicity. The study was done in tertiary care center. It was a prospective observational study done in a single institute. Same team members were involved over the whole duration of study, so minimal observer bias is expected. From electronic medical records of the patient as well as from the sonocyte readings. This study was done over a duration of 1 year, and a total of 200 cases were enrolled for the study. All the patients, they were divided into 2 groups randomly. One group received ultrasound-guided supraclavicular block, and the other group received local infiltration. Local infiltration at the site of surgical creation of fistula. The quantitative variables were described as mean plus minus standard deviation, and independent sample t-test was used to compare the mean between the 2 groups. A p-value of less than 0.05 was considered significant. The primary outcomes of our study included quality of surgical field as well as the functional patency of the fistula. Regarding the quality of surgical field, because brachial plexus block is a sympathetic block of the arm, it provides excellent vasodilatation, as we can see in the upper picture. Also, it provides very good motor block. So quality of surgical field was very, very good in the block group, whereas local infiltration does not provide any vasodilatation and patient keeps on moving his arm. For the functional patency, all the patients of both the groups, they were assessed immediately after the procedure as well as after the 3 months of surgical fistula creation. The patency immediate and at 3 months in the brachial plexus group was 100%, whereas in local infiltration group, the 3 months patency was 95%. However, the difference was not statistically significant. The secondary outcomes included duplex sonographic parameters. As we can see in the graph, right side of both the graphs, the right side graph depicts the changes in the sonographic parameters after the block. And we can see that cephalic vein diameter as well as the radial artery diameter, they increased significantly after the block. The same was with the brachial artery diameter as well as the radial artery blood flow after the block. The increase was significant. The duration of perioperative analgesia was significantly very high in the block group as compared to the local infiltration group. And in the block group, the need for analgesics perioperatively was minimal. Regarding complications after the brachial plexus block, one of our 100 patients, she developed recurrent laryngeal nerve palsy, which was self-limiting. And 2 patients, they developed seizures, which might be because of their uremia or might be because of local anesthetic toxicity. These patients were managed with GA and the outcome was good. We have developed our own institutional protocol to avoid LAST, which includes weight-based dosing. All the doses of local anesthetics are given according to the weight of the patient, not more than that. Ultrasound is used for each and every block because ultrasound, it allows for accurate placement of needle, thereby increasing precision of the block. Also, it decreases the complication rate, neurological and vascular complications, they are decreased. And because of increased precision, the dose of local anesthetic requirement is also decreased. Use of safer drugs such as ropivacaine, which have better safety profile than and lipid emulsion is always kept handy. There are few studies which suggest that preoperative regional anesthesia block, it may alter the operative strategy of fistula creation. Basically, the diameter of cephalic and basilic veins, they increase significantly, which may increase the rate of native fistula placement. So our future studies, they are intended towards this finding. Thereby, we conclude that brachial plexus block is a very good choice for fistula creation as it has acceptable safety profile. It also provides very good venous dilatation and increases the blood flow of the vessels, which is paramount for the maturation of the fistula. Also, it increases the patency rate, which thereby increases the success of this vascular access procedure. Thank you.
Now we are going more forward. Next speaker is Dr. Anurag Pathye.
Respected jury, learned seniors, and my colleagues, myself Dr. Anurag Padhi will be presenting my paper titled Does the preformed curvature embu aura gain provide any advantage over the non-curved LMA procedure during device insertion? Supraglottic devices can be classified into first and second generation D device. Second generation devices have added safety features, and prototype of second generation device is LMA Procil, which is a wire reinforced airway tube requiring an introducer tool for successful placement. Another second generation supraglottic airway device is embu aura gain, which is resembling the human anatomic airway and hence does not require an introducer tool for its placement. Given the preformed curve, it appears the embu aura gain should be easier and should take lesser time for insertion compared to LMA Procil. But the results from a previous study in adults and children are contradictory. So we aim to compare the insertion characteristics of embu aura gain with LMA Procil in adult patients. Our primary objective is time taken for successful insertion. Our secondary objectives are this. This is an LMA Procil with introducer tool. This is embu aura gain, dorsal and ventral view. This is a randomized comparative study conducted in the Department of Anesthesia, UCMS and GTV Hospital and registered with CTRI. Patient of either sex 18 to 16 years of age, ASA grade 1 and 2, modified malmotility class 1 and 2, adequately fasted for more than 8 hours with BMI less than 30, undergoing elective surgical procedure under GA were included. These are my exclusion criteria. This is the demographic profile comparison. Randomization was done using computer-generated random number tables into two groups. Group AAG, where embu aura gain was used as the aero maintenance device, and Group PLMA, where LMA Procil was used as the aero maintenance device. After a routine thorough PAC, patient was wheeled into OT, monitors attached, and general anesthesia were induced as per the standard institutional protocol. Supraglottic airway device were inserted after adequate muscle relaxation. Proper placement was confirmed by auscultation and end-tidal carbon dioxide waveform. Hemodynamic variables in the form of systolic and diastolic blood pressure, heart rate, end-tidal carbon dioxide and oxygen saturation were noted at various time intervals. Time taken for successful device insertion, that is the time from opening of the mouth and appearance of first square waveform of capnography, ease of the device insertion, graded as 1 no resistance and 4 unable to pass the device. Number of attempts for successful insertion, success rate in the first attempt, results of the gel plug test positive or negative, ease of the gastric drain tube insertion, graded as 1 being easy to pass and 3 being unable to pass were recorded. Use of maneuvers like jaw thrust or requirement of assistant help was also noted. According to a previous study, with the mean time taken for successful insertion as our primary objective, a sample of 20 cases in each group were included. Quantitative parameters were compared using unpaired student t-test and man-Newton U-test. Qualitative parameters are compared using chi-square chart. 2 out of 20 patients in LMA Procil and in one of embu aura gain group, the device insertion failed. So total 37 patients were analyzed. The time taken for successful insertion was comparable with embu aura gain group. The insertion of LMA Procil was significantly easier than embu aura gain. Ease of the drain tube insertion was comparable among the two groups. Total number of attempts for successful device insertion, gel plug test positivity rate, and number and type of maneuvers were comparable among the two groups. Hemodynamic variables including heart rate, systolic and diastolic blood pressure, and tidal carbon dioxide and oxygen saturation were comparable among the two groups. Incidence of intraoperative and postoperative complications were also minimal and comparable. Now coming to discussion, the time taken for successful device insertion has been reported in various studies to range from 13.57 seconds to 33.4 seconds. This difference is due to the definition of time for successful insertion. Some studies reported embu aura gain took significantly longer time than LMA Procil, while others reported shorter insertion times. However, we did not find any significant difference in our study. Due to inadequate ventilation in 2 patients with LMA Procil and 1 patient with embu aura gain, the respective devices were removed and tracheal intubation was done. Similar failure rate has been reported previously. Insertion of LMA Procil was significantly easier compared to emboragen in our study. Various reasons for the same could be a lesser experience with emboragen, a more firm material used to make the device, larger cuff size of the device, and a preformed curve itself. The gliding of the device to the mouth was also not very smooth. The device need to be straightened during insertion, is also reported by Mr. et al. First attempt success rate was higher with LMA Procil. This is attributable to the longer experience with LMA Procil use. Probably as the familiarity and the usage of emboragen increases, this difference could be bridged even further. Similar first attempt success rate has been reported by Joshi et al. In pediatric patients and Singh et al. In adult patients. Sarifuddin et al. Reported first attempt success rate with emboragen 86% patients, while Lopez et al. Reported 100% success rate with emboragen in first attempt. No serious hemodynamic fluctuations were recorded with any of the two devices. The incidence of complications during insertion was also and after removal was also comparable with the two between the groups, and similar studies have also reported complications with these devices. Now we conclude that the time taken for insertion of emboragen is longer than Procil LMA with comparable number of attempts. Therefore, emboragen remains an attractive alternative device for securing the airway in adult patients requiring general anesthesia. As only adult patients with normal airways were included in our study, further studies in patients with difficult airway and different populations are needed to evaluate the performance of the device in such scenarios. These are my references. Thank you.
Now, the next is Dr. Manjulata Shakir.
Good afternoon, respected dignitaries. Today I am presenting a topic on comparison of analgesic efficacy of fentanyl and tramadol in TAB block after percutaneous nephrolectomy, a randomized control study. Introduction. Transversus abdomen spleen block provide analgesia to the anterolateral abdominal wall. This plane has poor vascularity and hence drugs given by this route has prolonged action and not associated with major complications. Pain after percutaneous nephrolectomy mainly occur at the flank area overlying kidney, and patients are unable to breathe comfortably due to this pain. As fentanyl and tramadol were easily available in our setup for control of pain, so we did the study with use of this drug in TAB block to avoid their side effect through intravenous route. Aim of the study was to compare the analgesic efficacy of fentanyl and tramadol in TAB block. Our primary objectives were duration of analgesia and time to first rescue analgesia, and secondary objectives were visual analog scale score and side effects. Now come to the material and method. This randomized prospective double-blind control study was carried out in the Department of Anesthesia, Government Medical College, Datia, from April 2019 to September 2020 after ethics committee approval. Sample size estimated by calculating 5% margin of error and 85% confidence level. So decided to select 90 patients after considering dropouts. Inclusion criteria were 96 patients of age 30 to 70 years, ASA grade 1 and 2 of either sex planned under spinal anesthesia, and exclusion criteria were patient refusal, deranged renal function, coagulopathy, spinal site infection, systemic diseases like CVS, pulmonary, hepatic, CNS, etc. This is the consort diagram. We assessed 90 patients in 3 groups. 30 in each. Group A received 28 ml of 0.25% bupivacaine with 50 mg of fentanyl. Group B received 28 ml of 0 mg of tramadol, and Group C received 28 ml of 0.25% bupivacaine with 2 ml of normal saline. No patient lost to follow up. All patients were shifted to OT and baseline monitors were attached. Patients were educated about VAS before TAB and randomized at computer-generated tables. Spinal anesthesia was given with 25 G Quincke's needle and 0.5% heavy bupivacaine 3.5 ml. After completion of the surgery, TAB block was given by filling tube of technique in triangle of Pettit. Investigating drugs were injected through TAB block, which was prepared by another colleagues outside of the OT. Patient shifted to after monitoring vitals for 20 minutes, and study parameters were recorded by the nurse on duty as instructed to them. Results. Statistical analysis were performed as continuous variables were presented in mean plus minus standard deviation, whereas categorical variation in variable in number. One-way ANOVA test was used to compare the means. Pairwise comparison test was done using post hoc Tuckey test. Duration of analgesia was higher with fentanyl than tramadol and normal saline.
Time to first rescue analgesia was 7 hours, 4.89 hours, and 3.0 hours respectively with fentanyl, tramadol, and also lower with fentanyl in comparison to tramadol and normal saline. This is the table showing patient characteristic, demographic characteristic. Demographic characteristic in respect to age, weight, height, and duration of surgery between the groups are statistically insignificant. And the primary objectives were time to first rescue analgesia. It was higher in group A, 7.01 hours, and group B, 4.89 hours, and group C, 3.01 hours. And duration of analgesia was also higher in group A, 6.89 hours, in group B, 4.01 hours, and group C, 2.98 hours. So the time to first rescue analgesia and duration of analgesia both were significant between the three groups as P was less than 0.05. And this is the VAS score secondary objectives. VAS score was significant at 2 hours between the group A and group C and between the group B and group C. And VAS was significant between group A and group B, but not significant between group B and group C at 4 hours. And was insignificant between the three groups after the 8 hours. This is the line diagram of mean VAS score. Now come to the discussion. With our results, we infer that fentanyl, when added to the TAP block, prolonged the post-operative analgesia, then tramadol in TAP and TAP with normal saline. To our knowledge, not any single study was compared the effect of TAP fentanyl and TAP tramadol in percutaneous nephrolectomy. So this is the sole study to compare these both drugs in TAP block. Now, studies in support to our study were Neeraj Ji et al. Demonstrated that TAP block prolonged the post-operative pain, but they did not added any adjuvant to it. John R. et al. In their study with fentanyl and TAP for elective cesarean section concluded that fentanyl not much improved post-operative analgesia, and Allen Osdelac et al. In their study concluded that fentanyl when added to the TAP block for PCNL provide prolonged post-operative analgesia, and post-operative fentanyl consumption was also lower and less additive analgesia were needed. In our study, there was no case of post-op nausea, vomiting, and sedation. Results were in concordance with the study of Neeraj et al. And Pexo et al. K. Peng et al. In a meta-analysis of 7 articles concluded that USC guided TAP was an effective strategy for analgesia in patient of laparoscopic cholecystectomy. And limitation of our study were as it was a single center study and sole study, and we also did not monitored post-operative hemodynamic vitals. In future, we did multi-center study to compare these easily available and cost-effective drugs, and post-operative hemodynamics should also be monitored. Now come to the conclusion. Post-operatively, many adjuvant added in TAP block to improve quality of analgesia, but fentanyl prolonged the post-operative analgesia effectively and in safe manner in comparison to tramadol or plain TAP block. These are the some references for the support of my study. Thank you.
Now, the next speaker is Dr. Lokesh SB.
Respected delegates, I would like to thank Isacon 2021 for giving me the opportunity to present my topic, evaluation of pre-induction single dose of intravenous magnesium sulfate for prevention of post-operative pain in patients undergoing elective laparoscopic cholecystectomy. Myself, Dr. Lokesh SB. Laparoscopic cholecystectomy is one of the most common laparoscopic surgeries performed worldwide. But hemodynamic responses due to remoperitoneum, that is sudden increase in heart rate or blood pressure, are detrimental to the patients. Alpha agonists, beta blockers, drugs, opioids, and vasodilator drugs are often used to avoid circulatory response to the pneumonia. Each of the above medication has its own advantages and complications such as bradycardia, hypertension, sedation, etc. Magnesium sulfate has shown to block the release of catecholamines from both arterial medulla as well as from nerve terminals. It causes vasodilation by direct action on blood vessels. In methyl D-aspartate receptor antagonist, it causes hemodynamic stability. It also causes analgesic effects by reducing pain transmission in the central nervous system and thus helps in attenuating hemodynamic response to pneumoperitoneum. Magnesium infusion during general anesthesia for laparoscopic cholecystectomy may helps in prolonging the duration of post-operative analgesia. But the studies to support effectiveness of pre-induction single dose of magnesium sulfate are very sparse. Hence, the present study was undertaken. Our primary objective is to evaluate the effectiveness of pre-induction single dose of magnesium sulfate on duration of post-operative analgesia. And secondary objective is to assess any side effects like bradycardia, hypertension, and delayed recovery from vomiting due to magnesium sulfate administration. This is around my inclusion criteria and exclusion criteria. As is a randomized prospective double-blind study. It was conducted after obtaining ethical committee clearance and with informed written consent from the patient. And sample size was calculated based on the previous study done. And we got 30 patients in each group. The 60 patients were randomized into two groups using numbers generated from www.randomization.org. Magnesium sulfate group, the patient will receive injection magnesium sulfate at the dose of 50 mg per kg in 100 ml normal saline, slow IV over 10 minutes before induction. And in control group, patients will receive 100 ml normal saline, slow IV over 10 minutes before induction. The anesthetist who gave the drug and followed up the patient was unaware of the combination. And all the intubation will be done by the same anesthesiologist. After infusing the patient with study drug, depending upon the number generated from the random table, monitors are connected to the patient. After pre-oxygenation for 3 minutes, all the patients will receive IV injection midazolam 0.03 mg per kg, injection fentanyl 2 mg per kg, and injection propofol 2 mg per kg. After confirming adequacy of mask ventilation, injection atropinium 0.5 mg per kg will be given IV. Standard protocol for induction, intubation, maintenance of anesthesia, and extubation are followed for both the groups. The hemodynamic variables were recorded pre-induction prior to the hemoperitoneum and post-hemoperitoneum at every 5 minutes and thereafter till end of surgery. The patient will be extubated after confirming adequacy of spontaneous respiratory efforts. The post-operative pain was assessed by visual or analog scale between 0 and 10. 0 being no pain, 10 being the most severe pain. Every hour till first rescue analgesia. And the rescue analgesia was given if the VAS is more than 3. Time of first rescue analgesia and total number of rescue analgesia was recorded. Injection tramadol 50 mg via slow intravenous was what administered as a rescue analgesia. Hypertension is defined as fall in mean arterial pressure more than 20% of the baseline and was treated with intravenous crystalloids and ephedrine. The bradycardia is defined as heart rate less than 60 beats per minute, was treated with atropine 0.6 mg IV. And any adverse effect like desaturation, nausea, vomiting, headache, bronchospasm, flushing, and dysrhythmia were noted and treated accordingly. The monitoring of the patient was continued in the post-operative ward for 24 hours. The statistical analysis was done using IBM Spaces 22 version software. Results. The demographical data were comparable between both the groups. In both the groups, there was no incidence of bradycardia. There was no incidence of hypertension in both the groups. The duration of post-operative analgesia in magnesium group was more compared to control group. The total tramadol administered in first 24 hours was more in control group compared to magnesium group. In both the groups, we didn't observe any side effects. Magnesium sulfate has been used to attenuate hemodynamic response to pneumoperitoneum by its direct vasodilator effect and inhibiting the release of catecholamines from adrenal media and nerve endings. It causes analgesic effect by reducing pain transmission in the central nervous system and thus helps in analgesia. In many studies, magnesium sulfate has been used as a loading dose followed by infusion, which reported with side effects like hypotension, bradycardia, and delayed recovery from anesthesia. The limited studies are conducted to study the effect of single dose magnesium sulfate on post-operative pain management. Hence, the present study was undertaken. In 2006, Elsnobi and Elsnobi administered 40 mg per kg magnesium sulfate over 15 minutes before induction of anesthesia, followed by 15 mg per kg per hour infusion during the operation. They reported higher episodes of serious hypertension by using this dose of magnesium sulfate. In our study, we have used single dose of magnesium sulfate in the dose of 50 mg per kg and we didn't observe any systemic adverse effects. In 2009, G et al. Found that magnesium sulfate at the dose of 50 mg per kg or 2 to 2 minutes prior to the hemoperitoneum effectively attenuated the hemodynamic response without any episodes of severe hypertension or bradycardia. In our study, we found that pre-induction single dose of magnesium 50 mg per kg was effective in increasing the duration of post-operative analgesia without any adverse effects. To conclude, the pre-induction single dose of magnesium sulfate is effective in increasing the duration of post-operative analgesia in patients undergoing laparoscopic cholecystectomy under general anesthesia without any adverse effects. References. Thank you.
Now, the next speaker is Dr. Khushbu Sharma.
Good day, everyone. Myself, Dr. Khushbu Sharma, Senior Resident in RIMS Ranchi. I am going to present free paper on anesthesia and challenging in cleft surgery about my experience. Cleft lip and palate are one of the commonest congenital anomalies worldwide. Anesthetic challenges in these patients are related to the pediatric population, airway problem because there is shared airway, and also because of cleft lip and palate. There is malnutrition in these patients, and there are other associated congenital anomalies also. So the cases were done under SMILE train with limited resources. Aim to review the technique for the safety and good outcome. Typically, all the cleft lips were repaired at the 2.8 to 4 months of age, and cleft palate repaired between 8 to 16 months. If we repaired early in case of cleft lip, it's good cosmetically. And if we repair palate early, it's good for the speech development. There were lots of confusion about fitness and safe anesthesia in this patient, but it's also necessary to operate at appropriate time. So out of 546 cases, cleft lip alone was 46%, palate 21%, and combined 33%. Most of the patients which we have operated for cleft lip are of 3 to 4 months of age group. Some patients come early, so we operate, but otherwise 3 to 4 months. In the age of 9 to 14 months. For weight, there is Millard criteria for cleft lip, like 10 pounds, 10 weight, and 10 grams of hemoglobin. But it's difficult to achieve in our scenario because malnutrition is a common problem. So for cleft lip, we've relaxed the weight criteria to 4 kg. And for cleft palate, till 8 kg, we have operated safely the patient. Hemoglobin, our criteria is 9 grams, but not less than that. Upper respiratory tract infection is a common and frequent problem in pediatric patient, and we can't postpone the surgery for 2 weeks because patient never so many times never come back again. So, and we want to operate the patient timely. So we look for fever, activity of child, and chest auscultation is very important. Runny nose is a common problem during crying. So always not an indication, like we should not postpone the case. If there is upper respiratory tract infection, we start antibiotics and bronchodilators, and patient can be posted once improved, but no doubt there is more risk of bronchospasm. Other associated anomalies are there, so we should assess the airway for facial deformity, and if there is other major systemic disease, we refer them to the higher center, and in all cases should be assessed by a pediatrician. In pre-op preparation, we follow the usual fasting guideline of 246. Our O2 atmosphere should be kids-friendly and temperature should be optimum. No pre-op sedation is required in infants, and we don't give glycopyrrolate because it causes tachycardia. Light clothing is fine. Intravenous line should be put by the trained staff or under anesthesia. Then we start the IV fluid RL at the rate of 2 ml per hour per kg. Check all the equipments and we can give Rentec and Amisid. If there is IV line, we induce by IV induction. But if no IV line, inhalational induction either by halothane or sevoflurane, then we secure the IV cannula. Put the monitors, routine monitors, but never forget to put the precordial stethoscope. It's very helpful. IV induction with propofol and thiopentone, both are like good. And always confirm mask ventilation or check laryngoscopy before giving muscle relaxant if there is intubation. Analgesia is by tramadol or fentanyl. Muscle relaxant, we can give either of them. I have never faced any problem in all of this. Intubation by RAE tube, and always keep your difficult airway cart ready. Always keep atropine and succinylcholine syringe on table, and never try to intubate in light pain because there is more risk of laryngospasm. Keep suction ready, and tube fixation is very important. Intubation without muscle relaxant has more risk and more complication. So intubation with muscle relaxant have less laryngospasm, bronchospasm, repeated attempt, and it decreased the time of intubation also. We faced intubation difficulty more in bilateral cleft lip palate and isolated cleft palate. Intra-control ventilation is safe with less complication, maintenance with oxygen, nitrous, inhalational agent, and muscle relaxant. Always take care of tube during surgical manipulation or mouth gig. ETCO2 monitoring is very important. Some surgeon put short pack in cleft palates, and IV dexamethasone is always given to decrease the post-operative respiratory complication. Doses post-operatively, room temperature should be optimum. Always remove the pack. Proper suction should be done. Check laryngoscopy if needed, and reversal with glycopyrrolate and neostrigmin. Extubate only when patient is fully awake, and give diclofenac suppository. In recovery room position, look for bleeding, supplemental oxygen is required, and minimum SpO2 monitoring. Observe patient for 6 hours. So in my patient, there is no mortality or morbidity in a whole year. Surgical repair is really challenging from the anesthesia point of view, but proper technique and vigilance is very important. Thank you.
So next is Dr.
Greetings of the day, everyone. The topic of my study is to evaluate compared clinical impact of two different dosage of oral melatonin on preoperative anxiety and postoperative pain relief. We all know that preoperative anxiety can be a significant factor leading on to development of postoperative pain response. Routinely, benzodiazepines are used. They have undesirable side effects. Opioid and non-steroidal anti-inflammatory drugs, they have also undesirable significant side effects. Now, melatonin is a naturally occurring hormone which controls circadian rhythm, and it has a variety of effects like anxiolytic, sedative, hypnotic. The advantage is that it does not impair cognition or psychomotor function. The aim of the present study was to evaluate clinical impact of two dosage of oral melatonin, that is 3 and 6 milligram, on preoperative anxiety and post-op pain relief. The primary outcome was VAR for anxiety and VAS score for pain. And the secondary outcomes included time to first analgesic request, 72 hours paracetamol and diclofenac consumption, then effect on insomnia, sedation, and nausea scores. Study design was prospective, randomized, comparative, and double-blind study. After institutional ethics, written informed consent was obtained from all the patients. The inclusion criteria was total number of patients 63, age 20 to 60 years, ASA grade 1 to 3, undergoing lower limb orthopedic surgeries under spinal anesthesia. The exclusion criteria included all standard contraindication to regional anesthesia, the patient having major systemic illness, and the patients who are taking preoperative medications like MAO inhibitors, warfarin, or anxiolytics. The patients were randomly allocated to 3 groups of 21 patients each. Group 3 patients received melatonin 3 milligram, group 6 milligram melatonin, and group 3 received placebo orally the night before and 1 hour before surgery. To calculate sample was set at 95% with a power of study as 90%. These are the results. As we can see that when anxiety VAR scores were compared up to 12 hours postoperatively, no difference in the anxiety among the 3 groups was observed. However, at postoperatively 24 hours, anxiety scores were significantly less in group receiving 6 milligrams of melatonin as compared to placebo. Whereas at all postoperative timings ranging from 36 to 72 hours, there was no difference in the anxiety. regarding pain scores, there was no difference in any of the groups. And when like placebo, M3 or M6 at any time interval. So these are just in written the anxiety scores and pain scores. The time to first and second rescue analgesic request was longer in patients who received 6 milligram melatonin as compared to 3 milligram melatonin. The patients in melatonin groups, that is receiving 3 or 6 milligram, they had slightly higher sedation scores, although the level was not significantly different. There was no effect on hemodynamics in any of the groups, and none of the patients in any group received nausea. The factors associated with preoperative anxiety, they are female gender. And those patients who are having negative future perception, patients having malignancy, smokers, or having previous psychiatric disorders. The patients whose level of education is high, they also have they are also more anxious. In our study, lower anxiety scores were observed up to 36 hours postoperatively with 6 milligram of melatonin, although the difference was not statistically significant as compared to receiving 3 milligram melatonin or placebo. The expected anxiolytic effect of melatonin, well, why was not observed in present study? Because one factor may be that, number one, most of the patients were male, and moreover, the patients, they in our institute, they take 2 to 3 days to get operated. So maybe if they were anxious, the anxiety was settled before surgery. The opioid-sparing effect of melatonin is because of interplay between melatonergic and GABAergic systems. So there is enhancement of endorphin levels. In a study, it was suggested that the analgesic effect of melatonin during the perioperative period is limited, and therefore the results remain controversial. In our study, no effect of melatonin was observed in insomnia scores, which is the results are similar to another study done by Ismail et al. If the dosage of melatonin, they are increased to 10 milligram, then it can, delay circadian times. To conclude, pre-medication with 6 milligram oral melatonin seems to be more effective for preoperative anxiety and post-op pain relief as compared to 3 milligram of melatonin or placebo. However, more studies are needed with higher and soft doses of melatonin to obtain the optimal dose of melatonin for pre-medication. These are the references. Thank you very much for your kind attention.
Now all speakers are done. I'm request to chairperson, please hand over it. You can ask any question in it.
Over to Dr. Khairat Mohammed.
Hello. Hello. Am I audible?
Sir, you are not audible, sir.
Hello.
I request all the participants to turn on the camera, please. Dr. Khairat?
Yes. Am I audible now?
Sir, you are not audible, sir.
Yes, sir, audible.
I'm audible.
Audible, sir, audible.
Okay.
Yes, sir.
Okay.
Yes, you're audible.
Let me at an outset congratulate all the speakers.
Can you
for,
join from another device?
No, I don't have it around here. It's a holiday today. Am I audible?
Yes, sir. Yes, sir, audible. Please continue.
At an outset, let me congratulate all the speakers for presenting beautiful studies. One question I will ask from the speaker. who presented brachial plexus block for fistula creation for dialysis.
Dr.
The
Khairat,
question
you
is,
are not audible, sir.
hello? Am I audible now?
Yes,
Hello?
Please
Sir,
rejoin.
you are audible to us.
Okay.
Yes, sir, you are audible to us.
Okay. The question is to the speaker who presented brachial plexus block for fistula creation for dialysis. My question is there any correlation between local anesthesia and end-stage renal disease? Is it dose related? Should we use less concentration and less doses in creation of fistula in end-stage renal disease? Yes, please.
Hello.
Yes, dear.
Sir, the metabolism of local anesthetics is through kidneys only. So definitely we need to decrease the dosage in patients with CKD.
What about the concentration? What concentration you used in this?
Sir, we are
I mean
using
the percentage.
Yes, sir.
Zero.
Sir, yes, we are using 15 ml of 0.375% of propan.
Okay, so this is lesser dose and less concentration you are advocating.
Yes, sir.
Okay, thank you. My second question is to the one who presented transfusion in aneurysmal bleed. Is he audible to me?
Yes, sir.
My question is, can this transfusion be avoided altogether?
Sir, actually, there has been controversy to keep HB around 10 in aneurysm patients because if we allow anemia in these patients, that also is associated with unfavorable outcome. So, sir, avoiding it altogether would be difficult. The only purpose of the study was to see if we could transfuse also, and while avoiding the risks of transfusion. So, avoiding it altogether would be difficult, sir.
Okay. Thank you everybody for such good presentations.
Thank you, sir.
Bye.
Thank you, sir.
Thank you, everyone. Now the next session will take place at 11 a.m. PPF session.
Hello, everybody. We welcome you all on PPF session at Isacon 2021. We are well in time, and I am seeing at least 10 people on screen who are logged in. And we are starting with our session. As you all know, PPF, that is Private Practitioners Forum, is an official forum of Indian Society of Anesthesiologists, taking care and guiding anesthesiologists for their day-to-day practice, doing it safely for themselves and for their patients. If you are safe, your patient is safe, and if your patient is safe, you are safe. So always think of patient safety first, and you always be safe. So we go with the same theme. Today we are starting our session, and we have got 5 lectures and then a panel discussion on our waiting list. We will start with lectures first. The first lecture is from Dr. Nikita Patel on solidarity is the need of the day. How to achieve it at local ISA branch level. Dr. Nikita Patel is freelance consultant anesthesiologist from Nasik. Basic interested in trauma, orthopedics, and regional anesthesia. She has been faculty for management of emergency critical scenario and hands-on workshop for CPR in 2021. Faculty for CPR workshop in 2019. Secretary for Women Doctors Wing, IMA Nasik 2021. Awareness of legal rights of women on Women's Day 2020. Faculty for Tejaswini, a program for adults and girls, and IRC credited trainer. Over to you, Dr. Nikita, for your presentation.
Very good morning, ladies and gentlemen. Thank you, Team Isacon, for inviting me. And a special thank you to PPF National Coordinators, Dr. Asit Vaishnav and Dr. Pankaj Gupta for the opportunity. My talk today is Solidarity is the need of the day, and how do I achieve it at local ISA branch level? Now, supporting each other and growing together for a common cause is solidarity. As you can see in the picture, a fist grows into the sky. That is, a group of members come together and achieve heights while the roots stretch deep into the ground. That is, the foundation gets stronger, just like our Indian Society of Anesthesiologists. Now at Nasik ISA level, what we already have? We have an ISA office since 2013. Before that, we started this with a mere number of 17 who met at individual places, and since the year it was 1992. We have our own ISA traffic island, a proud monument built in 2017. Every visitor coming to Nasik is attracted and wants to go to this spot. So each member feels connected to this spot again. We have a common consent form in digital as well as physical form. We have guidelines for minimum charges which are updated every 2 years since 2013. Recently, we have this updated guidelines in 2021. We have a common notes pro forma, again in digital and virtual physical form, and we have our own website. This is the latest guidelines for anesthesiology rate list. We take into consideration extra hours also. These are just the basic guidelines. You are allowed to increase them, but these are the minimum charges. So no surgeon can exploit you, at least related to the charges. We have for the clinical communication ground, we have clinical meetings. Here we also have outside speaker and 2 local speakers. We have 2 WhatsApp groups, official and a friendly katta, and a Facebook page. We have a separate anesthesiologist group, lady anesthesiologist group. No. There is no gender bias at all. We are now 198 members in Nashik, out of which 85 are females. So sometimes there is reluctance to discuss by some females on the main group. Issues like common interest like parenting and children education are discussed here. Now, challenges that threatened our solidarity. COVID duties. Yes, COVID duties did threaten to some extent. The disease was new. The virus, we had no history, and what was its presentation, what will be the complications. Carrying it home was always on the mind, so it threatened our solidarity. The generation gap, our seniors were forced to retire voluntarily in spite of the willingness or non-willingness about the retirement, I should say. New members who just wanted to come back to start their work had to pay EMIs, and suddenly there was a lockdown. Work was stopped completely. So that difference was there. People, how did we solve it? Yes, we came together, had a work. Some of the work from the members of seniors was given to the juniors. So this also turned into an opportunity for the juniors. We have problems like individual versus group practice and ego. For the COVID duties, first and foremost, our association provided face shields to all members. To just ensure a sense of security, a call was made prior to the duty and after the duty, ensuring and inquiring about the experience of the member and his safety. Allotment of COVID duties in alphabetical order made it fair for all. After the things was done, settled down, COVID was little fearless. We appreciated our members as COVID warriors. Definitely everybody has problems, but how these problems were turned into opportunities. Sensing the fitness or the marathon trends in the lockout, we first started with a group that is called Kindness to Self and Kindness to Others. So in this activity, we formed a WhatsApp group and invited people who are into fitness, like jogging, running, simple, regular walking, to join the group. Everyone shares the kilometers walked, run, or cycled here. 5 times the sum of kilometers worked out by all of us together in rupees is donated for a noble cause. So that's it. It is kindness to self and kindness to others. This donation is done through a charity account by our association, not individual members. This not only motivates each member to exercise and improvise, but also bonds us together for kindness to others too. This idea was very, very welcoming. Initially, we were just a group of 30 members. I can proudly say today we are 72 members into the fitness group, and we have done 2 donations. One on the occasion of Teachers' Day, we donated to National Social Forum, who built up a library for village students. So that was very, very satisfying. Towards the end of the week, when I had put up on the group that we are going to donate and the sum is important, everybody started working out more and put up their workouts through apps like this. So this was a very, very new, innovative and welcoming idea, and the impact of kindness is really great. Now, those who were not into running, they came together for Surya Namaskars and meditation on International Yoga Day. Our own member is a qualified yoga guru who conducts classes virtually too. After that, as the fear of COVID was down, we met into open air space. Very few members came forward for the nature trails first, 20 of them. And then we had this family trek on a mountain open space with kids. So this time the number increased. Still, we were not meeting in a closed space. So now how to increase membership? So online Tambola. Tambola female members were attracted definitely, but we wanted to involve male members too. So we gave it a twist. Now here the twist was, we asked them to dress up in a cap, tie, and we maintained the commentary with cricket. So the twist was online Tambola with cricket commentary and the style of saying the numbers. So this increased participation of our male members too. We had officially sports declared now, and first we started with online chess tournament. Now people were winning, but that was it. We came together. Nobody wanted to leave the meeting virtually also. But then we decided to surprise them. So this time we send them ice cream boxes through Swiggy. You can see the smile on her face after winning the tournament. In the month of June, we planned a box cricket, again an open air activity, and named the teams as adrenaline rushers, atropine saviors, fentanyl pacers, and ketamine knockers. Yes, yes. As I can see, the names only attracted many new members, many young members who even I had not known since we were not meeting for the past 2 years, came forward for the cricket tournament. We had a proper tournament. Officially, we had winners. We gave them trophies. We had a base bowler, fielder, batsman, and everyone had great fun on this day too. This radio awareness activity. Now, this activity we have since last 2 years. Our monthly activity where a topic of common interest for public, like post-COVID rehabilitation or back pain by our pain physicians, labor analgesia is discussed. And here, two teams were formed. One to finalize the topic with the speakers, and another to shoot a promo video, post links on YouTube. So again, technically sound people came together during this event. Managing anesthesia cases. MAC. So MAC 21, the name was catchy too. Here, internal academic session showcasing local good work by our members came up. So this was one of the best way of sharing and learning together. Even new members doing work in peripheries like private practitioners, they came forward on this platform to present their work and were definitely growing together, not learning everything here, but we have again a good coordinator for this event where we have a pre-final event, we have a mock drill and problems and cases are discussed technically as well as non-technical. This becomes an extra local platform to promote kinship. In Marathi and English, on the occasion of World Anesthesia Day, members from all generations participated in video highlighting the diversified role of anesthesiologist, his qualification and history for public. Felicitation of members who present at various conferences is always done. This time, Nasik was lucky to host IMA National Sports. Our members definitely participated and won. But we had an official medical team to take care of the injuries. So our team participated in medical team in the ambulance too. Them also on our next meeting. Mentoring. Every new member is welcomed and guided in view of practice, be it freelancing or joining a corporate, medical college, whatever. Conflict resolution, clearing of misunderstandings is always done as a team. There was a conflict between practicing group practice as well as individual practice. So we called them together in our office. It was completely roundtable meeting where we first gave them a piece of Cadbury chocolate. So the tension immediately came down. Everybody was cool and they knew now this is an amicable meeting and we are all going out of this room in a happy mood. So that way we started the meeting. And yes, the misunderstanding, the conflicts were resolved in a very, very amicable way. Exploitation by surgeons is completely prevented as an association. A lot of effort is put into creating this sense of belonging. On the occasion of World Anesthesia Day, we appreciate our seniors, felicitate them for their contribution and our foundation. At the same time, we invite junior residents from the medical college for cake cutting and enjoying the evening. So this again, we try to make up the gap and welcome the members, seniors as well as juniors. A sense of brotherhood and unity among medical specialties. This is in Nasik since many years. We have a collaboration with Indian Medical Association for both academic and non-academic purpose. Since I told you about the sports organizing chairman and secretary were both anesthesiologists. ACS simulation for other specialties including dental, ophthalm, surgery, hematology and obstetrics is most welcome. This represents the session of our society at the forefront, again makes our bond stronger. These are the various conducts where we have done for ACS simulation. We also come together to celebrate the Independence Day, Republic Day. This time we also had a virtual cultural activity. There were singers who came together, poetry recitation was there. But he is the senior-most member from our society of 75-year-old person. And he, during his pandemic, was quite isolated, like risking his lungs. So he created his own poem called Chanda, that is hobby. And to express his Chanda, he had this platform and again felt a sense of belonging to ISA recently. We have done Shastra Puja on the occasion of Dasra at ISA office. We believe excellence is contagious. So another person excellence, you are motivated to excel yourself more. Our young person who is just 42 was recently elected as IMA president. It was definitely a proud moment for us. Our members have also conquered the Mount Everest and are the first Indians to complete the race across America. And won in beauty pageants, social service. So this culture of multiple individual achievements is important. For the financial crunches, this was arranged. Another senior member, 72-year-old, came forward to share his experiences of investments in share market. This activity enriched non-financial management, another source of income actually, and a subject close to heart of many. This time, I also made many new friends because of this activity. Recently, we had this karaoke evening. Now, since we are done with sports, academics, finances, so we again came together for karaoke. We had a planned 16 songs, and on the spot, 3 members were inspired and encouraged, and they presented 2. But to increase the audience, now the singers were coming. The members we had asked for felicitation, they were coming. I just wanted to increase the audience. As it was announced a week, everybody geared up to buy the outfits or borrow the outfits. And in the last days, it was top gear. It was put on our friendly katta, what to do, what not to do. And everybody again came together for this evening and enjoyed a lot. Family gathering, our children, our spouses look up to every year. They are also made special by having activities for them in our get together too. As I conclude, I will just say, may we all be protected. Om Sahana Vunattu. May we work together with great energy. Savirya Karvavahe. May our intellect be sharpened. Tejasvina Vadhitamastu. Let there be no animosity among us. Ma Vidvishavahe. Om Shanti Shanti Shanti. Thank you.
Yes, Nasik branch had been a leader in this mentorship and maintaining the unity. I would like to put it on record that Nasik and Kakinada branches have been at forefront in making all efforts to unite the members. So we move on to next session. ASA grading, its relevance in our practice by Dr. Vikram Alsi. Dr. Vikram Alsi is from Nagpur. He is practicing at Zenith Hospital Center for Minimal Access Surgery, Shivaji Nagar, Nagpur. He has 18 years of freelance practice, experience in laparoscopy, more than 10,000 thoracoscopies, more than 500 esophagectomy, more than 100 speakers at various ISA events, local, state, and international. IRC certified trainer, active member of ISA FBF, past secretary of ISA NCB, and many other social media fora also. Over to you, Dr. Vikram Alsi.
Good day, dear friends. It is a privilege to present my views at the National Conference. I thank Dr. Pankaj Gupta and the whole organizing team for this. I also congratulate them for a very successful conference in these difficult times. I'm going to talk on ASA physical status classification and its clinical relevance. You are all aware of ASA physical status classification. It was introduced in 1941 and its aim was to assess the patient's general condition before anesthesia. The classification by itself does not predict perioperative risk. This is mentioned in the ASA website. In 1941, Saklad et al. Did a very good job and came up with a system which is still followed with only a few modifications. He classified ASA into 4 classes and kept 5th and 6th for emergencies. He also included the functional status of the patient. Each class was supported by several examples to help classify patients into respective categories. They also gave a tabular form to objectively classify patients into various categories based on their symptoms. Class 1 was asymptomatic and class 4 was a patient with severe disease. It is quite similar to NYHA classification of heart disease. The first major modification came in 1961 when they tried to make it simple and remove the objective criteria. It made the whole classification subjective. This is the classification most of us studied during our anesthesia training. A new revised classification was published in 2014. I'm sure everyone is aware of this. I will not go into details. The following are a few salient features. They added class 6 for brain dead and they tried to remove subjective variations by giving examples. In 2020, they expanded these explanations further and tried to simplify it by more examples. They included pediatric and obstetric cases examples for first time. You can see that all obstetric cases, they start with ASA class 2. That was history in short. Let us see what ASA classification means. We regularly classify the patient into one of the ASA physical status at the time of pre-anesthetic checkup or on table before the surgery starts. There are many studies which find correlation between ASA physical status and post-op mortality. Hopkins found a significant trend towards increasing mortality with increasing ASA status for his patients. But does it help us? It surely alerts us if the class is 3 or above, but it does not help us decide the type of anesthesia or drugs to be used. It also does not help us in deciding the level of post-op care the patient may need. According to me, there are many drawbacks to the ASA classification. It is subjective. Different anesthetists will grade the same patient differently. You remember the story of 5 blind men and the elephant. Not just Panchatantra, there are many scientific studies to show the inter-rater consistency is poor. This study by Singaram in South Africa, it showed that the variability in the same patient seen at the pre-anesthetic clinic and then in the OR. He also found influenced by level of expertise or number of years of experience in the specialty. Another factor ASA doesn't consider at all is the type or severity of surgery. Look at this simple table from UCLA to guide us. See, it is a very simple form and things cannot be that simple, but surgical risk needs to be considered. I am sure most will agree. The functional status given in the physical status classification is very vague. Look at this class 3. A person having only poorly controlled BP, say 180 or 120, and a person with 4 months old MI with ejection fraction of 40% with end-stage renal disease. Both patients come in the same class. The anesthesia risk optimization required is different. It is also not a simple 1 plus 2 is equal to 3 kind of a system. See these examples given in the pediatric case. It will make us think a lot and still we may not be certain of the class that we put the patient into. Like I mentioned earlier, this classification does not guide us. We cannot decide the type of anesthesia or even what kind of setup we must use. So far as anesthesia management is concerned, or even perioperative care, we are at zero, no help at all. That also means we cannot decide if the patient is fit for surgery and anesthesia. Though an integral part of PSC, ASA physical status system has no role in deciding fitness for surgery or anesthesia. This study by Joe Fitzhenry, it shows that ASA does not predict operative risk, but operative risk is dependent on multiple factors. Classifying someone sincerely into one of the ASA physical status grade is a time-consuming activity. For a person in private practice, time means money. We cannot spend time doing activities which will not help patient in the patient management or anesthesia care per se. Our earnings depend on doing more cases. Each case postponed or cancelled directly affects our income. Many places, PSC is done by physicians who do not know anything about ASA physical status system. The aim to assess and communicate a patient's medical status simply fails with this system. What is a probable solution or an alternative available? We need an ideal system which is easy to perform, easy to replicate, has minimum variability, and will also help us in anesthesia management. Needless to say, none such exist. But what are the alternatives? We have METs or metabolic equivalent of tasks, breath holding time, and gut feeling. METs or metabolic equivalent of tasks. One MET is defined as amount of energy or more accurately oxygen used at rest. We know NYHA classification uses these METs. NYHA class 1 and 2 are relatively easy for anesthesia, and class 3 and 4 need to be optimized before surgery. But how do we practically implement METs? Most studies say that if MET is equal to or more than 4 without symptoms, we can proceed to OR. Now, what is MET more than or equal to 4? If you can climb 2 flights of stairs without stopping, run a short distance, brisk walk for 30 seconds, then your MET is more than 4. Anyone who can do these daily activities can be considered candidate for anesthesia. There is one interesting study by Winstein et al. They compared MET estimated by history to that by actual exercise cardiac stress testing. They found that the MET of a estimated by the preoperative history is conservatively assessed, and it often underestimates the METs by exercise cardiac stress testing. Meaning, we are likely to err on the side of patient safety. If you follow a simple history method of estimating METs, you are likely to be safe. Next, breath holding time. This is a test widely used. It finds mention in literature as early as 1922, when Jones found it as a safety factor in determining surgical risk and oxygen need under anesthesia. Sabrase's breath holding test, a simple test, and it's easy to replicate. I use a small modification. I ask the patient to close his mouth and breathe normally. I close his nostrils and start the timer. He is asked to hold his breath for as long as he can. And when he is not able to hold any longer, he simply opens his mouth and starts breathing. I take the best result of the 3 tests if it is more than 25 seconds. Though the normal value is more than 40 seconds, any value more than 20 seconds can be considered safe for anesthesia. This one study by Vipin Agrawal from Pune also concludes that. He says in a resource limited condition, breath holding test can be taken as a non-machine, non-technician dependent bedside surrogate test for lung function test. A person having breath holding test greater than 20 seconds should be allowed to undergo necessary operative procedures. Last I mentioned was gut feeling or intuition. Though it sounds unscientific, it is not so. I would like to take an example from cricket. Consider a batsman, someone like Tendulkar or Rahul Dravid. Over the years, they have played so many balls that the moment the bowler releases the ball, the batsman is able to judge how the ball is going to behave, where it is going to pitch, how much the ball is going to bounce. He may not be able to tell you the speed in kilometer per hour or the deviation in degrees, but he is able to get the bat at the right place at the right time and time the ball perfectly to the boundary. This is because of experience over the years and not something unscientific. Sometimes the brain works out a truth without you being conscious of the intermediate logical steps and chain of reasoning. Even that we tend to ignore our intuition. It is nothing but a subconscious analysis of all the data available to us, processed through all the years of experience. That gut feeling sometimes tells us to stay away from the case and sometimes to go ahead with it. Don't ignore it. To conclude, I would say that routinely grading patients according to ASA physical status is a waste of time. We can ignore it. Instead, classify patients as per severity of surgery and use the functional status. Thank you.
Yes, it was a good interpretation of ASA classification and its relevance. We move on to next topic of discussion or lecture is documentation and communication, a weak link in our daily practice. It's from Dr. Vijay Tyagi. He's a freelancer consultant anesthesiologist from Dehradun. He's practicing at Kanishk Super Speciality Hospital and Arihant Hospital, Dehradun. 20 years of freelancing practice as anesthesiologist and medical consultant and NABH. He's got appreciation award for service in Kedarnath disaster by UK IMA, that is Uttarakhand IMA 2013, and Doctor's Day Award for outstanding services and contribution by IMA Dehradun 2016. Over to Dr. Vijay Tyagi for his presentation.
Good morning. Good morning, all of you. It's really a privilege to share my views on the Isacon. Before I start my presentation, I just want to share my experience. My experience, actually, it was a story of about 8 to 10 years back when I was in medical college in Dehradun. I was senior resident over there, and there was a case of BOD. And I was the first person in this city who was booked under section 3048 negligence and FIR watch law against me. And I spent one night in police station at that time. Though after the settlement of all that case, it was decided by me I will go for the career in the law. And I did my LLB after that. And now I'm just taking care of medical legal cases of the friends, the society, IMA, giving advices on that. But I'm a freelancer right now. So my topic and what I am going to discuss is the documentation and communication. and the importance of that. So documentation and communication are weakening in our daily practice. Why document is needed? Remember the golden rule in the law that if it's not written, it's not done. And the importance of this thing, if it's not written, it's not done, and if it's written, it was done. That means we will see it and discuss it in one case, very important case, we will discuss it later on. But failure to document what you have done makes a good care of the patient to indefensible in the court of law. If you don't document your good work, that means it's difficult to defend in the court of law. Litigations arising in every case is a potential litigation. Do remember that when you are going for a case, don't take it half-heartedly. And if you are taking a case, you are responsible for it. And every case is a potential litigation. Anyone can go into the court of inquiry and the court of law. The purpose of documentation, documents are the evidence for the compliance with the standard care given to the patient. It's a proof of evidence of anesthetic management, how it was managed in the operation theater, whether you visit the patient preoperatively or not, what care you given after the post-operative period. Evidence of the choice of anesthesia and the dosage used. The most common allegation on anesthetics is that wrong anesthesia was given and the was given. So you can defend it with document only. That is no other way. Otherwise, any allegation can be made. And evidence of action taken if there is any critical and unfavorable incident occurred in the OT. If there is any unfavorable incident, that can you did the right thing, that can be proved only if you have documented it properly. So that's the purpose of the documentation. Effective communication, and so communication with the patient, very important step which is missed by many. Go to the patient directly, tell her you are her anesthetist and will take care of him, will see everything comes out smoothly, safely. You will take care of the pain. Fear of the pain and fear of surgery is the biggest fear for a patient, and only we can do this thing. Communication with the relative, again a very important step, because after the surgery is over, it's your chance to take the advantage of the situation. Go to the relative, yes, everything is fine, or anything gone smoothly, and just it's our chance to take the credit. Communication with the surgeon and the staff. Most of the time, staff can tell you many things which surgeon doesn't want to. So it's always better to have a communication with the surgeon and the staff. And last and the most important thing is the documentation of the communication. This is, we shouldn't forget. Then documentation, what are the documents which are to be maintained? The consent of the procedure, consent explanation of the procedure, what you are going to do, how you are going to do, what are the different alternatives, and whether the patient wants it or not. That is the responsibility of the surgeon, anesthetist, sorry. So it's our duty. The PSC, there are innumerable number of the cases, innumerable number of the conditions in the court of inquiry, in the court of law, anywhere. Where the first question asked is, when did you first see the patient? Did you do the PSC? So this is the most important documents. Yes, we saw the PSC. And then immediate preoperative assessment on the table. Even if we have made the PSC and we have preoperatively assessed on the table, this is again defensible. And if not defensible, then a good step. So if you have not done PSC, or if you have done, assess the patient on table, take a short X-ray, any problem, which she must have forgot before, but now she can say. Then intraoperative methods and the monitoring, what were the vitals during the surgery, how it was managed, was there any complication, was there any deviation from the normal vitals or not. That is to be noted, and all details are given on the ISA website. So forms and everything can be downloaded from there. but by maintaining vitals and recording after 5 minutes, mandatory. The post-operative status of the patient, how was the condition of the patient in the post-operative period, conscious, obeys verbal command, because we have seen many number of the cases where period there was tongue fall or the aspiration, and then anesthetist was held responsible for that. Timing of the surgery is most important. When was the case started? And the starting of the case, what we want to say is the starting of the anesthesia. No, it's not the surgical incision when it was started, because surgeon will always say after 1 hour, yes, I am starting the case, but patient was intubated 1 hour back, or spinal anesthesia was given 40 minutes before, and this happens commonly with the basically with the ortho surgeries. Reporting of the critical incident, don't conceal if there is any incident, critical incident happens during the surgery, don't conceal. Report it. It's always better to report it, because in the case which I will discuss afterwards, the cardiac arrest was concealed during the surgery, but when it came out, it was a different and difficult scenario. So you see the few cases, very important case, which I want to discuss is this was a case Aruna bin Kothari versus Navdeep Clinic. Unfortunately, it was a DOB, but when it went to the court of inquiry and court of law, it was seen that there was no PSC. PSC was not there, and hospital was also less equipped, no defibrillator. And when it was asked by the judge why the defibrillator was not there, did you notice it before giving anesthesia? And anesthetist, no, that compensation was granted against that anesthetic. And just said it. If there was no defibrillator, you must have told the setup surgeon and the in charge, I need it. If he doesn't provide, then you can say, I asked for it and I have proof for it. And again, we will see in one case this kind of scenario. Dr. Rao versus Jayaprakash. This was a case of 1990, very important case. Patient posted for the ENT surgery, took 2 hours and went off smoothly. Patient went to the home, but later on, the relatives discovered that patient is having decreased attention span and decreased IQ. So they consulted a neurologist. Neurologist went on the MRI and it was found hypoxic injury. So when it went to the court of inquiry, it was assumed that there was a cardiac arrest and it was concealed. Two anesthetists died during the procedure, but it was in the judgment, just said why surgeon didn't participated in the CPR. Another case, Lakshman Prakash versus the State of Madras High Court. Again, it was noted there was a PSC was not done and failure to prepare patient for the anesthesia. If you don't do PCAC, then you cannot say the patient is fit for anesthesia. So it's our fault. There's one case, Dr. Ravi Gupta versus Durgesh Saini. It was a case where fracture patella was repaired under local anesthesia, but patient post-operative period went into the MI and cardiac arrest was there. When it was proven, case went to the court of inquiry, the relative showed a bill which had billing for 4 ampules of the ketamine. 4 vials of the ketamine was ordered and purchased from the medical shop. So it just said, why? If you did it in local anesthesia, then why there was a bill for ketamine? That means that you must have used it. So beware of that. What is written? This is again this Joginder Singh. Dr. Joginder Singh versus Joginder Singh versus Rajiv Majumdar case is a very important case of anesthesia. And I say this, every anesthetist should read this case. I love this case. The judgment, the decision made by the judge, the observation made by him, very important case. And the most important thing in that case is, I will tell you in the last minute. Just listen that carefully. It was a case of bilateral renal stone. The first operation went off smoothly, and after 10-15 days, surgeon decided he should operate the second kidney also. But after the first operation, he noted it, the poor tolerance to anesthesia. Nobody knew it, why he has written that case. So when it went into the court of law and inquiry, the observation which were made by the judge, see, look at it. It was a anesthetist was Dr. Kurana. It was somewhere from Faridabad, so Delhi NCR. So he said, I have never seen, I have never read anything like poor tolerance of anesthesia. An expert committee also said there is nothing like poor tolerance to anesthesia. There is no word to it. But just simply said, you must have seen the previous surgery notes. And surgeon has written poor tolerance to anesthesia. Why didn't you ask that? What is that? That means there is poor communication between the surgeon and anesthetist, and that is not allowed. And during all that case, there was a time delay of about 8 hours from shifting patient from one nursing home to another nursing home. And then just again asking people during that 8 hours, what were you doing? An anesthetist told me 8 hours I was doing hand ventilation only. Then they just said, this is inhuman. This is inhuman. 8 hours hand ventilation is not allowed. For an expert person, simply ventilating patient. Anesthetist should have insisted to buy a ventilator. He should have advised recruitment of the trainee technician nurse to operate boils, and there is no proof of it. He has never asked for it. A specialist is required to know the latest technique for the management of the patient, and if he is ignorant about it, then he could be considered negligent. And judge said it, no one helped the poor anesthetist. Because this case happens in 1996 and the NCDRC judgment was in 2009. But again, just 25 days back, this was again taken by the Supreme Court of India, and to the pride of all anesthetists, Supreme Court absolved all charges against the anesthetist. And NCDRC, which awarded compensation of about 17 lakhs. But the Supreme Court said, no, there's nothing wrong in it, and there is everything is okay. So beware of it. What should be written, what should not be written. The litigations are writing, and it's necessary for anesthesiologists to know and follow the minimum standard expected from them by public, profession, and the law. The key factors in prevention of the patient injuries are vigilance, up-to-date knowledge, adequate monitoring. What my advice is, play a defensive practice. Defensive practice, practice defensive medicine. Pre in the post-operative rounds, you should develop a good patient relationship, maintaining up-to-date habits, better safe than sorry, and beware of the vicarious liability. Vicarious liability are the liabilities of your assistant, your technician. Sometimes, many times, we allow the technician to give the spinal. The patient is conscious. He knows who is giving a spinal, who is intubating the patient. Maybe not in the GA, but regional, so yes, it is. But you are responsible for the vicarious liabilities. So beware of that. This thing can. And last is thank you very much. Thank you very much for all this. That's all.
Good evidence-based guidelines for documentation and communication by Dr. Tyagi. We move on to next paper on next lecture in our session, Anesthesia in Post-COVID Patients, Protocols and Guidelines by Dr. Sridevi. Dr. Sridevi Valluri, the consultant anesthesiologist at Vijayawada. She is with Pioneer Anesthesia Associates, managing Rainbow Hospitals, L.V. Prasad Eye Hospital, American Oncology Institute at Vijayawada. She has 18 years of standing in practice of anesthesiology. In 2014, current series director, Pioneer Anesthesia Associates, providing obstetric, pediatric, and ophthalmic and onco-anesthesia services for corporate hospitals and freelancing. Previously, she was with KIMS Hospital, Vijayawada, and worked at George in Newton, UK also. Over to you, Dr. Sridevi.
A very good morning to all. I would like to thank the organizing committee, the scientific team at Isacon, and Dr. Pankaj Gupta for giving me this opportunity. In the next few slides, I'm going to take you through anesthesia for post-COVID patients and how we can protocolize and have a few guidelines in private sector. I'll take my talk through the following subheadings: post-COVID syndrome, mucor, MIS-C, and how we can do pre-anesthesia assessment, timing of surgery, preparation for emergency. While every anesthesiologist is battling with coronavirus as a frontline warrior, the issues of post-COVID-19 sepsis and syndrome has opened a new battlefield and emerged as a significant problem. So we must prepare ourselves and reframe. More than 150 million patients have recovered worldwide till today, but the dysregulated innate immune response, the cytokine storm, and the microvascular coagulation caused by COVID-19 has put these patients at risk of post-COVID sepsis and numerous complications. So it is only appropriate to set a standard for pre-operative evaluation, given the high degree of uncertainty. Persistent post-COVID syndrome or long COVID syndrome is said to occur if the symptoms persist for more than 4 weeks and their RT-PCR are positive. There could be new symptoms, or there could be multi-organ effects, or there could be effects of COVID-19 per se, or just because of hospitalization. It is hypothesized to be secondary to virus-specific pathophysiological changes, prolonged inflammation due to acute infection, and sequelae of post-intensive care illness. Lungs have been found to have impairment as residual shortness of breath and decreased FRC even up to 3 to 6 months. The radiological features are consistent with pulmonary fibrosis and interstitial lung disease with impaired diffusion. Right ventricular dilatation and dysfunction leading to cardiomyopathy, left ventricular diastolic dysfunction were also notorious with COVID-19. When troponin levels were increased, they had worse outcome. Sometimes only cardiac arrhythmias or abnormality in cardiac imaging were the only findings. We all know about the thrombotic events that occur in the acute phase. They continue in the convalescent phase as well. Thrombocytopenia was noticed. D-dimers in particular were found to be elevated even after 6 months. They were more than 500 nanograms per ml. PT, APTT, INR were all raised. Kidneys have also had an impact in moderate to severe SARS, where they presented with AKI, which lasted even after 6 weeks after discharge. Hypothyroidism, hypocortisolism, hypothalamo-pituitary axis being suppressed due to prolonged steroid usage were all seen in COVID-19, post-COVID-19 syndrome. Liver has had dysfunction with elevated transaminases, low albumin, and elevated LDH. The characteristic anosmia includes here, that is loss of taste, severe muscle weakness, fatigue, serious physical deconditioning have all continued in the post syndrome. There's been general myopathy and frailty. The recently emerging as the most common COVID infection is mucor, and we've all heard about the black fungus. It is a lethal fungal disease, with the rhino-orbital mutation being the most common. As surgical debridement of the infected area has improved survival in these cases are going to be encountered more and more. So we need to reevaluate our anesthetic approach towards these patients. Multisystem inflammation in children has been said to occur if they've had COVID in the last 4 weeks, there is no other possible diagnosis, and they're less than 21 years, presenting with fever, laboratory evidence of inflammation, and evidence of clinically severe illness requiring hospitalization. There is also multi-system involvement of more than 2 organs in cardiac, renal, respiratory, hematological, gastrointestinal, dermatological, or neurological.
Therefore, in general, all non-urgent procedures should be delayed until the patient has met criteria for discontinuing isolation. Elective surgery should be planned only after anesthesiologist and surgeon agree jointly to proceed. Center for Disease Control has given out guidelines for stratifying the severity. So once their RT-PCR positive, based on the symptoms, they're asymptomatic or symptomatic. If the symptoms were mild to moderate with no viral pneumonia, saturation is less than 95%, or saturation is more than 95%, they were considered as mild. And if they had hypoxemia, respiratory failure, or pulmonary involvement, they were considered as severe. Immunocompromised were again stratified as symptomatic and asymptomatic and dealt separately. It was found that replication competent virus was not present after 15 days following the onset of symptoms in approximately 95% of severely or critically ill patients, whereas it wasn't found after 20 days after onset of symptoms in any patient. Based on this, American Society of Anesthesiologists and Anesthesia Patient Safety Foundation have advised patients to wait for a few weeks before non-urgent or so the 4 weeks was considered as a decent time for mild to non-respiratory symptom COVID affected patients. 6 weeks for symptomatic, even if it included shortness of breath, but they should have been not hospitalized. 8 to 10 weeks if they were symptomatic, diabetic, immunocompromised, or hospitalized, and 12 weeks for ICU admitted patients. Good preoperative assessment with history, clinical examination, and investigations as pillars is detrimental for post-op and intra-op. So in history, the functional status should be assessed, the severity of the disease should be taken into account, the sequelae for SARS-CoV-2 on various organs should be noted, and any optimization should be done. Anticoagulants, prolonged steroid cover should all be detailedly accounted for. Effort tolerance, breath holding time, if they can't do the 6-minute walk test, cardiopulmonary evaluation in detail should be done. Nutritional status, renal and liver function should be also checked. Investigations could be classified based on the type of surgery and the severity of the disease. So if they were minor and they were asymptomatic, chest X-ray was found to be not needed if the pulmonary examination was normal and SpO2 normal. In major procedures, chest X-ray, whether even if they were asymptomatic, was required. Complete blood picture, complete metabolic panel, ECG were required in all classes. Echo was needed only if the cardiac examination was abnormal. It was definitely needed in symptomatic patients. PTT, fibrinogen were sent for in major procedures where they were asymptomatic, whether they were asymptomatic or symptomatic. D-dimers were done for all symptomatic and for all major procedures. LDH, ferritin, albumin were done based on severity of illness. Renal function tests were mandatory in patients where drugs such as amphotericin were being used. Liver function tests were particularly recommended in elderly patients ASA 3 and 4, where there was severe COVID-19 and where they had pre-existing liver conditions. HRCT, pulmonary function tests, and ABGs were recommended in patients who had moderate to severe hypoxia and who were posted for major abdominal, thoracic, cardiac, or vascular surgeries. In geriatric, even though they were asymptomatic and recovered, they were also advised to go through HRCT or PFT and ABGs. 2D echo and troponin I were recommended for those symptoms of normal ECG and heart failure. RT-PCR was not required if the patient came for surgery within 90 days of onset of COVID symptoms, because it would come positive even after recovery. Preoperative optimization should be multidisciplinary. Vaccination, if they can wait, should be completed with both doses and surgery plan 2 weeks after. Bronchopulmonary toilet is important for avoiding post-op complications. Steroid dose should be adjusted less than 3 weeks or less than 5 milligrams. They need not be supplemented. Hyperglycemia should be controlled. Anticoagulants, if they're on anticoagulants like low-dose ecosprin, it does not need to be stopped. Clopidogrel in low-risk surgery should be stopped 5 days before and restarted 24 hours after. And in high-risk surgery should be stopped 7 days before and restarted 24 hours after. Low molecular weight heparins can be timed as 12 hours before procedure and 24 hours after. Direct oral anticoagulant should be stopped much earlier, like 28 hours, and restarted much later as 72 hours. If unfractionated heparin was used, check platelets if it was for more than 4 days. Appropriate informed consent documenting the risk of anesthesia and the need for post-op elective ventilation in poor pulmonary reserve patients is crucial. Intraoperative management could be done in these lines: anxiolysis, reassurance, particular mention about humidification, preferring regional anesthesia, going for stable induction agents, making sure fasting timings are followed properly because of the delayed gastric emptying, cautious fluid management to avoid congestive heart failure, and use of hemodynamic monitoring wherever warranted, avoiding inadequate ventilation, hypercarbia, and acidosis, which can result in AKI. Of particular note is that tranexamic acid worsens COVID thrombosis, so not to be used. Patients should be stratified in the preoperative assessment itself, making sure that post-op oxygen supplementation, ventilatory support, hemodynamic monitoring would be available, particularly when we are doing in smaller setups, depending on their comorbidities, degree of invasiveness of surgery, depending on the cardiovascular problems that they have. Multimodal analgesia can be provided using epidural analgesia, nerve block, following the WHO pain ladder. NSAIDs should be avoided in those with renal dysfunction. Emergencies are inevitable. These could be challenging because of time constraints. Usually it's trauma or emergency cesarean or exploratory laparotomy. There is no shortcut to thorough history and clinical examination. Baseline ABGs, breath holding test, echo, D-dimers should be done. In emergencies, regional techniques are preferred and recommended, but we have to rule out coagulopathy and thromboprophylaxis. D-dimers are of utmost importance because they indicate, if they're high, indicate persistent need for thrombolysis and low index of suspicion for PE. If we have to reverse low molecular weight heparins in an emergency, go for FFPs at 10 to 15 ml per kilo rather than antifibrinolytics. Make sure the steroid cover is given. Aim for higher hematocrit to improve oxygenation. This is the recommended minimum time interval between antithrombotics and the neural puncture. And then the second one is the antiplatelet agents. General anesthesia in emergency, if deemed to be done, has to include the muscle weakness that can occur in COVID. So we have to make sure that muscle relaxants are given in minimum amounts so as to avoid residual weak paralysis. Then scoline should be avoided to those with prolonged recovery. Volatile agents like sevoflurane is preferred due to its bronchodilatory effect and rapid removal, but isoflurane is preferred in to halt fungal growth. Ventilator strategy should be similar to what we do for ARDS with stiff lungs, Lung protective strategies like low tidal volume and pressure control should be used. High PEEP can be used, but we should be aware of the potential barotrauma. To sum up, COVID-19 presents with not only multi-system involvement but post-viral sequelae. Timing of surgery for elective cases should be done as a multidisciplinary approach. Meticulous pre-op assessment is the key thing, making sure post-op supportive care is taken care of. Emergency surgery, if required, should be planned with due consideration to anticoagulation, post-op support. Regional anesthesia is preferred, although it can be challenging. These are the references. Thank you for patient listening.
Yes, our life, our practice, day-to-day practice is stressed, and stressed. Stressed of patients, financial stress, family stress, and stress. Here is a stress buster from Dr. Kala Iswaran. Stress busters for a busy anesthesiologist. Next topic. Dr. Kala Iswaran is a multi-talented anesthesiologist. She is practicing at Kalyan. She is consulting anesthesiologist, freelancer practitioner since 2 decades. She is associated with multiple hospitals in Mumbai, suburban Mumbai, and Thane district as a private practitioner. She has received many excellence awards and she has many papers at her presence portfolio. Over to Dr. Kala Iswaran.
Warm welcome to everybody. I'll be speaking on stress busters for a busy anesthesiologist. First of all, I would like to thank the Isacon Ahmedabad team and the PPF session to allowing me an opportunity to take part in the stress busters for a busy anesthesiologist. When we enter our private practice, our hopes and aspirations are such that we should have a very good practice, giving us an extremely good setup with all the amenities available in the OT and in the hospital, have a great house or vacation homes with good servants serving us with all facilities, have good family life, have great family life and great family outings and vacation times and a beautiful bungalow and a swanky car. These are our aspirations when we enter. And what happens? To get these, we need to have a successful freelance practice. And for that, we need to be available 24/7. We should be punctual. We should have the patients to deal with the patient's relatives, patients' queries, the surgeons, the staff, and also the people at home, our in-laws, our spouses, our kids. And at the same time, give quality care to our patients. No? The stress of high-risk cases and all, have the right attitude to deal with the surgeons, the family members, the kids, the neighbors, and the friends, each asking for a part of the time in your life. And meanwhile, you have to upgrade yourself, attend CME for the CME credit points, of course, and have a sincere approach towards all this, maintaining the ethics also. So this takes a toll, running between the hospitals as in freelance practice, the traffic, the reaching on time, which is very essential because you lose on other cases sometimes, the waiting for the surgeons while you are refusing other cases, the patient's complications or the patient's high risk, which make you wait and say no to other cases. And most of all, you say no to your child that eats you up. The kids crying at home, wanting your attention, but you cannot give that. So the stress is directly related the working stress, that is difficult intubation, a difficult spinal, difficult block, or inadequate anesthesia coming up in spite of ASA1, and not to add, if you have a very high risk case, that adds to the stress. The stress also sometimes is in an interpersonal relationship. Here you can see the surgeon yelling at the anesthetist. Okay, you can have stress with the colleague creating problems for you. You can have a stress with a setup, which is not what you aspirated when you started the practice. The setup fails to provide the quality care to the patients, and where you compromise in the setup. And slowly you see that you are aging and still you remain there, but the age catches up on you and the depth and the credit. Okay, so somewhere that is the main thing, the financial instability. Okay, all these adds to stress. Now, stress, success you achieve sometimes, but at what cost? Stress can lead to poor performance, and this can lead to lesser achievements, and it takes you away from your goals, lowers your self-esteem, and this all can lead to disastrous consequences on patients and self. And over a period of time, as you age, it increases the challenge, which adds on to the stress, and this is a vicious cycle. The stress can lead to headaches, acidity. You may eat omes or antacids like you're eating chips and then keep working. You'll end up with irritable bowel syndrome. You're prone to allergies you develop. You're prone to myocardial ischemias. You have chronic backaches, decreased immunities. You have seen people who are overworking and succumbing during the COVID time because of these factors. The obesity, you start stress eating and then the weight goes out of control. All these can lead to make you prone to cancers. You can have depression, and even suicidal attempts is a possibility. Now, burnout occurs because you are trying to find a balance between the family responsibility, the pressure, the time pressure, reaching on time, finishing on time, reaching for the next case on time. The time thing kills you sometimes. There's a chaotic environment around you. As I said, it's a vicious cycle, no? The stress leads to more stress, and then slowly you lose the control of the pace around you. Okay, so that leads to burnout. Now you have two choices: either you fight or you flight. Flight is relatively easy, though not very easy, but it's easier. You give up the practice. I have seen so many people easier giving up medicine and going for construction work or share trading, or they do some other sort of businesses. Okay, they retreat, they discard the entire thing, move on, they remove themselves from this profession. But when you fight, you have to stand your ground, defend your position, attack, dig in, and be perseverant. Okay, so you have to find your stress busters here. You have to fight and learn to say no and let go of the stressful surroundings, let go of the stressful setups, let go of the stressful relationships. Do not try to drag on the surgeon because you are there for 10 years. No, I should be attached. No, be friends and let go. Okay, learn to say no, take care of yourself. The mantra should be self first. Okay, you have to get adequate sleep, eat healthy, avoid addictions, do mindful exercises, and most importantly, do your financial management right from the beginning, and with value your friends and the family support you have. Do not take your family for granted, telling ki ye to family hai, they are going to be there, let me cater to the surgeon first. No, because your family, come what may, is going to be there for you. First of all, you all should have a mindful, fitful sleep. Sleep for 6 to 8 hours compulsorily. Learn to say no to cases which disturbs your sleep. Okay, inadequate sleep can lead to a lot of health related problems. Mindful eating is eating with the intention while paying attention to what you're eating. Do not eat, learn to refuse food when you are full, when you do not want to eat, and look at the quality of what you're eating so that you do not get obese, you do not have hypercholesterolemia, and you do not go into an addictive spree of eating, Mindful exercise. This is very important, the term mindful. Mindful, what does it mean? Mindful is not that monkey chattering which you carry everywhere around with you. That is what the surgeon ne ye bola, your wife has told you this, the husband has yelled at you, the kid's back answered, oh my God, my kid back answering me, how dare he talk to me like this? My mother, nowadays she does not understand what stress I'm going through, my kind of work. No, you cannot carry that baggage around with you always. The mind should be free from all the baggage. Then only you can have a very good exercise which to you. Okay. Now, tips to help you exercise mindfully is be curious and open-minded about the physical sensations, the physical activity what you get involved with gives you. You have to understand and learn to get the full benefit of whatever activity you're doing. Remove distractions. Keep your mind, get involved completely with whatever you're doing. Ride the waves of different emotions. Each exercise, each kind of the trekking or dancing or singing or simple gardening has certain emotions coming with them. Enjoy that to the fullest. Learn to go with the flow. Okay, listen to your body. Your body will tell whether this suits you or not. Learn to say no to that kind of exercise and go towards try out newer things which may suit you better. Engage in exercise for fun. Exercise should get you joy. Joy, the glow should come from within when you exercise. It gives you so much joy. Okay, it should not be a cumbersome thing. No, I have to attain this goal. No, I'm lacking behind. No, I listen to your body. Go with the fun of the exercise. Use attention anchors telling you what is needed, what is not needed. Connect with the intention for exercising. Then you know what you started it for. Not to become a chiseled body or have a zero size figure or fit into your own. You want to be happy. You want to be stress free. If needed, try slower forms of exercises which will suit your body. Pay attention to the quality of your movement. Okay, so not 30 times I did today. Tomorrow you're tired. No? So why you want to do that much? You do a slow form of exercise. You understand what is doing to your body. Main important thing is whatever activity you're choosing as a stress buster, it should calm your racing mind. The multiple thoughts coming into your mind, like the fight you had, the argument you had with your staff or your surgeon, or one patient who has troubled you so much, you should not carry it along with you. So the activity, whatever you're doing, has to calm your mind well. It should take you towards believing in you and in the ideas, the power, the meditation, and thoughts which you culminate in within your brain into a positive thinking, creative empower, and create an empowered environment or universe around you. A smiling, laughing, stress-free you. Okay. Now, the mindful exercise can be in any form. That is the yoga, which is the in thing. You need not go for power yoga and stress your body. I have to do these exercises. No, just do it. Go along with the flow of your body. Gym workouts. Recently, you must have heard so many people having an heart attack, young people dying. So listen to your body. Do not sleep deprived body to the exercise or gym workouts and push yourself. No, if you have not had adequate sleep, adequate food, and adequate rest, do not go for gym workouts. Learn to say no and do mindful exercise. Cycling can be fun, especially when you have your friends with you. You can have weekly program of cycling, which can slowly, it should be for fun, and it add-on thing is that it gives you fitness too. Gardening, COVID taught us each one can produce their own food, the veggies, the fruits in your own small garden or your balcony. The pleasure of growing your own thing is so joyful. You do not understand that you are exercising too. So this is a great stress busters, believe me. Music speaks what cannot be expressed. It soothes the mind and gives it rest, heals the heart and makes it whole, flows from heaven to the soul. Music can be in any form. You just play a guitar. You need not have a melodious voice to sing. You can attend the classical music or even simple Bollywood music, whatever gives you fun, enjoyment, and takes you away from stress. Trekking gives you a great connection with the nature around you. Even you can have join those trekking teams which goes every weekend and form new friends of like-minded people around you. Family and friends, they cannot be denied. You need to have regular meets. No, don't think of telling ki, oh, I have a case, I'll come late or something like this. No, do not miss. This is the best stress busters. Keep your friends and family close to you. Attend or try to attend as much as possible the friends get together and the family get together. Believe me, these memories last a lifetime. Emotional intelligence versus emotional infection. This is an important thing because when you have these kind of people who put negativity within you, they may talk about about bad things about their mother-in-law or their spouses, and such relative has troubled them, or how a colleague is troubling them. All these adds to emotional infection. Believe me, these friends are negative people. Learn to identify them and keep away from them, because they can infect your emotion, their mind, and add stress to you. They take away the peace from you. So understand the friends, the family members, and try to cut the topic there only, and be with those who are bring joy to you and bring positivity within you and take you away from your stresses. For me, I do not know whether dance was my destiny or boon, but it brought in me a great peace. It gave me meditation, that monkey chattering in my mind, constantly thinking about the case, how to improve myself, the surgeon yelling at me for coming late. I could not have food that day. Even still, I bore with the brunt of the surgeons yelling, the patient giving me trouble. All these thoughts keep on going in your mind. And but my mind is not in the exercise. No, it keeps running in all the thoughts which are adding. So what kind of exercise that was? If I'm cycling, my mind should be been in the cycle, not with the thought. So I tried so many array of exercises, but when I reached dance, it gave me the pleasure. If I start thinking about something else, there is a misstep, I lose the dance step. So dance made me think only about dance during that period. That it gives me a sort of meditation. It brings joy within them. How much ever there are shortcuts to happiness, they say, and dancing is one of them, surely. When I dance, I forget everything else and just feel completely happy. There are times when I've been walking, doing 13, 14 cases since morning, and I think, oh, will I be able to dance today? Will I push myself? But then I manage somehow to go climb the stairs, being so tired. But believe me, when I do this, I just forget everything else. The ache of all the body aches and everything just evaporates away, and I feel so rejuvenated, and it's sort of brings out happiness from within. Dance is a way to find yourself and lose yourself all at the same time. It's a great meditation. And it taught me that if you stumble, make it a part of your dance. So even mistakes, even shortcomings in my life, I face with a smile. It's not that I do not have problems, but it taught me to smile. It taught me to go ahead instead of loitering there and crying. Life isn't about waiting for the storm to pass. It's about learning to dance in the rain. So dancing taught me that, come what may, you have to move ahead, with a smile. And hence I could create positivity throughout the career and my life, which spilled over to my patients, my surgeons, my staff around me. So people around me, when I'm very happy when they look at me with a smile and I smile back. And my patients too are very comfortable with a smiling anesthetist rather than yet the staff. So the results are very positive, and my patients' healing and the surgeon's work, everything is reflected very nicely with a positive. So that's why sometimes people wonder how she does it. And thank you so much for listening to my talk, and hope you all have a stress-free life ahead. Thank you so much, Isacon Ahmedabad. Thank you so much.
It was a nice stress-busting lecture. And we move on to our next panel discussion. Panel discussion on tips and tricks of an efficient, effective, and safe anesthesia practice. It will be coordinated by me, and the panelists are all Dr. Nikita Patil, Dr. Vikram Alsi, Dr. Vijay Tyagi, Dr. Sridevi, Dr. Kala Ishwaran, and Dr. Mahesh Sinha, who is a senior member of ISA and ex-GC member. We have Dr. Dr. Gupta, Pankaj Gupta on panel online, and we'll be having a video panel discussion on the subject.
Welcome friends to PPF session of ISA, the Isacon 2021. We are having group discussion on tips and tricks for efficient, effective, and safe anesthesia practice. Exactly, if I give introductory history of PPF, it is Private Practitioners Forum of ISA, which is part of ISA. It's a platform on which practicing anesthesiologists discuss their problems, and we guide them, particularly we guide them for the safe anesthesia practice. Way back in late 80s, 88, 89, ISA started various fora to accommodate various people having various interests, and many fora has started on ISA platform. Defense anesthetist, railway anesthetist, prior practicing anesthesiologist also forum was started way back in 1988, 1989. Dr. Abhay Patwari and Dr. S.C. Parakh, both from Hyderabad at that time, were instrumental in starting these sessions. And we had a first session in 1988-1989 conference also. Later on, for 3-4 years, the session started, and Dr. Abhay Patwari shifted to Middle East, and the session was silent on ISA platform. Way back in 2017, again, Dr. Virendra, Dr. Pankaj Gupta, and Dr. Shakil Momin, and many others started this forum again, revived this forum again. A WhatsApp group was formed in 2017, and by a discussion on WhatsApp group, we formulated guidelines for practice for private practitioners, and that was passed by general body in 2018 conference at Lucknow. So, and now from 2017, our PPF session is very much active and guiding our anesthesiologists. So the practicing anesthesiologist is a freelance anesthesiologist, king of his own practice. I am saying that he is king of his own practice, like small Rajwada of pre-independence time. But as like small Rajwadas were answerable to English or maybe Angrez residency, presidency, similarly, we are also answerable to courts, government institutions, and our patients. So to guide them to self-practice, we have started PPF sessions in all conferences, and now today we are here to discuss in a group tips and tricks for efficient, effective, and safe anesthesia practice. Today we have with us Dr. Pankaj Gupta, National Coordinator of PPF. Myself, Dr. Asit Vaishnav, convener of PPF Gujarat State. Dr. Mahesh Sinha from Raipur, Dr. Nikita Patil from Nasik, Dr. Vijay Tyagi from Dehradun, Dr. Sridevi from Vijayawada, Dr. Vikram Alsi from Nagpur, and Dr. Kala Ishwaran from Kalyan. Dr. Virendra Sharma, one of the pioneers in reviving this PPF in 2017, is busy as a treasurer in national headquarters, so he cannot attend today's session. But we remember him for his basic efforts and starting with at starting of our sessions. Dr. Pankaj Gupta, you all know, he is Nasik and he is national coordinator of PPF. Dr. Mahesh Sinha from Ramakrishna Care Hospital, Raipur, is very senior anesthesiologist. Perhaps is the senior most person on the today's discussion group, and he has been ex-governing council member headquarters, and he is present president of IMH Chhattisgarh. Myself, you know me very well. I am practicing anesthesiologist at Rajkot. At present, attached with Smile Train Partner Hospital through Plastic Surgery Hospital and Maheshwari Eye Care Hospitals, and otherwise I have got 41 years of standing in specialty, where 31 years is in private practice. Here, Dr. Nikita Patil from Nasik. She is secretary of Nasik City branch of ISA, attached with trauma, orthopedics, and regional anesthesia work. Dr. Vikram Alsi, young anesthesiologist, again from Nagpur. He is attached with Zenith Hospital, Center of Minimal Access Surgery. He has vast experience of laparoscopic and thoracoscopic surgeries, minimal access surgeries, and he is IIRC certified trainer and very much active member on all social media active groups. Dr. Sridevi Velluri, she is anesthesiologist from Vijayawada, freelance anesthesiologist, and pioneer practice anesthesia associate, Rainbow Hospital, LV Prasad Eye Hospital, American Oncology Institute, and she has 18 years of experience in the branch. Dr. Kala Ishwaran is well-known versatile anesthesiologist from Kalyan. We know her by her presence and very much active participation in all social fora. And she is today with us to share her freelancing experiences with us. Now we direct our questions, directly go to the questions. Question 1, I am directing to Dr. Senior most person, faculty of today's session, Dr. Mahesh Singh. What are the common safety bypasses you have observed in operation theatre in yours or others' practice? Please.
Unmute yourself, sir. Sir, unmute yourself.
Yeah. Good evening, everyone. Thank you for calling me to take part in this discussion. A lot of things have been happening in the private practice forum, which is a solely freelance practice, which is unique to our country and some few more countries in Asia and developing countries. Otherwise, there's only hospital-based practices are there. So we have been observing a lot of things in the past, and there were not so many rigid issues, or even patients were not complaining, and even the level of work was also not so high. Very few things were getting done. Mostly obstetrics was one area, cesarean sections and like those surgeries were done. What are the things we used to bypass because of short of the time? This is like people will come and there will be pressure. Go ahead, go in the spinal, and without examining the patient, you go ahead giving the spinal, and later on you realize that the patient has some other problem also, and they land into trouble. And then this gradually the improvement is started with the newer laws coming up and people becoming more cautious about the medical legal aspects, medical council laws and ethics and other principles. So the main thing was the time was short, so people coming and going from the theater in a short time, not covering the whole period of the surgery was also seen. Equipments were in many places, many bigger cities like National Capital also equipments were not available in the operation theater. So how they're managing if some problem occurs in the nursing home, it is difficult to ascertain what was happening. Luckily, in my place, we had a machine in every nursing home, and that established right from the beginning and then continued. So at least that part was covered in our area. So we didn't bypass those things. Sometimes even surgeon used to say that, okay, now you can leave because now you're closing the skin or something like that. So these are the bypasses which were happening. Things were not, we didn't have monitors also. That was not, era was not evolved. So we cannot blame that time period. But the one thing was that we used to keep a pulse on the patient, our hand on the pulse of the patient continuously till we are present in the operation theater, which is lost, I think, with the advent of the monitors. So, and many other now deviations are happening. The cities are growing. So people are in much more lesser time to travel, and more time is required to travel to different places for the private practitioners. So many lapses happen. Now we cannot bypass like pre-anesthetic checkup, although maybe just before the surgery, we have to keep record, which were nowhere previously. There was no record at all of the patient getting operated, who operated and who gave anesthesia, nothing was there. Then what happened in the post-operative period. So these newer things are coming, and now this is mandatory for everyone to keep themselves safe. So first thing, these bypasses, it is still happening. I learned that many places this happens. People leave the theater early without handing over to an adequate person. This should not be done for your safety, because now nobody is going to save you. Neither the nursing home, the surgeon, nobody is going to save you. See, bypasses. So how to protect yourself is the one of the things. So first, foremost important thing is to get an indemnity insurance before you start practice, and you should be registered. So these are the few points which were bypassed, and many places even anesthesia was given by the technicians also. I hear that it still continues in many places. So this thing should be no place now in this time period. That is my point. Thank you. Yeah, Dr. Asit, your mic is muted.
Dr. Nikita has to say something on this point also.
Sir, I will just add, it is a habit after, particularly with COVID, we were with also, and then we have somehow given up the use of stethoscope. And with the patient hiding history also, if because of that habit, we start doing that, directly attach monitors and start doing the case. Because of the post-COVID complications, which are still unknown to us, we land up with a case where we can't intubate, and then the patient lands up into pneumothorax because of the IPPV, which we provide at a higher volume or so. So we have to get back into the habits of checkings. And to add now, with COVID, we have to be even more careful with the patient hiding history and the unknown complications which we are still to see. So that point I would like to add here. Also, overwork by the anesthesiologist. If he is not stressed, overworked, lack of sleep, he should opt out of doing the case or hand over the case to his colleague. It is not that losing your practice, but safety is more important in this case. Sometimes is also risky. So as sir said, it is safety of the patient and the safety of anesthesiologist himself.
Anybody has to add anything?
Yeah, I would
Sir,
like
I
to.
would like to add.
Sir, can.
Nowadays, most of the hospitals, including small nursing homes, they all have NABH accreditation. So one of the requirements of that is having a surgical safety checklist. So I think most of the anesthetists, they do fill it up, or they have someone filling it up and they sign it. But we bypass actually doing the checklist. I think if we follow that, most of the errors or mishaps can be saved. It's a very nicely designed checklist. Most of us are using it, but we are not using it in its true spirit, I think. Thank you.
Yeah, I would like to add. Yeah, I would like to add to the whole thing. One important thing is the PAC notes are very, very important in today's practice. Even if you're seeing the patient on table, it's better to see the mention in the notes. You've seen the patient 1 hour before the patient was shifted to the operation theater. And secondly, the anesthesia specific consent form, which has already been designed by us, and it's there on the website. With today, it is very, very imperative to have a specific anesthesia specific consent form. This very basic somehow we have forgotten in private practice, and now they may haunt us in the long term. So please, these two things on the notes I would definitely like to highlight here. Please always have a proper consent and a proper PAC notes. That's all.
Yeah, I'd like to say the documentation and communication. These are the evolvement of the newer era. The combining both of them, documentation and communication of documentation, and similar thing is become very important. One more point I would like to add: few people suggest that you do video or audio consent. Actually, many legal experts say it is not good. You may be caught because if something is not said and it is on record, you will be in a difficulty. Otherwise, writing something and the common things, which is a possibility, you don't have to write the total problems of what is going to happen, but you write the common thing and get it in the local language. These few things are very important. Thank you.
One more thing in the consent which I would like to highlight, sir, is that when you are taking the consent, at the end of it, leave a few lines and let the patient write in his own language that I have read the consent understand the whole thing, and that's why I'm signing this consent form. This is a new thing which has come up, which I'm planning to subsequently have newer consent form for all of us, which subsequently will design sometime this year. That is one important thing which has come up. And regarding this recording of consents, it can be a double-edged sword, as you said, but a lot of corporates have started doing it now.
No, actually, Pankaj, it is mandatory in transplant cases. You
Yes,
have to do
yes.
video recording. But other
Yes.
cases, they say, because there is set protocol in transplant, what you have to say and all the things. So there it is fine. But if you, because in the freelancer, he doesn't want to have time so much to do this consent and.
No, only corporates are doing it. In freelance, we won't have that much time also, sir. So it's a double-edged sword.
That is not easy.
Yeah.
So that we again can discuss in safety tips also. But if I summarize the first question and answer, what people are bypassing is pre-anesthetic assessment, a safety checklist, even checking, forget the basic or WHO prescribe or NABH prescribed checklist or ISA prescribed checklist, but basic cockpit drill that which have been taught them in institutions, checking laryngoscopes, checking anesthesia machines, that basic things also people are not doing it, and that is where we are into trouble. Second thing, lingering on, we will later on come to this thing, lingering on mobile phones, staying away from the patient, in the presence of showing your face outside the operation theater, in the presence of patient's relatives, and all these things are a safety bypass, particularly not using, not connecting monitors, even though they are available. We have seen people using only pulse oximeter or only BP monitor out of all these things, and ECG not using, just for the sake of maybe whatever you call it. But these are the things, the things which are available to them also, that people are not using it. Maybe they are very much bold, we are timid, but these are the safety bypasses which they bypass, and ultimately when they come into trouble, they contact us. So we move on to second question. What is the impact of social media on your practice? Is it intimidating with negative news or inspiring to be bold? Dr. Vikram Alsi, like me, he is very much active on social media, so he has the first right to answer the question.
Thank you, sir. I am quite active, but social media, like any other technology, can be a boon or it can be harmful. It is up to us to make it useful. There are many groups on WhatsApp or Facebook. They help you out when you are faced with the tricky situation. But at the same time, you being on social media during the surgery, you may end up neglecting the patient and face some mishap. Also, what happens is there are many news articles sent on social media. There have been a lot of articles saying some antibiotics should not be mixed in certain fluids, and they have no actual strong medical evidence backing. So we need to be aware of these kind of articles. Whenever a major change is suggested by any article on WhatsApp or Facebook or any other social media, we should cross-check it with a genuine reference and then only apply it or neglect it. So for that, we should be aware of what are the genuine sites where the things are available, and also we should be aware of the genuine this of the person who's forwarding the message. There are so many people who just forward without actually supporting or opposing that message. So we should be aware of that, and also only forward the messages based. Thank you.
Anybody has to add anything?
As Dr. Vikram has said, the genuinity of the level of evidence is very important, because a lot of things come in newspaper also. Somebody gives find it to something else. So we need to be very cautious on these things.
So the news on social media, whatever information we get on WhatsApp University, or we call it, and social media, has to be checked, rechecked, confirmed. But at the same time, when you are in trouble, always an advice from a social Facebook group or a anesthesia group, WhatsApp group, sometimes helps you out in managing the patient. And in your day-to-day practice, yes, what I am doing, yes, he is doing, and you can go through all these things and sail through patient through safety. So so use of social media has to be very, 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 very careful. You have to evaluate the information. Sometimes there are very much negative informations which sometimes make you intimidating. I am many times after hearing many news on social media, I am afraid of taking, even after 40 years of experience, I am afraid of taking some type of patients, some group of patients in some situations. I would like to avoid now, even after 40 years of experience, I avoid all these things. So it sometimes it intimidates you, but many times it brings you out from a trouble. So that's what I would also like to add these things. So now we are moving to the very much important question: when to set? Is there any criteria for refusing case in nursing home status? Dr. Vijay Tyagi, would you like to answer on this?
Yes, sir, I can. Sir, what I say is when to say no is a very much subjective and situational basis. See, there should be, it's on personal. You should say at some point of the time, you should say no. No to surgeon, no to type of cases. And most important thing in that condition is when the patient is high risk and the setup does not have a right backup. See, taking a high risk case in a less equipped setup, definitely you should say no. That is the most important thing I want to say on this point.
Anybody want to add it, Dr. Vikram?
Sir, like I have said in my talk, whenever your gut feeling tells you not to do the case, you should say no. We cannot have a single solution for all nursing homes. It has to be custom based depending on the infrastructure of the particular nursing home. If we consider a nursing home to have only a basic OT and no ICU facility, I would prefer to do only the cases which you don't need to observe post-op. I am saying observation and not ICU care. Most small nursing homes will not have anyone qualified enough to observe the patient after you leave. It will be under the care of the owner of the hospital. So I would prefer to do only cases where we can leave peacefully. Yes, sir.
Anybody wants to add it, or I sum up the case?
Sir, can I tell?
Yes, Kala.
If you go by criteria, even an MTP or a cesarean is you can have complications. So how can we say that there is no ICU backup? Can we get away with that? No. So that's why I mean, electively fine, you can refuse, but that is no criteria to refuse a case. If no, so you wherever you are the main person, you are the main intensivist there, so you do not leave the place, you make everything available, you try to create a just a room like an ICU is not enough for a you need to have physicians, you need to have the personnel there and trained people, and you are the ideal one who is trained as an intensivist also. So key high risk case, low setup, because I've seen complications occurring in huge setups with everything available. I mean, nursing home, how can people refuse at the last minute also? So
Yes.
I do not.
Yes, carry on.
Yeah, so what criteria is like you have to see the personnel. Is the surgeon capable? Is this personnel for monitoring post-op, intra-op for the next 24, 48 hours till the patient comes out? I have myself sat in a small nursing home and out. So we cannot just say totally no to just because you do not have an ICU backup. That's what I wanted to say, sir.
Yes.
Can I say?
Yes, sir.
Yeah.
Actually, there is a whole decision that how much the risk is there to evaluate. Based on that evaluation, you should take the case in a particular setup. There was a case which the patient was taken. It was a high risk patient. This is a planned surgery. Actually, you have to differentiate between planned and emergency. If it is an emergency, anywhere you can do anything anywhere. You are most protected in an emergency. But in a planned surgery, like I said earlier, also if it is a ASA grade of 2, the nursing home setup is all right. But taking a ASA grade 3 patient or multiple comorbidities, and you are knowing that a lot of things can happen, you will be not able to defend it. Actually, that is the main issue. It is not question of simply saying no. Even the surgeon should not take up that case in that system. And many people are now doing such thing that they take that case, they take to some bigger hospital and take their team and operate there. That facility is also there. So safety of yourself and your team is the most important.
Should I summarize? Yes, from my experience, just before starting our session, I have refused 2 patients. Okay, so if patient is not meeting with your nil by mouse criteria, you should refuse. Elective surgeries, you should refuse if patient is not meeting with nil by mouse criteria, age specific and substance specific. Secondly, very much important is if not meeting with the physical status or fitness criteria, hemoglobin criteria, maybe having respiratory infection, maybe high count, but not showing any infection, then these are the red signals to stop. Rethink. Just today only, before starting our session, I have refused a case on the same thing. That patient had a respiratory infection in before few days, and now still the count is 19,000. So I advise, let us stop today, we reinvestigate the things, and we can go further later on. Because again, respiratory infection can flare up, or maybe there will be reactive respiratory tract, and we may be in trouble post-operative. Similarly, if you feel that the setup is not particularly fit for that status of the patient, you can refuse very softly that yes, better we take patient this to a better setup, bigger hospital where we can have an ICU setup backup. It is in our interest. We may not say no, patient is not fit for this, patient is not fit for these things, but better we do not operate over here in our setup. Let us take patient to some better place so that we all are safe. So these are the ways of saying no. Similarly, if you are having any trouble with your particular gadgets, particularly on the day, maybe say you are in rainy season also, if there is a problem with electric supply, and they're saying that let us wait till the thing stabilizes. There is no hurry in starting the case. So these are the ways and places where you should say no, can firmly say no, you can politely say no. These are the ways you can avoid trouble in your practice and make your practice. We move to the sub part of the again similar question. Should we accept fitness by physicians? If no, then how do we manage to do it while working in a small nursing homes? Dr. Nikita would like to answer for these things.
Yes, sir. First of all, I will say I am a private practitioner and I am on my own in the operation theatre. So yes, I will ask for a fitness. Actually, fitness is not the word. It is screening by the physician for the cardiopulmonary status without suggesting any type of anesthesia to me. Being a physician, he is confronting daily with different cases, newer drugs and norms. Maybe I am not into it much, so I get to know that. And there is a screening of major illnesses like maybe a chronic kidney disease or liver cirrhosis, which has to be done. Small nursing homes don't have an ICU backup. So if in case I land up in a complication, I have the physician to help me. And also I will assess the patient in detail considering the anesthesia risk and stress of anesthesia. And depending on the situation, that is it an emergency or is it an elective, I will plan my anesthesia techniques on it. Medical legally, I will say I can be safe too. And if at all I land up in a complication, I have a responsibility to share with the physician. So I will say I will ask for a fitness in this case. But if at all, I will not try to postpone it considering the situation, and just I will try to change my technique of anesthesia delivery in this case, if it is an emergency.
So anybody wants to edit to it, or we should go to next question?
Basically, the word fitness does not match in, sir. It should be cardiopulmonary status of the patient. Fitness is absolutely decided only and only by the anesthetist. Fitness for anesthesia and fitness for surgery. But the physician work to do, he has to mainly the CP status, cardiopulmonary status, and we decide. And of course, as Nikita rightly mentioned, so many senior physicians especially have a habit of writing fit for spinal, fit for epidural. I mean, I've had the opportunity and I told one senior physician, well, sir, please don't into a soup, because then if I give spinal and something goes wrong with the patient, you'll be blamed. So please don't mention this, what is to be given. You can just opine on the status of the patient physically from the cardiopulmonary status point of view.
Yes.
Sir, I would like to add something. Fitness is a term. A same patient who is posted for, say, a minor hernia, minor as in non-complicated hernia, and similar patient who comes with a stab injury. What is the fitness? For one, you may wait and evaluate, but for other, you don't have a choice. So fitness is relative. It is up to us to decide whether we can do or not.
Yes.
Having a physician seen a case earlier, like Nikita has already said, it's always going to help us a little bit. Yeah, but I also agree with what Gupta sir said, that he should comment that cardiopulmonary status and not on fitness. Because a patient with stab, they may give spinal, and you know how it is with stab and bleeding, we give spinal, what happens. So I think fitness is a very dicey word to give fitness for surgery or anesthesia. It is we have to take that call and not physicians.
Actually, the fitness is a wrong terminology.
Yes.
Basically, it was because it has been used for so long time in the past in the medical college and all that. The surgeon used to send for fitness. So when fitness comes, then you have to give anesthesia for like that. But it is not like that now. The surgeons started realizing that it is different domains. So gradually things are changing. Even in one case, one physician was also given penalty for rectifying the case, and then some problem occurred. So now they are also learning. And I think we have to do this all exchanges. As I said, if it is a family physician, that also helps actually in the turn, because he is known to the patient, and when he comes, patient has confidence. One more person is there who is a doctor and as a family physician. So that helps in if some problem occurs.
Actually, I feel there is nothing like fit or unfit.
Yeah.
There is no such something like that. Every patient is fit for anesthesia. Only the patient may be a little higher risk for anesthesia. The ASA 1 and ASA 5 grades, definitely the mortality in ASA 5 goes up to 9.4% cases, whereas in ASA grade 3 it comes to around 3.4. So that's why there is nothing like fit or unfit. Now ASA 6 has come in now. After
you are operating on a brain dead patient also.
Yeah. So that's why that word fitness should not be used. It is nothing like fitness, only high risk or low risk. That's all.
No, physician should only give his opinion. What is the status of the patient?
Yes,
perfect. There will be what are the comorbidities and different things.
Perfect.
Can I add a word?
Yes, Dr.
Yeah, thank you.
Very quickly, please.
It's regarding physician screening, many a times we get screening from RMP. I don't think that should be accepted. That-
There is only one comment that physician's reference is being used as anticipatory bail. We move on to next question. That is very quickly, Kala, can you summarize which blocks are easy to administer and improve anesthesia outcome from private practitioner perspective?
Yeah. Okay. Sir, first of all, we should start thinking with the needle and syringe filled with local anesthetic drug. First requirement or the change in the attitude of the anesthetist, a simple local infiltration can work wonders, especially for a painful ailment like abscess or a small lesion which is painful. Most simple blocks in routine daily practice is LI for any case, keeping in mind the total dose of the drug, and use of local anesthetic for the giving spinal block. That can also change your practice. The patients are, the multiple pricks can be avoided. The perianal blocks, the penile blocks, the digital or the ring blocks, superficial cervical plexus block. It's very simple, and all the neck small lymph node biopsies and abscesses can be done easily. The hernia blocks are extremely effective. The rectus sheath blocks, both for any ventral, abdominal surgeries, they are very effective. The tap blocks too, and at least one upper limb and lower limb be mastered by an anesthetist. Like a supraclav, you can do most of the surgeries of the upper limb, and a femoral and sciatic, you can cover the lower limb. That's what I would like to add.
Quickly, we
Yes,
move
sir.
on to very next question. We have 5 or 7 minutes left at our disposal.
Yes.
What are the minimum OT standards for an ophthalmology OT or any small occasional GOT? Can we give it or say fitness or preparedness for standby only? And what if the patient needs anesthesia? Dr. Sridevi, please. You are working in that situation many times.
Unmute yourself, please.
I am unmuted.
Myself.
Yes.
Yes,
sure.
sir. Thank you. Yes, sir. I have the, should I say, I'm fortunate enough to work in a corporate ophthalmic place and a small nursing home setup ophthalmic place. So I know what standards can be as good as having everything, all monitors, including capnography, high-end station, case station, to basic boils. So, but then any, as RCOA or AAGBI say, all setups should have, where anesthesia is administered, should have minimum monitoring. So that includes ECG, SpO2, blood pressure. And sometimes, depending on how, if the general anesthetics are more administered, then a capnography also. So particularly when we come to ophthalmology, it is a subspecialty. It has patients catering needs from neonates to elderly with comorbidities. It's held done in different places, as we've earlier discussed, smaller setups to bigger setups. So we need to have skilled staff, a mix of skilled staff and equipment available for resuscitation. Would I be happy to give fitness or preparedness for standby only? Yes, depending upon, as we've earlier discussed in the last few questions, depending upon their ASA status, their comorbidities, the complexity of the surgery, and the availability of equipment. So yes, that's where I stand up here.
Yes, very quickly, anybody wants to add to it? Or we should move to next question. Okay, if anybody is nothing to add to it, we move to next question. Yes. During COVID, many surgeons and anesthetists started wearing OT scrubs from home to hospital and hospital to home also. What are the drawbacks? Is it advisable? the question itself suggests many things. Let us open the debate. Again, Dr. Sridevi, you have got a good insight in that.
Thank you, sir. Actually, it's not a normal practice to wear scrubs in public places or outside the hospital premises. In West, they have been doing it, but not in, particularly in US, but not in UK or in Europe. They've always said hygiene and professionalism, scrubs should be in theaters or to the hospital itself. And so we have in India. But of late, during the COVID pandemic, we've seen so many on the road going in scrubs. So is this a good practice? Definitely no. But then why were they doing it? Maybe because of the availability of the PPEs, the hospitals, they were all geared up for this pandemic. The government has been so liberal in giving us all these PPEs. Maybe they had PPE wearing this, so that's why they were wearing it. I'm not sure, but I definitely wouldn't agree on this practice, considering the respiratory pathogens would be on the linen and they need to be properly sterilized, cleaned and all. So I definitely wouldn't agree. But any other thoughts would be great. So, yeah.
But if people are doing it also.
Yes, yes, please.
Yeah, but if people are doing it also, I feel the moment they enter their own houses, they should be probably changing before they enter their own houses, otherwise they will infect their own family members. So that's definitely not to be followed.
Basically, it's a transfer of pathogens in both the directions, from home to the hospital and from hospital to the home. Maybe so. The better thing is to have at least change after entering the hospital. Yes. So you should wear scrubs, hospital dresses, OT dresses after entering the hospital, or particularly we as an anesthetist, if you are concerned.
So can
make a habit of changing dress when you enter the OT. It is for both the safety of patients as well as safety of your homes also. So we move on to very next question. What safety measures we should take to have safe practice, clinical and otherwise? Yes, the thing is that we already discussed the bypasses. Out of that, now we would like to formulate a few things for safe practice. In summarizingly, I would like to tell that make habit of PD anesthetic assessment, preferably. Yes, please. Anybody want to take? Preferably on the previous day of surgery, or if your previous visit to the hospital, make that patient available and assess. If not, at least 1 hour before the surgery, document it, enter it in the do pre-anesthetic assessment in the presence of patient's relative. See the file, see the investigations. They should feel that yes, you have seen it. You discuss a few things with them, identify yourself, that is one thing. Identify also risk involved or status, something they would like to ask for it to you, answer it. That is the first thing. First, so pre-anesthetic assessment is must and advisable. Second thing, consent. Proper anesthesia consent in colloquial language as circulated by our PPF guidelines is most important to follow. I think safety checklist prescribed by WHO, prescribed by our PPF's guidelines, or even NABH as per NABH checklist. But make a habit of doing checklist. To be very specific, without even checklist days, you should have check on SOAPME, again the thing which goes for crash induction or crash intubation. SOAP-ME, there is suction, oxygen, airway instruments, and all these things. SOAP-ME criteria should also apply the checklist. Check anesthesia machine, check airway instruments, monitors, and defibrillators, and then proceed for the check. Document what you have done. Document what you have done at PSC. You had document that you have done pre-anesthetic checkup, checklist, completed checklist. Document whatever you have given, whatever is done, chart it, and properly hand over to recovery staff. Have very much important is to have a designated recovery area, recovery room, maybe recovery HD unit, ICU, whatever you call it. But post-operative, post-anesthesia recovery area has to be designated one, labeled one, should have oxygen suction, resuscitation instruments and monitors at their disposal. That has saved me in one ongoing case against with me. So that is most important. Have a recovery setup. One anesthetist, one surgeon anesthetist group had been paid very much handsomely, has to pay very much handsomely till National Forum that they did not have a recovery room and patient had developed this complications, permanent complication. So recovery, designated recovery is most important to have in your safety areas, and avoid use of unnecessary use of mobile, exposure to world that you are not concentrating with the patient. So these are the safety things which I would like to add to our things. Very last thing I would like to add, a very controversial thing, but carry your own as a freelancer anesthetist. If you are working in one institute and you are well versed with it, it's not a problem. But if you are a moving freelancer anesthetist, moving to many places, have your one bag, your companion with you. Create your heaven. If you face any difficulty, if the particular instrument of that hospital is not working, you have your own standby, and that works better. So here with this, we are completing practically 40 minutes of our designated time, and I would like Dr. Pankaj Gupta to summarize the today's discussion.
Yes, please. I would like to mention one point. You mentioned that put the time of 1 hour before for the PAC. So the word of caution, in NABS there is right timing everywhere. So you must not be present at two places in the same time.
Yes.
Thank you.
Yeah, thank you, Dr. Asit sir. Thank you, Dr. All the speakers. We had a wonderful discussion on how to improve and make your practices very safe. Today, I feel safe anesthesia is all what we all are working towards in through the private practitioners forum. Private practice is a totally different ball game because it is a one-man show. We don't have proper PAC clinics. We many times our calls overlap. Surgeons take their own time. They start late. We have a lot of problems which only we know what we have to face in everyday practice. So through this forum, what we are trying to highlight is that please go through all the guidelines that now the National ISA has endorsed. Please follow every guidelines. Even today, I am aware that people are not following the proper guidelines, especially in the rural areas. Even today, I hear of stories where even basic voice machines are not there in small peripheral setups. So that's why I mean through this forum, what we are trying to highlight is that please follow all the guidelines that we have laid up and make yourself safe so that your future is safe. And that's what I feel. We have had a wonderful discussion on the whole thing. I should really thank Dr. Asit Vaishnav for spending so much time in talking and interacting and making proper guidelines to all of us how to have this discussion. And of course, Dr. Mahesh is always there. He's been very active in IST and IMA for the last so many years. It's always good to have. And of course, Kala, we all know, is very, very active everywhere. And I Kala. Sridevi, yes, I interacted a few times with her and I thought, let's have one private practitioner. I have still not met her. Vikram, fortunately, I have met a few times here and there. So that's why I feel I should really thank all of you from the bottom of my heart for having a wonderful discussion. And I hope that it goes around and everyone comes out with a positive message after listening to this panel discussion. Thank you, everyone.
Thank you so much.
Thank you.
Thank you, sir. Thank you, sir.
Good night,
everyone.
Thank you.
Thank you.
You can stop.
Yes, there are a few live questions. I will invite Dr. Rajiv Gupta.
Hello. I would like to ask one question. Like we were discussing about physician's reference. So many times they give their opinion, and sometimes they also write to be done in spinal or GA. Right. So my question is, how much medical legal liability do we have if he writes patient is fit for spinal anesthesia or he writes fit for GA? And if we write spinal and we do not give it spinal and something happens, how much medical legal liability do we have? Or on the contrary, if we write GA and we do not give GA, or if we give GA, suppose no. So, and if something happens, then what is the difference between the medical legal liabilities in both the cases?
Am I audible there?
Yeah.
Hello.
Yes, yes, you are audible.
Yeah, yeah. See, the physician is not supposed to be writing what to give. It is very clear. Inform your physician. There should not be mentioning anything about the mode of anesthesia. If it so happens, you have full right to tell the so-called physician to please come forward and give anesthesia if it's your job. It is your job to decide only the cardiopulmonary status of the patient.
See, my
and
question
not
is
give
not
an
this.
opinion on what anesthesia is to be given. This is very, very clear. Yeah.
My question is not this, but I am talking about documentation. If he documents spinal and if we give GA and something
So-
happens, number one.
Yeah, sure.
Number two, if he says GA and if we give GA and if something happens, then whose responsibility lies in this case, in these two scenarios?
See, first of all, you should not accept a statement from him. If he gives such a statement, please refer the patient back to him or ask him to change his notes. He is not supposed to decide on what anesthesia is to be given. That is our prerogative. There is no second question about that. Regarding the medico-legal implication that if he writes spinal and if he gives GA, he can also be in a soup and we also can be in a soup. So please refrain the physician from making his comment on what he should be writing. He should decide only on the cardiopulmonary status of the patient. That is all. Rest of it is our job to decide how risky the patient is going to be, whether it's ASA 1, ASA 2, ASA 5 or 6. He is not supposed to decide that. So medico-legally, both can be held responsible.
Sir, can I add to it?
Yeah.
When we give anesthesia, it is totally our responsibility for the anesthesia outcome. You should be able to defend that why you gave GA when the physician had given spinal or otherwise, whatever, and your actions are responsible. If the surgeon has if the physician, had suggested spinal and you give spinal when actually you think that GA would have been better, then you will land up in a bigger soup. So ignore his comments and do what is best, because you can defend yourself by doing what you believe in. You cannot defend yourself when you follow someone else. And it is very difficult to actually ask the patient to go back to the physician and get the opinion corrected. Next time onwards, obviously, we can ask him to correct, but same patient we cannot refer back. In private practice, it is very difficult. And I would suggest to do what we believe is best for the patient. Thank you.
See, I'll add to that. You can always have a failed spinal. You're doing a hernia, your spinal has failed. Are you going to not give GA if required? So what to give is our prerogative. Nothing to do. Physician has not supposed to comment on what is to be given. That is very, very clear.
That proposition we accept it, but in such instances, you can at least write down in your notes, in your assessment, that physician has suggested these things, but to my opinion, I am going for these things. That can also be done, giving the reasons in your document.
So educate your physicians is what my dictum will be.
That is different thing. That is different thing. So these are the various steps you can take. Dr. Virendra Sharma has to say something.
Regarding this discussion going on. Good afternoon all. See, if you have in written, this situation is almost in most of the hospitals, we ask for a chest physician reference or a cardiologist reference. Our intention is that we want to have an assessment of, say, suppose he might do a PFT or the cardiologist might do a echo, which might help us to know the cardiac status. But the problem is if he writes, for example, I'm giving a patient is severely asthmatic and the chest vision thinks it can easily be done in spinal. So he writes, do it in spinal. Now suppose in that case, severe spasm happens. So what I want to suggest is, as far as possible, discuss with that chest physician or cardiologist that please give a fresh opinion. Otherwise, both of us will be in problem. Because if there is a case, text-wise, wrong opinion. Nowhere in our text it's written that this technique is superior or that technique is superior. Ultimately, general anesthesia is considered to be the best option. So, considering the situation of the patient, his status of chest or cardiac, then decides. But that written document of that physician or cardiologist or whatever will land both of us in problem. So better it is try to avoid this documentation, have a discussion with him. See, I think he raised this a very valid thing. Rather than we writing there that as far as my knowledge and this is, I do not agree with him. That means in court case, we are going to contradict each other. And the judge or the advocate is going to see if both of them don't agree, there is something wrong. Either this technique was superior or that technique was superior. So better, because I'll quote one medical legal expert came to Lucknow and we were having a discussion. Sir, we have a time. Can I speak for a few minutes on that? One. So what happened? There was an orthopedic case operated by some orthopedic surgeon. Unfortunately, he did some plating or nailing something. The nail came out. The patient went to the another orthopedic surgeon and he said, where did you go? This fellow doesn't know anything. He did a plating. During plating, bleeding started. Situation became worse. Surgeon was smart enough. Anesthetist was resuscitating. He went to the attendants, told him, look, some anesthesia complications happened. Your patient is serious. Patient died. Right. FIR was lodged. They were arrested. Huge hue and cry. Advocate representing the doctors went to the court. Sir, how you can arrest and all? So the simple answer which the judge gave, your first surgeon was challenged by the second surgeon that he was a fool, he was doing kneeling. So that means one of them has done a wrong procedure. In the second operation, he is saying the anesthetic complication happened, so the patient died. Anesthetist is saying it was a surgeon complication. So one of you three is wrong that the patient died, so I cannot give a bail. Now rest, enjoy your stay in the jail. So you try to get what I'm trying to say. When we start contradicting each other, so the one word which he said, don't try to contradict your colleagues. This is very important, I'm saying. Let us not have any ego that I am the best judge and all. Whatever written document comes, it is going to be challenged in the court. So that was my suggestion. Rest, I think it was a very nice.
That was very valid, very valid advice. I would take that advice.
One question.
There's only one question and we have to finish. We have to go for general body meeting also.
Physician can say
Yeah, sure, no problem.
the physician can stamp it as ASA grade 1, 2, 3 or not.
Yeah, he is knowing the knowing the subject. He can. Many physicians have knowledge of ASA grading, and they can. It is an accepted method of teaching also in their curriculum. And very last, please. And Dr. Virendra Sharma has a message for PPF also. Please come to the mic. You have to go to mic.
I'm Dr. Vinod from Nashik. I'm doing my private practice 10 years. Many times you have to there is a call for us if surgeon is doing some procedure which is done under local anesthesia and some mishap happens at the time, or any labor procedure also is there, labor like that routine labor. PPH is there, patient is in shock. We have to go there, attend that. What is our medical legal consideration in that scenario? Do we need to write the notes? If something again goes wrong, are we responsible for that? Just for a good faith.
Yes. Whenever in good faith you have gone to help someone, by and large, you are not held responsible for that. But when you have taken part in resuscitation or any treatment, even with a good faith of helping them, you have to write it down. You have to be a part of the notes, and court will consider that you have gone for resuscitation purpose. You have no other benefits, and they usually see all these things. They usually all see all these things. And we have two medical legal experts over here also. We have two legal experts over here, Dr. Parakh and Dr. Mahesh Sinha. We can elaborate on more on this. Yes. Particularly this thing, what you anyway.
Thank you, sir. Very good afternoon to all. I'm Dr. Viren Sharma, National Coordinator of PPF, along with Dr. Pankaj Gupta. My message is, see, next year we are going to have Platinum Jubilee celebrations of ISA. So it's a very prestigious thing for us, and every program which is being run by ISA, they are planning to celebrate it. Celebrate in the sense by doing activities. Unfortunately, because of COVID, this PPF movement has also suffered a lot. We could only do certain activities online, but now as things are improving. So my request to all city and state chapters is, please plan PPF activities. ISA National is there to support you. We are taking budgetary provisions also to encourage. So this year, again, our this movement of PPF, and we should do something constructive for the benefit of our colleagues. So thank you all, and a very constructive session planned beautifully by Dr. Asid, Dr. Pankaj, and the rest of the panelists. I congratulate them for that. Unfortunately, I couldn't attend. So many obligations are there during Isacon, so I feel sorry for that. But please do plan activities right after the conclusion of this conference. A message from National Secretary will come to all of you. Thank you very much.
Sorry, we end the session with this. Thank you all.
Thank you.
ભાઈ મને કહી દો હું એટલું એટલું બતાવી દઉં શું બતાવવાનું
જો પેલા સેગમેન્ટલ પેનલ બતાવવાનું
હા એ તો હું સમજી ગઈ પછી કીટોડેક્સ વાળું કેટલું લખવાનું બોલે
બોલસ આપીએ અને ઇન્ફ્યુઝન માં લખી નાખજે ઇન્ફ્યુઝન આપણે જેટલા ચાલુ કરી દીધું લગભગ 12:30 કે 1 વાગે જેવું કર્યું તો હા 2 વાગે જઈએ
હેલો
Hello. Are we there? All?
હેલો
Hello.
Is everybody back? Sir?
Is everybody online, please? We'll start. What do you say?
Can we start our introduction, sir?
Yeah, can we please? Yeah. First of all of us decided to be present physically, but I seem to have lost the toss. So I'm the only one who's physically present to, be in this company. And thank you very much for, thanks a lot to Isacon for giving me an opportunity to share the platform with such august company. And we start with the very controversial topic of controversies in anesthesia. So may I request, for
Our next speaker person is Dr. Pradeep Bhatia. He has the topic of anticoagulants, which and when for safer anesthesia given.
Okay.
Please.
Welcome, Dr. Bhatia, please. Please.
Good afternoon, ladies and gentlemen. First of all, I would like to thank the organizers for inviting me to this conference. And I will be speaking on anticoagulants, which and when for safe anesthesia practice. So anticoagulants are generally prescribed to treat or to prevent blood clot formation in high-risk patients to prevent serious conditions like stroke and heart attack. They are generally prescribed for DVTs, atrial fibrillation, acute coronary syndrome, mechanical heart valve, and ischemic stroke. There are different types of coagulant available in the market, and each one works at a different level on the blood coagulation pathway. So it's always challenging to manage a patient who is taking anticoagulants and who is to undergo some surgical procedure, because patient is on anticoagulant and the risk of bleeding is very high intraoperatively. And if you interrupt the anticoagulant, then the risk of thromboembolism will be there. So if the patient bleeds excessively during the procedure, the anticoagulant may have to be stopped for a longer period, further increasing the risk of thromboembolism. So you have to maintain a balance. between reducing the risk of thromboembolism and preventing excessive bleeding by managing these patients. And commonly used anticoagulants are unfractionated heparin, low molecular weight heparin, vitamin K antagonists like warfarin, and a direct oral anticoagulant, in which direct thrombin inhibitor is dabigatran and the 10A inhibitors are fondaparinux and rivaroxaban. So, what is the approach to decision making? You have to assess the thrombotic and bleeding risks, which may vary depending upon the individual circumstances. Data from RCTs and well-designed are not available, which can guide us for practice in different settings. And complete resolution of anticoagulant effect is not always known, particularly if the patient is taking newer oral anticoagulants. The approach that we are going to discuss is based more on expert opinion rather than the data, and it is not a substitute for clinical judgment about the perioperative anticoagulation management. So what should be the approach? First of all, estimate the thromboembolic risk in the patient, then estimate the bleeding risk, determine the timing of anticoagulant interruption, and whether to use bridging anticoagulation or not. How to estimate the thromboembolic risk? In the patients with high thromboembolism risk, minimize the period without anticoagulation. So it should be continued as long as possible. Patients with atrial fibrillation, prosthetic heart valve, recent arterial or venous thromboembolism within last 3 months, they are at a high. If the patient had recent stroke or pulmonary embolism, the surgery should be delayed if possible till the risk returns to the baseline. The risk classification is largely based on indirect evidences, and clinical judgment, I again repeat, is more important in risk assessment. Risk stratification scoring system. These two scoring systems, they involve the components like congestive heart failure, hypertension, age, diabetes, and stroke, transient ischemic stroke. And then a modification of the scoring system also includes vascular disease, age 65 to 74 years, and the female sex. So patients with mechanical heart valve, they will, if the patient has any mitral valve processes, he will be at a high risk. If any case ball or tilting disc aortic type of valve is there, then he is at high risk. And in addition to it, if the patient has recent within the last 6 months, then he is at a high thromboembolic risk. Similarly, the patient with mechanical heart valve are at moderate risk if he had a bileaflet aortic valve prosthesis and one of the risk factors that I have already described in the risk factors. And the patient will be at a low risk if it is valve prosthesis without any additional risk like diabetes, hypertension, and old age and previous stroke. So next, the patient of atrial fibrillation will be at a higher thrombotic risk if the scoring system is high and patient had recent within 3 months of stroke or transient ischemic attack. The patient will be at a moderate thrombotic risk if the risk scoring is moderate from 3 to 4, and he will be at a lower risk if the risk score is low. Now the patient with venous thromboembolism who had recent this attack within 3 months and severe thrombophilia like protein C or S deficiency, antithrombin 3 or antiphospholipid antibodies, they will be at a higher thrombotic risk. Venous thromboembolism within the past 3 to 12 months with non-severe thrombophilia, they will be at a moderate risk. And if the venous thromboembolism has occurred more than 12 months back, then he is at a lower thrombotic risk. Now you can see that with the scoring system, as the risk score increases, the risk of stroke and thromboembolism, they also increase. And this is up to 1 year follow-up. So after assessing the thromboembolic risk, estimate the bleeding risk. A higher bleeding risk requires longer period of anticoagulant interruption, and bleeding risk is determined by the type and urgency of surgery. So patients with comorbidities like kidney disease and liver disease, they also contribute to the risk. And procedures with lower bleeding risk like dental extraction, minor skin surgery, they can be performed without interruption of anticoagulant. And how do you define major bleeding? It is generally defined as bleeding that is fatal or involves a site like intracranial, requires surgery to correct, lowers hemoglobin by more than 2 grams, or requires more than 2 peg cell transfusion. But different definitions have been used by different clinicians. So this is a list of procedures associated with high bleeding during the process, which is up to 2 to 4% in the next 2 days. And the list includes major surgery of more than 45 minutes duration, abdominal aortic aneurysm repair, coronary artery bypass surgery, and foot and head shoulder surgery, heart valve replacement, hip replacement, kidney biopsy, knee replacement, laminectomy, neurosurgical procedures, and polypectomy, transurethral prostate, and vascular digital surgery. The procedure at low bleeding risk, that is less than 2%, involves hernia surgery, hysterectomy, arthroscopy, axillary lymph node dissection, carpal tunnel, bronchoscopy, cholecystectomy, hemorrhoid, hydrocele, etc. So once you have determined the thromboembolic and bleeding risk, then decide whether anticoagulant should be stopped or should be continued. The data comparing the relative benefits of stopping or continuing the anticoagulants are limited, and the decision to balance the risk of thromboembolism will be taken on case-to-case basis. So clinical judgment is important, though there are some guidelines which are mostly expert opinions. So when to interrupt? An overview. So if the surgical bleeding risk is high, then it should be interrupted. Then if the thromboembolic event risk is low, then it can be stopped preoperatively. And if the risk of thromboembolism is high, then duration of interruption should be shorter and bridging therapy should be included. And when anticoagulant can be continued, if the bleeding risk is low, preoperatively, like cataract surgery, dental procedure, but mind you that multiple tooth extraction can be a high bleeding risk. Then cutaneous procedures are also associated with low bleeding risk. And this pacemaker insertion, cardiovascular defibrillator insertion, endovascular procedure like angioplasty, catheter ablation, arthrectomy, etc. are associated with low bleeding risk. So if the patient is taking warfarin and you have decided to continue with warfarin, you have to monitor INR, which should not be above the therapeutic range at the time of the procedure. So other practices to reduce bleeding should be also used, like routine perioperative use of NSAIDs and aspirin should in the immediate postoperative period. Thromboprophylaxis should be started to reduce the risk of thromboembolism. Can you use temporary inferior vena cava filters? They are indicated in patients with very recent, up to 1 month of acute venous thromboembolism who require interruption of anticoagulant for a major surgery, in which therapeutic dose of anticoagulation will need to be delayed for more than 12 hours postoperatively. Then IVC filters are indicated, but they are not indicated if the patient is to undergo minor procedures, if the venous thromboembolism has occurred for more than a month back, and a clinical situation like prior perioperative venous thromboembolism, high-risk thrombophilia, they are not routine indication for use of IVC filters. Then determine the timing of anticoagulant interruption. It depends upon the specific agent, their half-life, their duration of action. Warfarin requires early discontinuation compared to the oral anticoagulant, and the patient factor should also be considered, like reduced kidney or liver function. The anticoagulant should be stopped and a sufficient time should be given to allow anticoagulant effect to resolve. For warfarin, monitor INR to check if the anticoagulant effect has resolved. For oral anticoagulant, well-validated and easily accessible tests are not available, and data to guide the timing of anticoagulant interruption, particularly for oral anticoagulants, and our practice is mainly based on expert opinion. So if the patient is receiving anticoagulant, then that is how you decide. If the patient is taking oral anticoagulant, then assess the bleeding risk. If the bleeding risk is low, then omit anticoagulant just on the day of surgery, that is interruption of 1 day only. Bleeding risk is low to moderate, then anticoagulant should be omitted 1 day before surgery, so total interruption would be only 2 days. And if the bleeding risk is high, then anticoagulant should be omitted 2 days prior to surgery and should be restarted after 2 days, so total interruption would be 4 days. So if the patient is taking anticoagulant like warfarin, then if the risk of bleeding is minimal, then don't interrupt. You can continue with warfarin, just like skin procedures or tooth extraction. But if the risk of bleeding is moderate to high, then assess the thromboembolic risk. If thromboembolic risk is low to moderate, then warfarin can be interrupted without bridging, but if the risk of thromboembolism is high, then bridging is required. So, for most of the patients, anticoagulant bridging is not required because it increases the risk of bleeding without reducing the rate of thromboembolism. And bridging should be reserved for patients with high or very high risk of thromboembolism on warfarin, like recent stroke prior to within 3 months, mechanical heart valve, and high risk scores, previous thromboembolism during interruption of chronic anticoagulation, patients who cannot take oral medication for prolonged period, like postoperative ileus. So, what are the drugs that we use for bridging? Low molecular weight heparin, they are convenient to use. Generally, they don't require monitoring. Intravenous unfractionated heparin, they can be rapidly reversed with protamine, and it is a good alternative. Particularly if the patient is having impaired kidney functions or patient is on hemodialysis, then the dose modification of unfractionated heparin is not required, so it can be preferred. We don't have any data of using oral anticoagulant as bridging agent, so they should not be used. So when the bridging should start? So bridging, if the patient is on warfarin, the bridging should start 3 days before the planned procedure, that is 2 days after stopping warfarin, which is, we know that is stopped for 5 days prior to surgery. And when PTINR started to drop below therapeutic range, then you start the bridging anticoagulant. It is not usually recommended to bridge for oral anticoagulant because the duration required for the drug to be withheld is short, and clinical effect initiation. So, if heavy urgent reversal of warfarin is required, that is within 1 or 2 days, then warfarin is withheld and vitamin K 2.5 to 5 milligram orally or IV is given. But for immediate reversal, like for emergency surgery or active bleeding, you can give fluorothrombin complex concentrate or fresh frozen plasma along with vitamin K. And when to resume anticoagulant, warfarin generally is resumed on the same postoperative day because it has already been stopped for 5 days. Surgery is done, and then you can start on the same day after surgery if there is no active bleeding and drains are clear. And heparin is discontinued when INR reaches the therapeutic range. Now coming to neuraxial anesthesia. Removed, and if INR is 1.5 to 3, then monitoring the neurological status, and if INR is more than 3, then a dose is withheld, and if it is less than 1.5, then catheter should be removed. If the patient is on unfractionated heparin, then it is stopped 4 to 6 hours prior to neuraxial anesthesia, and we can monitor APTT, and it can be restarted 1 hour after catheter placement or catheter removal. For low doses, prophylactic doses subcutaneous 5,000 to 3 times a day, 4 to 6 hours. This it is a normal dose of normal interval before neuraxial anesthesia, which can be started 1 hour after the placement. But if the patient is getting moderate doses or therapeutic doses of unfractionated heparin, then it should be withheld 12 to 24 hours prior to the neuraxial anesthesia. And one more thing is important, that if the patient has received heparin for more than 4 days, then as there is risk of heparin-induced thrombocytopenia. So if the patient is receiving low molecular weight heparin and prophylactic doses, then it should be stopped 12 hours prior to neuraxial anesthesia. And if the patient is getting therapeutic doses, then it should be stopped more than 24 hours prior to the. And then when the next dose after placement or removal of catheter can be started for after more than 4 hours, the catheter removal or it can be started, but it should be delayed if the placement is traumatic. Anti-10A level, they are not predictive of the risk of bleeding, and again the risk of heparin-induced thrombocytopenia should be kept in mind. So for fondaparinux, there are no AFRA guidelines, but the European guidelines are that fondaparinux should be stopped 36 to 42 hours prior to the neuraxial anesthesia. And after 6 hours of the catheter placement or removal, it should be started. Okay, but one should not administer when the catheter is in place for the pericarditis. Now coming to oral anticoagulants, direct thrombin inhibitor is dabigatran, and 10A inhibitors are apixaban and rivaroxaban. The indications are for which these drugs are prescribed: the hip and knee replacement surgery, secondary prevention of management of DVT, pulmonary embolism, stroke, and for embolism prevention in atrial fibrillation. Only dabigatran has a reversal agent in idarucizumab, but apixaban and rivaroxaban, they don't have any reversal agent. So as it has already been discussed, then if the risk of bleeding is high, then this oral anticoagulant should be stopped 2 days prior to the surgery. On the day of surgery, should total 4 days interruption is required. But if the bleeding risk is low, then just 1 day prior to surgery, and on the day of surgery, then 2 days of interruption is required. And if there is no bleeding post-operatively, then it can be started again. So these recommendations are if the kidney functions are normal or creatinine clearance is above 30 for anti-10A inhibitors. But if the creatinine clearance is less than 50, then dabigatran dose should be omitted for 1 more day. So for rivaroxaban and apixaban, both these drugs should be stopped 3 days prior to neuraxial block, and anti-10A level can be assessed. And after removal of catheter, 6 hours post removal, again the doses can be started. But if the patient is getting dabigatran, then dose adjustment according to creatinine clearance is important, and the next dose can be given after 6 hours of catheter removal. So coming back to the basic question which we had started with, anticoagulants which and when for safe anesthesia practice. So reversible anticoagulants are unfractionated heparin, warfarin, dabigatran. All these 3 drugs, they have their some antidote. Drugs with definitive endpoints are unfractionated heparin, warfarin. You can monitor their efficacy or reversal of the effect with APRT or with INR. Drugs with rapid onset and recovery are unfractionated heparin, low molecular weight heparin, and oral anticoagulants. Ease of administration is oral anticoagulant. And the drugs which are convenient to use and no monitoring is required are oral and low molecular weight heparin. You don't need to monitor their effect. And drug anticoagulant which are doses are unaffected by the renal dysfunction and dialysis are unfractionated heparin. So that was all about the anticoagulant. Thank you.
Hello. Hello. Can you hear me, sir?
Yeah, now I can.
Can you throw some light on antiplatelets before surgery, their role, especially regarding the neuroaxial anesthesia? You know?
Yeah, I have not deliberately covered antiplatelet because that was not the topic. But then low dose aspirin is not a contraindication for neuraxial block. If patient is getting 75 to 150 milligram of aspirin, it is not a contraindication. Platelet count estimation is of no value because it causes platelet dysfunction, not the counts. And clopidogrel, yes, it should be stopped for at least 4 to 5 days prior to giving neuraxial anesthesia. And a simple bedside test could be bleeding time, which may not be very accurate, but it will give some idea of platelet dysfunction. If it is prolonged, then it's better not to go for this regional anesthesia.
Thank you very much. Any other question, please? Yep.
therapy while stopping dual antiplatelet drug as an anticoagulant. So when patient is having drug-eluting stent and we are going for any semi-elective surgery, then is there any role of anticoagulant therapy or bridging therapy while stopping that dual antiplatelet drug?
So thanks for the question. So it depends when was the drug-eluting stent was given. I mean, if it is more than a year, then it is not a problem. There is no need for any bridging therapy. Normally, these are anti-platelet, not the anticoagulant. So normally it is not required, and all the elective procedures should be delayed for at least 1 year. But in case it is a semi-emergency type of a thing, then yes, it's practiced most often that if you stop antiplatelet, then patients are taken on heparin. Yes, though the mechanism of action is altogether different of both the drugs, but it is still practiced to prevent the thrombosis, stent thrombosis. Yes.
Thank you.
Well, thank you, Dr. Bhatia. It's been a very exhaustive, you covered in a short time, probably very vast subject, very well presented. Thank you very much, please.
Thank you, sir. Thank you.
May we have the next speaker, please? Well, I'm not sure if Dr. Palta is speaking or not.
Sir, I'm speaking. My video is recorded.
Okay. Thank you very much. Hello, Sanjeev. How are you?
All fine, sir. All fine. Thank you, sir. Thank you. Good afternoon.
Good afternoon and welcome. And could we have his video, please?
Yes, sir.
Good afternoon, everybody. First of all, I must thank the organizers of this vibrant state for giving me this opportunity to present my lecture. And my topic is point of care ultrasound focus, unnecessary gadgetry or evidence-based medicine. And I am Dr. Sanjeev Palta, Professor Anesthesia from GMCH, Chandigarh. Point of care testing. With the ever-changing landscape of healthcare delivery, significant efforts have been made to improve the speed and accuracy of diagnostic testing, particularly by using point-of-care testing. The aim is to minimize the delay between onset of symptoms and initiation of definitive therapy. Point-of-care testing has been shown to achieve these goals, leading to improved operational efficiency and ultimately better patient outcome. So what is the definition? Point-of-care ultrasound refers to the use of ultrasonography at the patient's bedside for diagnostic and therapeutic purposes. It is available to physician. It answers specific clinical questions that narrow differentials, guide clinical therapy, and direct the consultations and disposition. The advent of smaller, more portable machines combined with improved picture quality has brought ultrasound out of the radiology department and onto the wards, operation theaters, and intensive care units. So is it a gadgetry or evidence? In 2002, the National Institute for Clinical Excellence mandated the use of ultrasound in central venous catheter insertion, followed by a National Patient Safety Agency report in 2008 requiring it for pleural procedures, both of which were compelling evidence for increased safety with ultrasound-guided techniques. The Royal College of Emergency Medicine introduced focus as a mandatory component of the emergency medicine curriculum in 2010, with the respiratory medicine introducing the pleural ultrasound into their curriculum a few years later. So let's discuss the focus in various scenarios. When we talk about the pleural procedures, as early as 1990, it was shown in a prospective study by Grogan et al. In 52 patients that ultrasound guidance versus clinical guidance reduced the incidence of pneumothorax, dry tap, or inadequate tap from 14 out of 13 to 0 out of 19 patients. And this was confirmed by a large retrospective cohort study published by Raptopoulos et al. In 1991 concerning 342 patients, which showed a reduction in rates of pneumothorax from 18% to 3% with ultrasound guidance. The accuracy of clinical examination versus ultrasound guidance for determining a safe procedure site has been assessed in a prospective comparative study of 67 patients, and ultrasound increased the rate of accurate sites by 26%. So overall, the evidence and guidance are compelling that ultrasound guidance, which in many cases will be focused, is mandatorily prior to pleural procedures. Let's talk about the respiratory failure. It was traditionally thought that ultrasound as a diagnostic tool for the assessment of respiratory failure would be of limited value. Why? Due to the aeration of lung interacting with the ultrasound beam and obliterating the useful images. Significant number of pathological lung conditions replace the aerated lung with fluids like water, pus, blood. We can have a useful clinical information by examining the lung with ultrasound. So many diagnoses will be through understanding the generation and distribution of common sonographic artifacts, and this understanding has led to a revolution in bedside lung ultrasound for respiratory failure. The seminal paper in this regard was published in 2008 by Lichtenstein and Mazai, detailing the bedside lung ultrasound in emergency, known more famously as a blue protocol. There were a number of different profiles generated for each common diagnosis, and individually they were not especially sensitive, but their specificity was very high. Combining these profiles gave an overall diagnostic accuracy of 90.5%, which is significantly better than both auscultation and chest radiography, and it approaches close to that of CT. This is the diagnostic accuracy of the blue protocol in respiratory failure. The overall diagnostic accuracy in all these 5 conditions of cardiogenic edema, COPD, pulmonary embolism, pneumothorax, and pneumonia combined together reaches more than 90%. A blinded observational evaluation of focus for respiratory failure patients admitted from a single emergency department in Italy has been published by Zanobatti et al. Performance of focus-guided diagnosis versus traditional techniques for both time to diagnosis and concordance between the diagnosis in 2,683 patients was tested. Focus significantly reduced the time to diagnosis from 186 minutes to 24 minutes and performed as well as clinical examination plus chest X-ray for diagnosing various conditions like acute coronary syndrome, pneumonia, pleural effusion, pericardial effusion, pneumothorax, and dyspnea from other causes. A comparison from Denmark of 320 and 4 emergency department patients with respiratory symptoms showed that focus accuracy by 24.3% at 4 hours versus usual care. And the diagnostic accuracy of lung ultrasound in adult patients with pneumonia has been confirmed by a 2014 meta-analysis also, giving the sensitivity and specificity of about 90%. And this was published in Respiratory Medicine in 2014. These are certain pictures in which, starting from the clockwise from the left, this is a normal lung, and then you can see A lines, then B lines, and on the right side, the uppermost picture, which is showing you the artifacts, and this shows some kind of this is a large, you can see pleural effusion present over here, and this is shred sign, which is basically related to consolidation in the lung. Let's talk about the heart failure now. The diagnosis and treatment of acute heart failure is another area where lung ultrasound has shown significant promise. The addition of lung ultrasound to traditional management has shown improved diagnostic accuracy in 2 large observational studies by Russell and Pivetta. These and other data have led to the European Society of Cardiology Acute Cardiovascular Care Association acknowledging the role of lung ultrasound alongside echocardiography in the diagnosis of acute heart failure in 2017, and similar recommendations also came from the Heart Failure Association of the European Society of Cardiology in 2015. But yes, I agree, all is not gold. When we talk about the abdominal ultrasound, the fast examination has been commonplace within the emergency department for at least the last decade and has had a clear-cut role to play in the management of trauma patients. There is, however, an increasing recognition of the limitations of this scan, including its low sensitivity and reliability of negative results, and it seems likely that increasing availability of CT will probably negate its role further. And it's supplemented with a recent Cochrane review, which failed to demonstrate any benefit of fast scanning in abdominal or multiple blunt trauma patients, potentially limiting its future utilization in this cohort of patients. But there is still an evidence from an observational cohort study of approximately 70,000 patients undergoing paracentesis that ultrasound reduces the bleeding complication rate by 68%. A further study involving 100 patients comparing ultrasound guided versus clinical guided paracentesis showed a significantly improved success rate from 65% to 95%. Let's talk about cardiac arrest. The largest study of focus in cardiac arrest was a non-randomized prospective protocol-driven study across 20 centers in the USA and Canada. They took 793 patients in non-shockable cardiac arrest and performed ultrasound at the beginning and end of the resuscitation process. Patients were analyzed according to the presence or absence of sonographic cardiac activity. 1/3 of the patients, that is 33%, they were found to have cardiac activity on ultrasound at the point of cardiac arrest. And this was associated with an increased rate of return of spontaneous circulation, which was 51% achieved in this group, and importantly, a significantly increased survival to hospital discharge, which was 3.8% versus 0.6%. The absence of cardiac activity was associated with a significant reduction in return of spontaneous circulation, which 14.3%, and a very poor survival to hospital discharge rate. Hence, focus during cardiac arrest could have a cohort of patients in whom the prognosis was exceptionally poor and which may help influence the decision to continue or not. Where the etiology of cardiac arrest was found to be pericardial tamponade, the survival to discharge in the focus group increased to 15.4%. Let's talk about focused echocardiogram. Randomized controlled trial involving 184 emergency department patients with undifferentiated hypotension was published in 2004, and it showed that immediate goal-directed ultrasound increased the rate of correct diagnosis of shock etiology from 50% to 80%, and the average scan time was 5.8 minutes. In 2010, the RUSH protocol was published. This is rapid ultrasound in shock and hypotension. This combined echocardiography, lung ultrasound, inferior vena cava, aorta, pleura, and peritoneal windows, and it can help in discriminating between hypovolemic, obstructive, cardiogenic, and distributive shock. The evidence supporting the use of focused echocardiography in shock is comprehensive and has been synthesized into a consensus document endorsed by American Society of Echocardiography and the British Society for Echocardiography. Let's talk about a new term, which is P-focus, and this is perioperative applications of focus. And you can see by this chart, which I'm telling over here, there are so many conditions from preoperative to intraoperative to postoperative, to volume status, to pulmonary, airway, abdominal, pelvic, and so many protocols you can see on the right side, which shows of perioperative application of focus and accessibility to the people over here, and thereby easing the life of anesthesiologist. I would be wrong if I do not say that ultrasound is basically eyes for anesthesiologist. Let's talk about the gastric ultrasound. Perioperative point of care ultrasound can determine the presence of the contents, which may be solid or liquid, within the gastric antrum, and this technique has been validated as a means to quantify the volume of liquids contained in the stomach. The utility of gastric ultrasound has been demonstrated in a variety of perioperative settings and patient populations, which include pregnant patients, obese, and pediatric patients also. And currently, this modality is most often used to help risk stratify patients and not to alter nil per oral guidelines. I'm taking a little liberty about telling something about the airway also over here, though it may not fall into focus, but with the advent of ultrasound coming and penetrating into our OTs, this is something like, very easy, and if we may define it under point of care. A meta-analysis involving 17 studies by Gottlieb et al. Demonstrated that airway ultrasound performed successful endotracheal intubation with 98.7% sensitivity and 97.1% specificity in a mean time of 13 seconds by the anesthesiologist. The use of ultrasound to confirm endotracheal intubation is useful in clinical situations where patient presentation involves low and tidal carbon dioxide. A systemic review demonstrated that physicians who utilized vascular ultrasound were able to correctly diagnose DVT with 96.1% sensitivity and 96.8% specificity. What are used in ICU care? Needless to say, so many guidelines published, ultrasound guided central venous catheter placement, and can it make the catheter placement safer? guidelines for the appropriate use of bedside journal and cardiac US from the American College of Critical Care Medicine gave a strong recommendation for the general use of ultrasound for central venous access in real-time technique using a short access approach. Regarding the site, they gave a recommendation for IJV and the femoral veil, but subclavian veil. This diagram just illustrates the way the ultrasound can be used in every condition available over here, and all these conditions we can utilize the ultrasound in our ICU care, in our emergency care, or even in our OT cares, also from an cardiovascular, vascular, anywhere it can be used. So concluding my article, and point of care ultrasound is rapidly gaining an evidence base to support its use and an aid to traditional management techniques in the acutely unwell adult patients, leading to a better patient outcome. There is a body of evidence showing that it improves safety during medical procedures and it can aid diagnostic accuracy in a number of medical presentations. Evidence highlights an improved diagnostic accuracy and a reduced time to diagnosis. In 2016, the Society for Acute Medicine has also published the first focused curriculum within the UK designed for physicians, and it is known as FAMOUS, Focused Acute Medicine Ultrasound. And it covers a number of areas considered to be important in the management of the acutely unwell patient. So where are we lacking as anesthesiologists? The anesthesiologists are supported by published guidelines when they perform transesophageal echocardiography and use ultrasound for procedural guidelines. However, aside from these applications, anesthesiologists' use of point of care ultrasound has not previously been backed by professional society guidelines. Unfortunately, no such guidance has been available from an anesthesia specific society. So not surprisingly, the utilization and teaching of diagnostic point of care ultrasound among anesthesiologists remain highly variable. So where is the future now? See, these devices are now extremely portable, have intuitive interfaces and rapidly integrating methods of automation or semi-automation. Additionally, the integration of artificial intelligence is identification. So with all these innovations, the number of specialties utilizing point of care ultrasound and the frequency with which point of care ultrasound exams are being performed are dramatically increasing. So we have a hope because in 2015, a comprehensive whole body educational curriculum for anesthesiologists termed the focused perioperative risk evaluation sonography involving gastro-abdominal, hemodynamic and transthoracic ultrasound exam was published, known by the name of Foresight, and it is a useful tool for perioperative point of care ultrasound. Thank you very much, and I just hope that I was able to convince you people that it is a necessary gadget and has got a strong evidence. Thank you very much once again to the organizers for this vibrant parade. Jai Hind.
Hello.
Yes,
Yeah.
ma'am.
Our next, sir, can we go further? Yes. Good afternoon, everyone.
Can we get to Dr. Palta if he's available? I mean, this was a recorded thing. If he's available online.
Right, sir. I'm there.
Yeah. Sanjeev, you have done a lot of work on focus that I know, you know. My question is for basically the audience that in India, the laws for use of ultrasound are very strict, very stringent, especially in our states, inside that we are working in.
Right, sir.
Apart from the legal hassles that one has to encounter to use ultrasound in theater and critical care, you know, are there any specific prerequisites for training for anesthesiologists also for use of ultrasound for these purposes?
Sir, am I audible, sir? Am I audible, Ji?
Hello.
Sir, am I audible?
Yes.
As far as I can let you know about the experience about GMCH or PGI, sir, all the ultrasound machines which come to the hospital, they are registered with the BNDT Act, sir.
So that's what I'm saying. Yeah.
Yes. And then we have to submit our data, sir, our MD degrees. Once they approve it, only then we can use it. And wheresoever we are going to use these ultrasound machines, maybe in an ICU or maybe in a I mean, put a label over there outside the ICU that sex determination is not done at this place. So, but
Um,
there is no way any bar for anesthesiologists to use the ultrasound as a point of care or otherwise also in the perioperative care.
Well, my question was, do they need any, training or anything, any exposure to this before using it, legally speaking?
That is what I told in my slide also, that not enough guidelines are available, not enough protocols, programs are available. Only that in the last decade that ultrasound guided workshops are happening in India, specifically for anesthesiologists. And I would say we to encourage everybody to please go and attend at wheresoever, because practically in every medical college now, at least anesthesia department do have 1 or 2 ultrasound machines. But of course, I can agree that without having a proper structured training program, this machine is of no use and can produce more harm to the person.
Yeah, that was my point actually.
Yes.
Any other question? And Ma'am Janeja, please, can you take over, please? Yeah.
Yes,
sure.
yes, sir. Good afternoon, everybody. Our next speaker person is Dr. Shweta Balhar. She is from USA, and her topic is optimizing preoperative investigations and what is the rationale of it. Thank you.
Hello, everybody. My name is Shweta Yamulgolhar. It's an absolute pleasure and an incredible honor to be speaking at this esteemed conference. Today, I'll be speaking on optimizing preoperative testing and what is the rationale for this. So, preoperative evaluation is an inseparable part of anesthesia. A good preoperative evaluation reduces perioperative morbidity and mortality, reduces unnecessary consultations and case cancellations, and reduces hospital length of stay. Preoperative testing is an important part of preoperative evaluation. What is the rationale for preoperative testing? Preoperative testing helps us identify and optimize clinical conditions, help us direct anesthesia choices, guides postoperative management and risk stratification, obtain a baseline where isolated values may not be meaningful, and also at times reduces medical legal liabilities. However, these days, unfortunately, preoperative testing is more protocol-based than tailored to any particular patient for clinical evaluation. Preoperative tests are basically of two kinds. There's routine, which is not indicated for any particular reason, but just done on a routine basis, whereas indicated or diagnostic given to identify a particular cause or see how controlled the conditions are. Preoperative testing should ideally be guided by clinical status of the patient after a physical examination, ruling out comorbidities and taking into consideration. In early 1940s, Adam and Lundy proposed preoperative examination and suggested that testing should be used to reduce perioperative risk, which was based on a sound clinical concept. Between 1940s and 60s, however, preoperative tests were expensive and physical assessment therefore formed the crux of evaluation. Post 1960, there was a very rapid development of cheaper, quicker biochemical tests, which led to an exponential rise in preoperative testing. By mid 1980s, there were people who started questioning this practice, and then Kaplan et al. Did a retrospective review of around 2,000 patients' charts and found that 60% of these patients had unindicated labs and only 0.22% abnormal results of the abnormal results actually influenced the preoperative management. Thereafter, there were several studies done in the to find the same information. Most of these are retrospective and some prospective randomized controlled trials. And these basically ended up giving these conclusions that of a very small percentage of the ordered tests are actually ever indicated. Of the ordered tests, very small percentage are abnormal. And even smaller percentage, literally most of the times it's less than 1% of those tests actually changed any kind of operative or perioperative management. Another thing it highlighted was that physicians are poor at evaluating the preoperative tests that they order. Roizen and colleagues did evaluated some patients with posted for elective surgery and found that around only 10%, 10 of 160 patients with abnormal test results were treated for such abnormalities. So these patients ended up not even being treated, most of these patients with abnormal tests. Other conclusions were like normal preoperative tests really did not reduce postoperative complications. There was no difference in adverse events between tested and untested patients. And Hawkes et al. Saw that even for symptomatic cardiac patients, low adherence to ACC AHA guidelines for perioperative workup really did not worsen the outcomes. The studies that were conducted in India were by Chanda et al. They studied around 1,200 ASA1 patients and found that 32.5% patients had abnormal CBC, 11% had abnormal chest X-ray, 9% abnormal EKG, and 8.5% had abnormal LFTs. However, there was no change in outcomes. But Keshavan et al. Also studied these patients, their ASA1 and 2 for elective surgeries, and they compared the preoperative testing ordered according to NICE guidelines, which we'll be discussing afterwards, whether they were indicated or unindicated tests. And for that, 52% of these patients had unindicated tests. And of these, 1.3% of the tests were actually abnormal, which did not influence the management at all. Karim et al. In an observational study also compared the current pre-anesthesia testing practices and found that 83% patients were exposed to at least one unindicated test. What are other implications? Financial burden. So the healthcare expenditures in US come up to like a total of $3.2 trillion in 2015, around 17.8% of the national GDP. 7 billion alone are spent on laboratory tests, and 16 to 40% of these tests are completely unnecessary. Considering the advancement between procedures and evaluation and management services that has occurred between 2000 and 2010, which was around 30%, there has been an exponential rise in the testing and diagnostic tests as much as by 85% during the same period. Keshavan et al. Studied 15 patients and found that 52% of these patients had unindicated tests, as we discussed before. And looking at the financial implications of that, they found that as many as 1,71,358 rupees were spent on these unindicated tests. And most of these tests were echocardiograms and EKGs, around more than 50% of these. This is a large amount considering that it is not providing any value for your care. What exactly are abnormal tests? About 5% of healthy abnormal individuals may have abnormal tests, but may actually be normal for that particular patient. So when a lab value is given to us, it is basically 2 standard deviations ideally from the midline, which covers around 95% of these patients, which essentially means that 1 of every 6 tests, which is abnormal, is essentially normal for the patient, and more so for diseases which have low prevalence. So whatever we think are abnormal tests may not even be abnormal at all. How about healthcare resources? It is an emerging concept of healthcare value, which is very important. PricewaterhouseCoopers Health Research Institute identified around 1.2 trillion in healthcare spending waste. And most of it has been because of overtreatment and excessive use of diagnostic tests. It is understood and it is well known now that more cost-effective healthcare system is to cut the waste, and especially for some countries like India, we're resource poor, and cutting waste seems very appropriate. It is so appropriate that the accreditation societies in US have included that as one of the 7 competencies that training in physicians should be taught and should understand. How about medical legal liabilities? We do not have any official statistics for India. However, American Society of Anesthesiologists closed claims has never identified preoperative testing as an issue that has led to a significant lawsuit. So has Columbia Anesthesia Malpractice Registry, FEPASDE. They do not identify pre-anesthetic testing as a high-risk situation. Of the 10,500 closed claims, 4 claims were actually paid by anesthesiologists regarding preoperative testing, and that has been for pregnancy testing, where actually pregnancy testing was done, but the anesthesiologist failed to check to see if the patient was actually pregnant, and that resulted in pregnancy loss. Meta-analysis were done by Callan et al., and they found that around 6.8 to 62% of abnormal lab tests, as well as 1 to 35% of abnormal radiological tests were never reviewed by anesthesiologists. It does seem to be more risky to order tests and not evaluate or check them rather than not ordering them at all. So in order to help us with this situation where there are so many tests available and we do not know which ones to order, we have some guidelines and recommendations in place by some authorities. The first one is ASA Task Force recommendation for preoperative evaluation. It is a practice advice lines. And Choosing Wisely initiative is the American Board of Internal Medicine associated initiative, which is being used in a lot of countries all over the world. We'll be discussing some of these now. Recommendations by ASA Task Force on preoperative evaluation was the latest of which is in 2012. They advise is based on clinical evidence, whichever grade or level that is available by practicing anesthesiologist. They mention and suggest that routine tests should not be ordered and should be selective based on clinical findings. They do not at present have enough evidence for specific parameters or rules, but some of the guidelines that they give are EKG should not be ordered based on age recommendations unless the patient is clinically unstable and has surgical risk factors. A further cardiac evaluation should only be undertaken in consultation with specialists. Chest X-ray should not be ordered routinely unless the patient has unstable lung disease or cardiac patients or infective etiology. Other pulmonary workup should only be done after consultation with a specialist. Same goes with hemoglobin unless the patient is expected to have a lot of blood loss or their hematological disorders, or anticoagulation studies if the patients are on anticoagulants. Same goes with chemistry. Urine analysis really is not indicated at all unless the patient is going to have implants. And pregnancy tests, they suggest you do not order pregnancy tests unless it is going to change the course of management, or in case of if you have any ethical concerns. They do not have enough evidence to give out an unambiguous assessment considering the timing of preoperative tests, but they suggest that if everything is stable, the tests from last 6 months can be utilized. And patients with low risk undergoing low risk surgery can be evaluated on the day of surgery. They also mention an extreme importance of pre-anesthesia clinic for patients who are not category 1. NICE guidelines were proposed by National Institute of Health and Care Excellence in UK, which are basically, again, evidence-based recommendations proposed by healthcare professionals given out in 2016. Their recommendations are quite similar. They say consider communication, pull up different lab values that the patient, if you can get them, and consider the medications that the patient is taking before ordering any labs. The recommendations regarding individual tests are extremely similar to the ASA recommendations. For pregnancy tests, they suggest discuss the possibility of pregnancy, discuss the risks associated with anesthesia, document the test, document the discussion, and test if the patient is unsure, and follow local protocols. They have based their recommendations on surgical grades of minor to increasing complexity major surgeries. And depending on what kind of surgery you're undergoing, like minor surgery, they basically suggest no recommendations regarding routine tests, even for ASA 3 and 4 patients. For intermediate surgery, they suggest some labs can be done, some routine tests, again, considering the clinical status of the patient, can be ordered in ASA 3-4 patients. And for complex surgeries, routine tests can be ordered, but they should also be tailored for the patient's clinical status. So what about Indian scenarios? We find that there are no definitive guidelines in India for preoperative testing, and most of these are center-specific. Different practitioners have adopted different guidelines. There are some practices which have adopted nice guidelines, but as you've seen before, not many people have been able to use nice guidelines and stick to them. The argument for Indian perspective has always been that most of these guidelines are based on Western countries and may not be adaptable to disease patterns and present commodities in the Indian context. Also, in India, there's increased risk of litigation, and hence that is always a concern. Considering that India is a resource poor country and most of these patients are self-paying, it is very important to understand if we are actually doing them any good. So Dakre et al. Tried to study whatever evidence was available in Indian and Southeast Asian countries and their perspective, and found that there were studies which showed that even though anemia, we have such a high prevalence of 74.3%, but actually it has rarely, if ever, made any changes in the surgical plan or any kind of anesthesia management, other than one patient that they had studied of the 385 patients. So incidental detection of anemia held no significance as opposed to a physical examination. Same goes with diabetes. Routine HbA1c and random blood sugars for non-diabetics is not useful. However, some practitioners have suggested that this may be the only checkpoint in a country like India with poor access to healthcare. It could be a checkpoint where it can be diagnosed and treated. Again, even with the high prevalence of tuberculosis, Mishra et al. Studied and found that 65% of the chest X-rays are not indicated, do not change any anesthesia management. Same with EKG, even in Indian setting with the comorbidities that are present, they rarely, if ever, change perioperative management, should be reserved only for symptomatic high-risk patients. So we now know that we have been grossly over-ordering these tests, and they have not really been helping us to change our anesthesia management or improve outcomes, or basically no difference between tested and untested. So how do we attempt to fix this systematic issue that we have where we order unnecessary, unindicated preoperative tests? So the first thing which is really important is to make sure that the patient is preoperatively evaluated, and it should be a multidisciplinary evaluation, even if not in person, maybe even a phone conversation. Considering what the patient is clinically at, the patient may be sent to pre-anesthesia clinic, where objective means of triage can be used, which does not involve laboratory tests alone, like scoring systems and clinical testings like breath holding test or 6 minutes, give you an indication of the patient's capacity, and after which preoperative tests can be ordered accordingly. Local protocols should be altered based on the national guidelines to fit and making sure that it fits your practice and your healthcare system to be able to apply to them to fit your healthcare system. Now, this is a process map which basically indicates how the patient can move after being scheduled for surgery, that the patient should be evaluated clinically by the surgical team and then sent for anesthesia checkup, which could involve pre-anesthesia clinic or just a telephonic conversation to analyze if the patient needs to visit pre-anesthesia clinic, which is a good triaging system to help properly assess the patient before ordering preoperative tests. In fact, NICE gives recommendations for implementation of the guidelines that they have proposed. They suggest that the most important part is awareness and education of anesthesiologists, surgeons, and ancillary staff. It is important to find a lead, a person who would champion the cause. Delineate the stakeholders like surgical physicians, anesthesiologists, nurses, and practitioners to see how it is going to affect them. Assess the baseline degree of problem. To assess that, generally, just like any QI initiative or quality improvement initiative, an Ishikawa diagram can be used. It helps you find individual points in place where these changes can be implemented. And then delineate what data needs to be measured to measure improvement, and apply your changes in smaller scale and run a PDSA cycle. A PDSA cycle is basically plan, do, study, act cycle, which means once you implement those changes in a small scale, study the percentage of compliance and resulting benefit of that changes, make any changes for whatever you have now figured out after studying after making those changes, and make further changes which can continue and should be audited ever so often to make sure that it works for your healthcare system. A role of EHR or EMR, if you have adopted one, is extremely high. Even though there was concern that because of the order sets, it may make it possible for people to order quickly and easily, and hence you may end up over ordering. However, there's enough evidence to indicate that EHRs can impact as tools to educate and perpetuate the habit of conscious ordering of lab tests. Especially the various interventions can be made based off of clinical decision-making tools and algorithms, which can be of use to the physicians for ordering tests. To take home, most perioperative labs are unindicated. Unindicated labs increase waste, chances of litigation, patient anxiety. Every anesthesia society is recommending reduced unindicated tests and provides guidelines to follow. Hospital implementation is prudent, and starting small helps. Thank you so much.
Thank you very much. I'm really happy that you talked about the perspective from the Indian perspective also, that what tests, unnecessary tests are being done or so. There's one point where I have my reservation, and then that is multidisciplinary team assessing a patient. My experience is that if we get into that, more tests are ordered. Each faculty ordering, tests as per their, requirements. So I think a better clinical evaluation by the anesthesiologist remains a better option than involving, unless it is absolutely necessary to involve the specialist, because with the prevailing conditions, the health care system that is operating, the corporate level, and even at the peripheral level, involving multidisciplinary team is a risky proposition. This is what my own experience is.
Dr. Singh, I don't know if I'm audible.
Yeah.
I completely understand what you mean. And when I mentioned multidisciplinary, what I essentially meant was that the patient, the surgical team needs to evaluate the patient when they're posting the patient for surgery and make a decision if this patient needs any preoperative evaluation from anesthesia team. And how that is done here is that when the patient is posted for surgery, they would go over the patient's chart or conditions and see if the patient would possibly need, per what they understand, need preoperative anesthesia evaluation. And just a phone call, it is informed to the anesthesia team, and the anesthesia team goes over through the chart and decides if only a phone call is okay, or if the patient needs to come visit a preoperative clinic. So after which, then you can decide, the anesthesiologist is the one who decides if further evaluation is required by any other subspecialist team or any super specialist team, as we call in India.
Yeah. I think involving the surgical team is also a big risk, because left to them, they wouldn't want any tests to be done, because the patient is taken for surgery. So it's...
I totally agree with what you're saying. What essentially ends up happening is these patients on the day off face a lot of delays or additional tests, which is harmful for them as well as for the surgical prospects. And that's why it seems to work over here. But I completely agree with the concerns that you've raised. Yes.
Thank you very much. Very nicely presented. Ma'am Juneja, can you please, chip in, please? Hello. Any questions, please?
Our next speaker will be Dr. Bhanumurthy Senpara. He will speak on ERAS in Indian perspective. Thank you.
Dr. Desai? Dr. Harinder?
Yes.
Dr. Bhanumurthy hasn't joined, and she has also not sent the talk to us. So we'll have to move to the motivational talk.
It will be motivational talk by BK Shivani.
Okay, is it live? Is it a recorded or a live talk? Recorded, sir. Okay. Could we have the talk on, please?
Om Shanti. All your life, since you became a doctor, you've always been there for others. Last 1.5 years, absolutely without bothering about yourself, and even without prioritizing your family, you have been there for others. I'm sure you have been hearing every single day that how much gratitude and blessings you are getting from everyone around you. At the Brahma Kumaris, which is spread in over 135 countries, we connect daily and we meditate. And when we meditate, of course, for those who are going through healing. But we specifically meditate for all our healers, for your mind and your body to always be energized by God's power and blessings. So that as you continue your seva of healing, it's not only you who is doing it, but God is using you as his instrument to get it done. So that you feel the presence of the divine energy in your life. Because when you experiment and feel the divine energy in your life, then the ability to face very painful scenes day after day. But it's so important to cross that every scene, not allowing the mind to feel low even for a few minutes, because you don't have that space for the few minutes, because your next moment is again for healing someone. And when we hear that one of our own fraternity has left and moved forward on their journey, then those thoughts, what if this happens around me? They tend to come back. And so it's very important today, just for a little time, while we are connected here, let us take up some very few simple things which each one of you can do, which will keep your mind protected, energized, and most important, another very beautiful and powerful quality. and that is detached. Detachment, which is a skill and a power of every healer, but most important to be used right now and to be understood in the right way. Sometimes when we hear the word detachment, we think that if we get detached, then how will we feel like taking care of our patients? That is not detachment, that is indifference, where we become nothing makes a difference to me. I don't care of what's happening around me. We're not going to become indifferent. We need to become detached. The higher the detachment, the more is the level of compassion, and the more is our ability to radiate power to them. So let's understand detachment so that then we will be able to experiment how to create it in our life. Like sometimes two children are born physically connected, physically attached, and their life is not very comfortable. They have to sit together, sleep together, go to school together because they are physically attached. Then what happens? You operate on them and you separate them. This is when life becomes very comfortable. Now one can sit, other can stand, one can go to school, other can be at home because now they are physically detached. So physical detachment makes life comfortable. Now emotional attachment. Emotional attachment means when my mind gets attached to the emotion, to the vibration of the scene around me, or my mind gets attached to the behavior of people around me. It could be my senior, it could be my colleague, it could be my spouse at home, it could be my children. When my mind gets attached to the state of the situation or to the behavior of the people around me, then what happens? If they say a wrong word, my mind is attached to them, I get hurt, I get angry. When things don't go right, I get irritated. And then when I see so much pain around me day after day, after every few hours, and my mind is attached in that scene, I start feeling the pain. I sometimes even cry. And when that happens, once in a while, it doesn't matter because we feel low, we cry, we feel pain. And then after a few minutes or after an hour, we are back together. So it doesn't matter when it happens once in a while. But when it is going to happen on a daily basis, when it will start happening on the daily basis, then that pain, that sorrow, that helplessness will start depleting my emotional health because I'm seeing it every couple of times, every single day. So it will start depleting my emotional health. Even if my emotional health gets depleted for a few days, it doesn't matter. But when it's going to happen for some months and day after day, then that for some of us, then it does not remain as an emotional health issue. It sometimes tips off to a mental health issue, which means someone can start experiencing symptom of depression. Someone can start experiencing a burnout, a panic. We heard that two of our own fraternity members are no more here because they chose to end their life. If we think about it, why would someone choose to end their life? It's not because they were not able to handle that. It's not because suddenly they had this thought that we don't want to live anymore. It doesn't happen like that for anybody, and you know this better than us. That suicide doesn't happen suddenly. Suicide is when someone has been going through depression for quite a few days, maybe more than a month, and in that state of depression, unaware that they're going through depression, so they don't take help, they don't take healing energy, they don't see a therapist, and then we know that depression sometimes gives rise to suicidal thoughts. And those suicidal thoughts also, when we don't talk to somebody, then only someone will take this step. Otherwise, nobody would ever do it. No one can ever do it. So it is so important because your journey and our journey is still not over with COVID. We know that it's here to stay for the next few months. You have already started telling us that there's going to be a third wave and maybe it's going to be very critical. So when we know that the journey is long, then it's important to prepare ourselves for the journey. So when we start taking care of our emotional health, then we will never, ever even shift a little bit towards a little depression symptom or a little anxiety symptom. We will never go there if we take care of our emotional health. And that is where spirituality and meditation gives us the power to build up our emotional health. So what is detachment going to be? Detachment means we never practice detachment in big things. In small things, someone says something which is not right. Somebody does not follow your instruction properly. Someone makes a mistake working around you. These are things which happen every day, even before COVID. And because we thought irritated is normal, getting angry is normal, we would get irritated, we would get angry, we would even shout a little bit at somebody. When we were doing this, what was happening? Our mind and our emotions were becoming dependent on people's behavior. This is called emotions. This is emotional attachment. That means, as is the behavior of the person, so will be my reaction. So if a person works well, behaves fine, I'm very happy, I appreciate them. But if they make a mistake, if they do something which is not right, I react, I get angry, and I feel it is normal to get angry. But now I need to check what is happening. One, I'm becoming emotionally dependent. So what I'm going to feel here is not in my control. It is becoming dependent on people and situations. And each time my mind is dependent on people and situations, and then I react because people and situations are not perfect, this emotional health starts dipping. Just very little, but it starts dipping. So today, let's take our first equation and check to what extent am I emotionally independent or am I emotionally dependent? So this is going to check our emotional fitness level. So let's grade ourselves 1 to 10. Let's grade ourselves 1 to 10. 10 is emotionally fit. 1 is emotionally weak. Doesn't matter where I am in 1 to 10 because I'm going to start working on myself, but I need to know where I stand. So just check your last 1 week and just check how many times you find yourself reacting to situations and you believe that it is the situation that was the cause of what you were feeling. So, मुझे गुस्सा क्यों आया? उनकी वजह से. मुझे बुरा क्यों लगा? उनकी वजह से. मुझे चिंता क्यों हुई? उसकी वजह से. मैं खुश क्यों हूं? उसकी वजह से. So everything that I'm happening here is because of something outside. This is emotional dependence. Grading is low. Grading is low. What would be emotional fitness? They made a mistake. I speak with calm and stability. They did something wrong. I advise them. I instruct them. I discipline them. But I do it with calm and stability. Because my mind is not attached to their behavior. Their behavior is their mistake. I am not going to make a mistake by reacting because every time I react, my emotional health dips. This is like a battery here. It will go dip, 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 dip. And my mind will get into the habit that nothing is in my control. I only react as per situations. Let's take a little experiment today that at least till COVID goes away, we are not going to use anger as a method to get work done. I know it might sound like, oh, there are so many things happening. Obviously, we have to get angry. No, we should not get angry at such times because anger will deplete our energy. This time, we have to conserve all our energy. We have to save all our energy. Anger will deplete our energy. And the one you get angry at, maybe a sister, maybe a staff, maybe sometimes even a family of a patient, because they're just repeatedly troubling you with the same questions, you can get a little irritated. But right now, we need to conserve our health. And also, the sister who's assisting you, who is around you, don't know what they are going through in their mind. Don't know what is happening in their family. don't know through what fear and anxiety they have come to work today. And if we get a little irritated or angry with them, it might tip them off to an emotionally low level. So these are times, like you selflessly care for physical health of people, we would also need to keep emotional health of people a priority. Emotional health, our emotional health, and all the people who are working with us. All the people who are working with us. So every morning before we leave for the hospital, we need to create this thought. Today, I'm going to be calm and stable with everybody. Come what may. It doesn't matter what mistake they make, how they behave, because my mind is not dependent on their behavior. I am the creator of my every feeling, word, and behavior. So let's write down this equation, because this is the mantra of emotional fitness. This is the one tool of emotional health. I am the creator of my every thought, feeling, word, and behavior. I am not dependent on situation, on people's behavior, or the crisis that is happening outside me. I need to remind myself every day this: I am the creator of my every thought, feeling, word, and behavior. First equation. Second, so which thoughts, feelings should I create throughout the day? Only those which are healthy. And what is healthy? So what is normal for the mind? You know, for the last few decades, our definition of normal has not been very correct. We call stress normal, anger normal, worry normal, fear normal, rejection, hurt normal, competition, criticism, complaining normal. None of these emotions are normal. They are not normal, even though we all create it, but they are not normal, because all these emotions make me a disturbed mind here. And you all know better than us that all also have an effect on the body. So let's not call any of these emotions as normal. Let's start actually calling them as an emotional illness. In spirituality, we call these emotional illnesses so that we are aware we are not to create them. But what is emotional health? Stress, emotional illness. Calm and stability, emotional health. Anger, this side. Patience, understanding people, compassion, here. Fear, here. Fearless, confident, here. Complaining, here. Gratitude, normal. Criticism, no. Appreciation, motivation. Long list. Competition, no. Cooperation, cooperation. Comparison, no. Self-respect, self-respect. Long list. And all of us have these qualities, but we use this of more and this very little. And most important, we call this normal. We call the negative ones normal. So from today, we'll prioritize what is normal. None of these negative, uncomfortable emotions are normal. These pure, powerful, positive feelings are normal. So I get to, one, I am the creator of every feeling. And second, I know which one is normal. So all that I have to do now, in every scene, I'm going to use one of this. So people will make a mistake, I will be compassionate. Things will be going wrong, I will remain calm and speak the right words. I will not react and make the situation even more complicated, because I know this is normal. So this is true power of knowledge. And when I start using these normal feelings, emotional fitness starts increasing, because battery keeps charging. If I use these negative ones, battery keeps discharging. Now, why is it very risky? Because if the battery keeps discharging, then my dependency on situations keeps on increasing. I don't have the power to choose my response. But if I'm using these normal ones, battery keeps charging, I am independent of situations. And so important right now to be independent of situations. To be there in the ICU, to be seeing people helpless, to be seeing families sitting outside and you're not able to give them a good news, you will need to be extremely emotionally strong, extremely strong with who you are, with who you are. And that we cannot do in these big scenes of life. We have to start then do them in these little scenes life, not to react, and conserve my energy, conserve my energy. Now, how do this is called detachment. And the more we are detached, the more we are compassionate. Because when I am attached to somebody and I get upset or I feel pain or I react, then what will happen at that time? My vibrations of pain will also reach to them. My vibrations of pain will reach to the patient. My vibrations of pain will reach to the staff. My vibrations of pain will reach to the family. Even though I'm perfect outside, I'm very powerful on my face, in my behavior. But inside, if there is pain, I'm carrying those vibrations. And that vibration will reach to everyone around me. They are already in pain. So compassion doesn't mean only care and treatment. Compassion means where the vibration that is radiating from me to people is a high vibration of purity and power, not sympathy and pain. Sympathy is a low vibration. Empathy is a high vibration. So we are not going to feel pain. We are going to feel power because we need to give power to everybody. So the more we will practice this right, normal feeling, we will be able to radiate that. We will be able to radiate that. We need to protect ourselves so that we don't catch the emotional virus of another person. Someone is agitated, someone is disturbed, but I am healthy. I am healthy. But if I don't take care, I catch that emotional infection and I also start behaving their way. I also start talking like them. Sometimes I start shouting even more than them. So, which means their infection is no more their infection. I have also caught that infection. So, remaining stable doesn't mean remaining quiet. It means you be strict, you discipline, you instruct, but you do it with stability and dignity. You don't absorb their emotional infection. Now, simple lifestyle habits that we can start doing from today. Very simple, which we need to do every day. Most important is when you are about to go to sleep. Very, very important lifestyle habit is to sleep right. To sleep right. Because of your role, you may not have fixed sleeping times. But if you are back home on time, please try and sleep early. Please keep 10 o'clock, 9:30, 10 as your time to go off to sleep. Very good, deep energizing and charging happens between 10 to 2. At this time, make it a point to sleep unless you have to be in the hospital. So if at home, aim to sleep by 10 o'clock. Now, little things we need to do just before 10 o'clock before we go to sleep. Of course, you have to remain connected to your hospital always, but don't get connected to anything else before going to sleep, which means don't check what's happening in the world. Don't check world news before going to sleep, because the last layer of information that we will take in on this blotting paper of the mind, it's going to go deep into the subconscious during our 6 hours of sleep. During the day, our thoughts are on the top layer. But if we go to sleep with that thought, then our thoughts are going to go deep, deep inside into the subconscious. And when negative thoughts go on a daily basis deep into the subconscious, it's only then that emotional health starts dipping and it shifts to something more sometimes. So cleaning our mind before sleeping is extremely important. Like some of us have a shower before we go to sleep. We change our bed sheets. We make everything so neat and clean before sleeping. We need to clean our mind before sleeping. Everyone needs to do it, but you need to do it even more than everybody, because during the day, you have already seen a lot. And all those things that you saw during the day, they got recorded here. They got recorded here. So 1 hour before we go to sleep, we disconnect from world news. No other media, no other platforms. 1 hour before we go to sleep. At least 15 minutes, only 15 minutes. Just 15 minutes before going to sleep, please put something very pure and positive into your mind. Healthy emotions, emotional health perfect, needs a healthy emotional diet. So like you prescribe a very good diet for us when we come to you with our illnesses, we need a healthy emotional diet. And healthy emotional diet means what we watch, what we read, what we listen. At 15 minutes before going to sleep, only 15 minutes, consume very pure, divine, powerful, positive content. 15 minutes, this will go on the mind like that. because this is now going to get processed during the next 6-7 hours of sleep. So it is spiritual study or a self-transformation book or a positive video, whatever you like. Second, 5 minutes, connect to God before going to sleep and share everything that happened during the day. Very important to surrender. Very important to surrender. Some of us have started feeling, we start feeling sometimes, I could have done something better. If I would have done this, that person could have got saved. If I could have done that, that could have saved. Even if you're not treating COVID, but you must be getting so many phone calls. Please arrange a bed for my relative. Please get me oxygen from somewhere. My family is dying, help me. Feel so helpless. That guilt starts coming on our mind because 2 days later, they might call you and tell you, that person is no more for whom I was asking you for help. And when we hear that, the mind just goes, what if I had tried a little more? What if I had done this? What if I had called this? So this needs to be cleaned, because otherwise we can live with this guilt and this trauma for a very long time. So what to practice for that? Every time you are able to help someone, you're able to get them the bed, you're able to get them the oxygen, you're able to treat them, they appreciate you. Every time you are being used for doing something wonderful, don't create a thought that I was able to do it. Just say, God got it done through me. I was just an instrument. So surrender your success. Surrender your success there. Surrender the appreciation and the blessings that you receive. Inside, have to only create a thought. I was only an instrument. It was their destiny to get this bed. It was their destiny to be able to get treated. It was their destiny to get healed. I was only an instrument. And God, when someone doesn't get healed, when someone doesn't get a bed, when someone doesn't get assistance, when someone leaves and moves forward on the journey, same thing we have to say even that time. I tried more than my best. This is very important to record on the mind. I tried more than my best. I am only his instrument. The rest is between him and their destiny. Their destiny. I cannot write the destiny of people. I cannot control the destiny of people. Neither the covering, they are also destiny, but I am an instrument for that. And here, in those very few 1 or 2 cases where it doesn't happen, also I need to remember, I tried my best. Please, let's not record guilt on the mind. Please, please don't record guilt on the mind. This is a long journey, long journey. So I have to say it in the night before going to sleep. I have to surrender all this. All that happened well, surrender. So gratitude there. And those one odd, which did not happen, right? We have to surrender. We have to. And we need to do it before going to sleep. Please don't keep this for the next morning. We cannot sleep with emotional wounds. If we sleep with emotional wounds, they become very deep during the next 6 hours of sleep because they go into the subconscious. So this has to happen before sleeping. If you want, you can write it out. Sometimes writing it out releases all these things. That's the reason why people write diaries. That's the reason why people write letters to God. Write it out, bring it out. And most important, throughout the day now, when you are healing, even that time, remember, when actually it's happening in front of you. Don't consume the pain of people. Give power to people. You know, sometimes we need just one person in a hospital ICU or when someone is leaving. This is very important. We've all heard Antamati so gati. Antamati means the last moment of the soul before they are leaving the body is very, very important. Very important. But at that time, there is a lot happening because all of you are trying so hard to revive that person. Just keep one person's responsibility. It could be a junior nurse, too much that time. Just assign her the role. Okay, while we are trying to do all that we are doing to save the person, your role is to just stand from a distance. If you can stand close by, just hold a gentle hand or stand from a distance and radiate God blessings and prayers to them. Say the thank you to them for the beautiful part they have played in this world. Tell them with a very powerful message, everyone loves you, everyone was around you. Now you're going to start a very beautiful journey. It's very, very important for a soul they leave. Before they leave, let the souls not leave in only all that was happening to try and save them, but also get 2-3 thoughts from somebody, gentle hand holding and saying, thank you for the beautiful part you played here. Everyone loves you and everyone is always with you. And you are now moving forward for a very beautiful destiny, for a very healthy body. And that will be your best gift that you give somebody while they are leaving. This actually decides the destiny of the soul in the next lifetime. That's why it's called Antamati Sogati. मतलब अंत की जो मति होगी, मति means state of mind, वो आगे की गति हो जाएगी. So that's also something we can do at that time, radiate that power. So in the night, before going to sleep, 15 minutes pure diet, surrender to the divine, release everything that happened. Now, one thing we need to do before going to sleep, we are going to create some very pure, powerful thoughts before going to sleep. Sankalp se siddhi hoti hai. Thoughts manifest. So we are going to create those thoughts which we are going to become. I request you to write these thoughts, please, so that you have them with you as a little emotional health prescription which you can use every single day. First thought, I am a powerful being. मैं शक्तिशाली आत्मा हूँ. I am a powerful being, which means I will remain very stable and not react to situations. Second, I am calm and stable always. I am, even if I'm never, I write that line. I am calm and stable always. Third, I am fearless. I am fearless. We know that you're fearless, but you know what? There's a lot of fear around you. You are surrounded by vibrations of fear. So we should never allow those vibrations to enter into our energy field. So I am fearless. That's our third affirmation. Fourth, I am detached and compassionate. We have to put this into our programming now. I am detached and compassionate, which means I don't consume, but I give completely. Fifth, I am angel of God. I'm instrument of God. God uses me for all his seva. God uses me for all his seva throughout the day. So that is fifth. Sixth one, my body is perfect and healthy and will always be. So no creating thoughts. What if I get this? My body is perfect and healthy and will always be. Seventh, and this is a visualization. God's power and blessings is a circle of protection around me. Like you wear a PPE kit, just wear this in your mind, a divine white light circle of protection around me. PPE kit doesn't allow virus to come in. This divine circle of protection doesn't allow vibrations to come in, will not allow anyone else's energy to come in. So God's is the divine circle of protection around me. Then draw this same circle of protection around your family. They are safe. They are secure. I have to say this every day before going to sleep. They are safe. They are secure. And then one affirmation for your hospital, for all your patients, that God's power and blessings is a circle of protection around my hospital. Everything is smooth. Everything is perfect. And everyone is healed. And one affirmation for the country and the world. God's power and blessings is a circle of protection around the planet. Now 10 thoughts. I'm a powerful being. I am calm and stable. I am fearless. I am fearless. I am detached and compassionate. I am God's angel, God's instrument. My body is perfect and healthy. And God's power and blessings is a circle of protection around me. Circle of protection around my family. Everyone is safe and secure. God's circle of protection around my hospital. Everything is smooth, perfect, and everyone is healed. And God's power and circle of protection around the planet. The world is safe. 10 thoughts. These are 10 thoughts. This is like our personal prayer for this present time. These are our 10 thoughts, which we call affirmations, thoughts which we will create just before going to sleep. Because the last thought before we go to sleep goes deep inside. Next 6 hours, this vibration will get created. So close your eyes, lie down, say these thoughts. So the end moment of the night is very, very important. So 15 minutes of pure content, surrender to the divine, everything that happened during the day, and just say these 10 thoughts before going to sleep. First thing in the morning when we wake up, you need to check the phone. For other people, we tell them don't check the phone when they wake up in the morning, but you have to check the phone. Once you've seen the phone, you've seen everything is fine. These 10 thoughts, please repeat them again in the morning. These 2 times are very crucial, just before going to sleep and just after waking up. In the morning, repeat them at least 3-4 times, which means give 5 minutes to yourself. Just 5 minutes to yourself. Repeat them at least 3-4 times and visualize them powerful, healthy, calm and stable, everything you're visualizing. And then at least 15 minutes. This is very, very important right now. At least 15 minutes of healthy emotional diet again in the morning, which means watch, read or listen to something very pure. 2 times of the day and everything, morning and night. And last thing, our diet. I'm sure everyone is on a vegetarian diet. These are times to be on a vegetarian diet only. Diet is not just health for the body. Diet is also nutrition for the mind. We are what we eat. It means jaisa ann, vaisa man. Jaisa pani, vaisi vani. We all know animal in a slaughterhouse. What are the emotions over there? And nowadays, so you're telling everybody, it's so nice that you have started telling people that a non-vegetarian diet is also not the body. A lot of people are eating non-veg only because they say, Doctor Saab ne bola hai, ye health ke liye acha hota hai. They have only one reason to eat. Doctor Saab ne bola hai, isme protein hota hai. So we request all the Doctor Saab to please start changing this information in society and to please tell people this is not healthy for them. Emotionally, animal in a slaughterhouse, anger, hurt, pain, helplessness, fear, violence, and death. That's the energy of that food. How can that give health to anybody? It can just give proteins, but not health. Right now is the time where all the patients and all of us and all of you should be eating a very light diet. We need to keep our system very clean. You teach us that for a good immunity, our gut should be very fine. It should be perfect. It should be clean, which means no toxins should get accumulated. That means the food has to be very light, easy to digest food. So we are all practicing this right now, that we are eating very easy to digest food. No fried, no heavy things, nothing which is difficult for the body to digest. So that the body is also at a high vibration. Mind is also at a high vibration. We will remain safe from the virus. If the virus comes, the mind and the body is equipped to handle it because it is at a high vibrational energy. So let's have a healthy, a light diet, easy to digest, lots of raw, lots of soups, juices, lots. And when we eat cooked food, light, easy to digest food, and obviously a vegetarian diet. Now, where food is being cooked for you is very important. So whether it is in the kitchen at home or whether it is in the kitchen in the hospital, let's have high energy words playing in the kitchen, at home, and in the hospital. Right now, fear and anxiety is in the air, everywhere around us. Fear and anxiety is also in our water. Water absorbs vibrations. Food absorbs vibrations. Just check once online, effect of emotions on water, and you will see experiments with crystals. We have experimented the same in the Brahma Kumari's headquarters in Mount Abu. Same, we have experimented that water crystals, they change with the emotion that is radiated. In the kitchen, high energy words. So spiritual songs, bhajan, mantra, jap, prarthana, whatever you like, in the hospital and at home. But please play that in the kitchen. Let it play 24 hours. Let it go on. How food is cooked in the temple and the gurdwara, that's called prasad. So right now we need to eat prasad. We need to eat prasad throughout the day, and we need to drink amrit, because both these things are going to keep the mind very strong. So high energy words playing in the kitchen throughout the day. Whoever is cooking for you needs to cook in a very peaceful state of mind. No talking on phones while cooking. No having the news or anything in the house while food is being cooked. It is for everyone's mind. It is even for your children. Those words all go into the food, and it's not good for everybody. Second, just before you start eating, no phone and TV while eating. Just 5 minutes, keep your phone away. If there is a crisis, somebody will call, but don't look at messages or anything while eating your food. Keep this 7-8 minutes just to energize your mind and body. And just before you begin eating, 3-second pause, gratitude, and say your affirmation into the food. Say it into the food, put that vibration into the food. I'm powerful, I'm perfect, I'm healthy, I'm compassionate, I'm detached, I'm God's instrument. Put it all into the food, and put it all into your glass of water. And especially, most of you even have your meals and water in the hospital. So that's even more painful than what we are doing in the city. So that 3-second pause is a compulsory thing for you. If you just experiment it, within 15 days, you will see results. It doesn't take long for this. 15 days may you will see results. That pause and energize your every meal, your every glass of water. So it's 3 seconds. How many times in a day? About 7, 8, 10 times. That's all. 3 meals, 6, 7 glasses of water. That's all. 3 seconds. How much does that become? 8 times 3 seconds, 25 seconds. Nothing. Nothing. But that 25 seconds is saving you from consuming the fear and anxiety around you. So 5 minutes in the morning, 2 minutes we're saying the affirmations before going to sleep, and 3 seconds we're saying before every meal and glass of water. That much. How much is it total? Not even 15 minutes. But the result of this, you have to experiment. Don't believe anything without experimenting. Scientist means we have to experiment everything. Experiment, and you will see beautiful results. And you will see such amazing results that you will start sharing this with your patients. This is the way to take care of the mind. So just those 10 affirmations, we'll just repeat it right now, but we'll do it as a meditation. So just sit back comfortable, sit straight, keep your body relaxed, and we'll repeat the same ones so that it's going in right now here. Don't write or anything right now. It's all recorded, but right now we'll record it over here. Take 3 deep breaths. Inhale and exhale and relax the body. And just come to the center of the forehead and visualize a tiny point of light here, like a little star. This is the energy which runs this body, which creates every thought and feeling. And gently, in your mind, start saying what I say and start visualizing it also. So I'll say it, you repeat it in your mind. And also visualize it. I am a powerful being. I am calm and stable always. And keep seeing that point of light there. I am fearless. I am detached and compassionate. I am God's angel, His instrument. Everything that happens during the day, I surrender. My body is perfect and healthy. and will always be. Visualize the divine light circle around you. God's power and blessings is my Suraksha Kavach. It's my protection shield. Now draw that same circle around your family. God's blessings, a circle of protection around my family. We are safe and secure always. Now draw the same circle of protection around your hospital. Around the whole building, draw divine light circle. God's power and blessings is a circle of protection around the hospital. Everything is smooth, perfect, and everyone is healed. And then we draw that divine light around the planet. God's blessings, circle of protection around the world. Everyone is safe and everything is perfect. Om Shanti.
Well, I think this brings to the end this session of controversies in anesthesia. I wish the session could have been more interactive and more controversial than it was. So anyway, thank you everyone. Thank you the speakers, thank you the panel members for being there. Who's there online? Please, from the chairpersons, please